A very good evening to all of you. I'm very happy to see that you are all on the other side. NEET PG has been a game not only for you but also for us as teachers, and I'm so happy that you all have crossed with flying colors. So, a very warm welcome from the side of PW Medet family. We have always been with you right throughout your teaching, and now we expect you to be there post PG when you enter in your college. Today, in this particular segment, we are going to have a quick recall about whatever was asked to you today. So, this will help you in regaining all those questions or whatever you can recollect from what you have given, and this will help you to get the right answers. So, I welcome our esteemed faculty members from the PW Merit family. We have Dr. Santosh sir, who's from medicine. We have got Dr. Anusha from microbiology. We have got Dr. Rishabh sir, who's from radiology. So in this particular segment, I'm going to talk a little bit about the analysis of the paper with our respected family members. And also, I'm going to put up certain amount of things which we can compare about the last NEET PG and the FMG papers which have already been done. So as you know that the more you sweat in practice, the less you bleed in battle. And today was the battle. And I know that if you have done a good amount of work all throughout the year, this was not something which was, I can say, not very difficult. Neither it was very easy, but it was something which you can float through. So NEET PG this time was approximately of a moderate difficulty paper, and that is what the analysis was. It wasn't something which was very, very easy, but it was something which was quite manageable with a lot of clinical based questions. So we will discuss about the analysis of the paper one by one with our respected faculty members. And let's see the inputs about how this particular paper was and what could have been a better thing that the students would have done or whatever thing that they can take for the next year to come. So my first question would be to Rishabh sir. Welcome, sir. Many of our students have already contacted you and you have already done the initial paper analysis. You have gone through at least what are the type of questions. My first question to you will be that if we compare the last year NEET PG paper compared to this year NEET PG, what do you feel the difficulty level has increased, or do you feel that the difficulty level has been the same or they have gone into some other trend of asking?
So I think the difficulty level was lesser as compared to last year's NEET PG, especially the shift 2. The second shift indeed was a little tough last year, but this year it was more of a balanced paper. What the students have said that it was a moderate difficulty, and whenever students say it is moderate difficulty, that means that the questions have come from the topics that they have studied, right? And that makes the paper sort of easy to moderate range, and like the as compared to last year, I would say that the topics were not different, but the asking style was very different. Now, I've gone through the radiology recall myself, and there was one topic which was very new. It was not a PYT, it was not a PYQ. So I'd also like to request all the other students and all the other faculties to please point out which questions were new and which questions were PYTs, because it's a habit for us of all the faculties to say that this was PYT, this was PYT, but we have to point out which was a new question. So there was one new question in radiology that I'll be discussing in the radiology recall. Apart from that, I think most of the questions were from previous year topics, as we will see. As compared to the last year, this year the question was trickier, but again, PYT heavy.
Correct. So thank you for that input, Rishabh sir. तो इतना हमें समझ में आता है पेपर exactly easy नहीं था. There were a lot of clinical based questions and clinical की वजह से there was something that tricked you towards that the answers could have been different. But what I felt was कि इस बार options eliminate करना थोड़ा आसान था because options more or less were quite straightforward. If the questions were difficult, options में हम लोग निकाल सकते हैं that what if you even if you don't know the correct answer, still you can eliminate out कि आपका option क्या correct है क्या नहीं है. Okay, fine. I'll move on to the next question, and that is related to Rishabh sir की बात जो उन्होंने अभी करी. That is about the PYQs and PYTs, which at PW we really focus upon. और हमने एक पूरी series करी about the PYQ and the PYTs, and that was something which was quite helpful in getting a lot of questions even this year. So my question to Santosh sir would be, we always emphasize कि PYQ पढ़ने चाहिए, PYT पढ़ने चाहिए. This time हमने ये देखा कि PYTs were more important than PYQs, क्योंकि more or less the topics were asked more in detail, not exactly, but related questions had come. So, how much role did the previous year topics and PYQs play as per the percentage? And how much do you think it is important for the students to read before the exams come?
Okay, I think I interacted with other faculty members as well. So I think most of us are aligned to believe that majority questions came from previous year topics. There were new topics, but a sizable chunk was from previous year topics. And someone who has done the previous year topics well with the conceptual understanding could have managed to get a very good score, even if the new questions are total bounces to them. Second thing, I have seen a change in the language of questions. Even if it is a PYT, there's a slight change in the language of question, especially when it comes to medicine. So the language, the change is that the kind of questions that we generally discuss in the bedside discussion and not in the theory class are integrated into the clinical STEM. For example, where you miss the where the presystolic accentuation of mitral stenosis murmur disappears is a usual discussion of a MS case in bedside, not usually discussed during theory. So those kind of points are made into the question. So I think before the session we were talking about it, and it makes so much sense that if you've done your internship sincerely, that would have added at least 10 marks more to your score, because a lot of things were what we do in the practice or what we do during the bedside discussion, they were integrated into the previous set topics to make a clinical step.
Correct. And that is very right. That is very correctly pointed out by Santosh sir also. कि clinical questions बहुत ज़्यादा थे. So if we do our internship properly, so in that 1 year, at least इसमें से 20-25 questions were straight away coming from internship related clinical scenarios. जैसे in ENT as well, ENT maybe there was a child who was unconscious, got into the emergency, peanut hai, and what will you do? What will be the next step? They gave a needle cricothyrotomy question. Straight away they had shown an image of a surgery and they have asked you which is the procedure done, what is the next step of management. So इस तरीके के questions बहुत सारे थे. So if you have aligned yourself towards your clinical postings, towards your internship well, then many of the questions would have been very straightforward for you all to answer. Right. So that is very correct, Santosh sir. Thank you for your inputs. I would straight away move on to the next question to ma'am. So Anusha ma'am, image-based questions are the talk of the hour every year. हर साल हम लोग ये expect करते हैं कि image-based questions बढ़ेंगे. Was image-based questions increased this year, or were the same amount of questions asked? And how were they aligned this time as far as NEET PG was concerned?
So, first of all, hi to all the students who have joined us and are anxiously waiting for the recall to start. And congratulations to all of them for appearing for this much awaited exam. वो ही अपने आप में that's a feat. बाकी तो ठीक है, result will be obviously good. Sir, image based questions were plenty. मतलब ऐसा नहीं था कि though it was a very clinically heavy question paper this time, and I also feel it was quite exhausting for the students क्योंकि लंबे लंबे questions, big case scenarios, especially for microbiology, all questions were only clinical based. So जो images थे, they were helping in the sense कि अच्छा, even if you don't understand the question, image देख के directly you could have attempted. But I think almost 20 to 30, close to 20-30 image based questions were there, and especially what feedback I've gotten, anatomy was very image heavy this time.
Yes.
And that
right.
too, like a picture of a skull and what artery will pass through this foramen. Something like, I mean, I'm not an expert of anatomy, but anatomy particularly was image heavy, micro not so much, and it was very clinical heavy this time. I felt that agar, like Santosh sir said, agar ek conceptual understanding नहीं बनाई थी तो थोड़ा difficult हुआ होगा to attempt the questions, because looking for those buzzwords in those big paragraphs, that was the catch this time, I feel.
राइट मैम. सो हर साल यही होता है. दैट्स व्हाट वी ऑलवेज से. जब हम लोग पढ़ाते भी हैं तो वी ऑलवेज टेल द स्टूडेंट्स कि जो भी पढ़ रहे हो उसको देखते चलो. You have to keep something, you have to watch something about the disease, whatever you are reading, because most of the times, whenever you are given these questions, जो आप देखते हो, you tend to remember, you tend to recall better. So image-based questions are always higher in these kind of papers when you see INI-CET as well as NEET PG or FMG. But this year also, we had plenty amount of based questions were on images. And they are mostly around clinical scenarios, जहाँ पे आपको X-ray images दी गई, they were scans, they were histopathological images, and they tried to correlate those questions with kind of clinical scenarios to get to the right point. Fine. So we'll move on to further discussing about कि NEET PG कैसा था, NEET PG क्या था, because the buzz of today is NEET PG. तो हम लोग इसके बारे में थोड़ी और बात करते हैं before we go to the actual recall, which is subject by subject. So now my question goes to Rishabh sir.
Yes, sir.
That आपको सर बहुत सारा फीडबैक मिला होगा from a lot of students, and this is something which our students really want to hear. क्योंकि लास्ट ईयर आई थिंक यू डिड अ वेरी थरो एनालिसिस अबाउट कि नीट पीजी की कट ऑफ कैसे आएगी एंड हाउ विल बी द रैंक and accordingly, will they be able to cross it over or not? So, is bar, in order to get the top colleges, what should be the expected cutoff, seeing the difficulty of the paper?
Sir, so last year it was sort of, अगर हम बात करें कि 140 correct पे people were getting, 140 was like the golden number, 140 correct people were getting 10,000, 12,000. I think that is gonna increase a little bit this year because in any PYT heavy paper, even if let's say some questions are tricky, some questions are clinical, but since now like 3 lakh, 2.5 lakh students are giving, so I think the cutoff this year for a top 10,000 rank would be between 145 to 150 corrects. And versus, and then the, you know, that accumulation of ranks will happen between 135 to 145. So 135 will have ranks ranging from 35,000 all the way till 15,000 at 145, right? So that is my analysis. Let's see how the results come in, and then obviously we'll post the analysis after the results.
And so, what do you suggest that if the students, a minimum amount of questions that students should have answered today should be what approximately?
So attempt, as I said in the exam day strategy video also, should be above 185. And if
Okay.
we are talking about blocks, since we discussed with Santosh sir also, that per block, I think we have a margin of only 2 to 3 questions, leaving 2 to 3 questions. So 37 for 37 to 38 questions per block they have to attempt.
Okay, so I think that means a higher attempt strategy would have been better for the students today.
Yeah.
And especially those questions which they felt, because there were some amount of questions which were unheard of, which were new entries into each and every subject, what we also saw. So what we have estimated is those new entries are something which will bother everyone around, but the questions which were regular, so you don't have a lot of scope of getting those wrong because that will get down the rank. So if you have gotten most of them right, then you will fall between that target of 140 to 150. That is a good score. That's a very good score to get in this particular NEET PG exam because it was moderately difficult. Fine. We'll move on to Santosh sir. Sir, we have already done a lot of PW Med marathons right from the past month. We had a huge PYQ series, which we got a lot of love from the students as well. Now, I would specifically want to ask you about the predictability index because we have done marathons, we have done the PYQs. From that series, the predictability index, what was the amount of predictions that came out to be true from those particular classes that we took in the last moment, and how much percentage did the student get from that area?
Okay, so I think both the marathon as well as the PYT series that we did would have added a lot of value to students' preparation, because from the marathon itself, I would see that even for larger subjects like medicine or surgery, more than 60-70% questions could be addressed. And when the PYT session is also added, 80% plus questions could be comfortably addressed. Only thing is that you need to have a little basic backdrop of conceptual understanding, and then you can take it to much higher. And in fact, in medicine and maybe some other subjects also, we did clinical masterclass where we tried to teach them how to catch the buzzwords and recognize the clinical stem, because that was the lacunae. So if that is also taken into account, they should have gotten the targets that Rishabh had set for them.
Correct. And I think that was the strategy. ये हमने आपको बताया भी था. This was something we requested all the students कि even if you have not done one subject that you are really not confident about, अगर आपने पूरे साल वो subject नहीं किया है, we requested you to at least see कि वो एक marathon जिसमें सारे faculties ने they had concise that subject in a 5 to 6 year of span and 5 to 6 hours of span of time, and in that 5 hours there was the crux of the whole subject given. तो उसमें that workbook that was given in the last moment, I think that workbook had a lot of things which straight away got repeated इस साल के पेपर में. And straight away जब वो पेपर आया, so we have seen the same amount of scans, the same amount of pictures, the same things like those clinical scenarios जो भी frame up हुए हैं. So it would have helped you a lot in your papers if you have done that. Now, I think already somebody is asking about to compile the system-wide PYTs. We have already done that. We have already shared about the important topic list with the students. हमने सारे के सारे बना के we have done the marathons, we have done the PYQ series, and सब में we have focused upon the important things which have come in today's exam as well. Right. Now, one more question to Anusha ma'am. Ma'am, हर साल एक प्रॉब्लम आती है कि वी नेवर गेट टू नो कि वन लाइनर ज्यादा इंपॉर्टेंट होते हैं नीट पीजी में कि क्लिनिकल बेस ज्यादा इंपॉर्टेंट होते हैं, बिकॉज मोस्ट ऑफ द टाइम स्टूडेंट हमें ये कहते हैं कि हम वन लाइनर्स पे ध्यान दें और हम क्लिनिकल क्वेश्चंस पे ध्यान दें. बिकॉज दोनों की स्ट्रैटेजी डिफरेंट है, दोनों को पढ़ने का तरीका डिफरेंट है. सो इस साल के लिए व्हाट थिंग कैन वी टेक फॉरवर्ड फॉर द नेक्स्ट ईयर नीट पीजी, ताकि स्टूडेंट्स को एटलीस्ट they can understand that what is the trend which has changed since the past years to the current NEET PG.
Right, sir. So ये थोड़ा सा it's already been discussed that the paper was PYT heavy rather than PYQ heavy. And also the straight, what feedback I've gotten, the straight questions were majorly from, I think, PSM this time, which were straightforward questions. Especially for microbiology, there were absolutely no one-liners. They were all clinical-based questions. So what our takeaway can be is they're really focusing on clinical scenarios and a deeper understanding of the subject. They have not budged a lot from the PYTs, especially for micro, not so much new topics. Just the way of presentation changed, very much clinical, and buzzwords were hiding in those clinical scenarios only. So instead of giving a straight away direct question with the formations and images and special features, they were hiding somewhere in a clinical scenario type of a thing. So definitely PYTs were there, presented in a case based quoting. So a deeper understanding was definitely required. And the takeaway will be that when you attempt these PYTs, please focus on building a understanding of the subject. And you will definitely need to give a lot more time to subjects than just maybe 2-3 months and just brushing through the important one-liners. I feel it was not one-liner heavy, it was clinical heavy this time.
Great. So, ma'am, I think that would suffice for the question that I asked. Clinical based questions ज़्यादा थे इस बार, one liners कम थे. You should always build a concept between whatever you are reading. Have some kind of a back thing, whatever you are proceeding for, so that you can get the questions right. So this would be the conclusion of this particular segment of the analysis of paper. I'm really thankful to all the faculties who have joined. Coming segment will be about paper wise, the recall of all the subject. We are going to come up with each and every faculty who's going to take up the recall for each and every subject in detail. So stay tuned, guys, and see for all the questions. Do help our faculties if you think that there are some options which can be changed, and actively participate in this recall, because this is made for you from the faculties. We are all working towards your dream, towards you getting your dream seat in your dream college. So thank you again for all the faculties who have joined today for the paper analysis. I would now proceed on to give the dais to Ranjit sir to start on with the pathology recall.
Okay, thank you, Dr. Sanchit, and thank you, an esteemed panel of people who are discussing about the paper. So now let's move on to the discussion of pathology questions. So I'll be quickly going through things. I want you guys to see the right answer alone. If there's a major blunder, let me know. Age change, that's not a concern. If there's a major blunder which will change answer, definitely talk about that, right? So let's go to the first question. Caspase are crucial enzymes involved in which of the following programmed cell death or types of cell death, right? The answer is very, very simple. Caspases are involved in both apoptosis as well as pyroptosis, right? Both of them is involved. It's not involved in necroptosis. It's not involved in other three options, right? So option A is the right answer. Was there any change in this question? If there's no change, just say yes, and we'll move on to the next question. Fine. Devotee, the PYT list will be there in our Instagram channels and other things. You can definitely go and have a look at that. Fine. Okay, just give me a second. Fine. Perfect. Now let's go to the next one. This question was there. A 20-year-old woman present with mild jaundice and anemia. Her father had a history of similar blood disorder, right? This is important for a familial history. Lab shows an elevated MCHC. There's only one disease which has elevated MCHC. What is that? The answer is perfect one. That's your hereditary spherocytosis. It's hereditary. I won't think of an autoimmune hemolytic anemia for the only reason there's a family history of the disease, right? A inherited disease. So obviously the answer has to be an hereditary spherocytosis. Option C is the right answer. Perfect. Any doubts, any clarifications, please put in the comment section and we'll definitely have a look at that soon. Fine. Okay. Let's move on to the next one. Classical question, right? So there was a history of DIC, right? Persistent nosebleeds, bleeding disorder, easy bruising. So suggestive of not exactly history, but suggestive of a bleeding problem, suggestive of DIC. Very acute problem for the past 5 days. Reports of fatigue and mild fever. I think this image was there. What is the cell? Everyone, we have seen a similar cell, Faggot cell, or a cluster of ore rods or bundles of ore rods seen, which is nothing but an acute myeloid leukemia. With the history and the ore rods, the most probable diagnosis can be APML, and acute promyelocytic leukemia. Options. What do you think? What do you guys think is the right answer? A, B, C, or D? Come on, let's interact. Like Sanjit said, let's interact so that we'll take care of it. Shaktiman, ferroptosis is not a problem. Ferroptosis you'll not have caspase. You'll have only free radicals, so that also is not a concern. Apoptosis and pyroptosis where you'll have caspases. Fine. Answer is translocation 1517, the PML RARA translocation that is classical for APML. This is seen in AML, this is seen in CML, and this in mantle cell lymphoma. But APML you'll have translocation 1517. Fine. Okay, let's go next question. This question, I think there's an undifferentiated thyroid carcinoma as option D, not anaplastic. See, this is a very simple question. Quite a few of the students got confused when the question stem becomes bigger. Only one of the thyroid neoplasm will have amyloid. If amyloid is noted, there's nothing else than medullary carcinoma thyroid. Medullary carcinoma thyroid also will be positive for TTF1 because we always rate TTF1 as lung adenocarcinoma, right? TTF stands for thyroid transcription factor, right? So it's also positive in thyroid tumors. Don't worry about that. But we have a bigger clue sitting here, right? Thyroid tumor, amyloid present has to be in medullary carcinoma thyroid. Nothing else, no other confusion, right? It's only amyloid. Great, Garima, great said. It's amyloid present. It has to be in medullary carcinoma thyroid, right? Let's go to the next guy. So some of the students said there's a gross image as well. Some said only microscopic image was there, right? 32-year-old, painless testicular mass. Grossly, if there's a very smooth image, fleshy appearance, no cystic surface, and microscopy, you'll see you'll have all these nested cells and you'll have the lymphocytes in between. What's the diagnosis? There's a classical picture of seminoma, right? We have been reading almost, see, these are all not even PYTs. Same images, same question were asked in previous question, right? It's kind of same PYQ. Maybe the presentation and the others are changed with respect to pathology, right? It's a very, very simple paper, at least with respect to pathology. I hope you must have not made any mistake, right? Great, Gupta. It's seminoma, right? How many of you wrote this right? Because there it was two-step thing, right? A pedigree was given and diseases were given. What's a pedigree inheritance here? Is it dominant recessive, mitochondrial X-linked, dominant X-linked recessive? What is it? Mom affected, all kids affected, mom affected, all kids affected, dad affected, no kid affected, and it is mitochondrial, right? Perfect. So mitochondrial inheritance, these three are not mitochondrial inheritance, right? Kearns-Sayre syndrome is a mitochondrial inherited disease. Option D is the right answer, right? Right? See, this was not a difficult question. It's a simple one, but there are two steps. That's all. You have to identify what is a pedigree. Then you have to go to the question saying what's the most likely answer for it, right? Perfect. Next one. I have created a scenario around it. Most of the students said there is a case of CLL. And the question was, which is the best test to do CD markers, right? So I created a scenario on CLL, diagnosed CLL. I have to prove the CD markers. The best test to do CD markers is undoubtedly your flow cytometry, right? That's the best test to do CD markers, and that's the investigation of choice also. You cannot do CD markers in karyotyping, neither in your blood level. It has to be on a flow cytometry. That is the investigation of choice, right? Any change in this question? Perfect, Gupta. The answer is flow cytometry, right? Nice. Let's go to the next one. This was a PYQ which came in the recent exam, right? If you got the PDF of that from the PW Meta channel, I'm sure you must have answered it right. Classical visual disturbances, your ectopia lentis, and a tall person diagnosed of Marfan syndrome. The thing is FBN1 gene or fibrillin1 gene is the right answer, right? I'm sure you must have made it right. Okay, let's go to the next question. This, I wouldn't say it's new, but it's an applied thing, that's all. You must have read this, seen these images in your microbiology as well, right? You have all these worms in the peripheral smear, Wuchereria, Bancroft, and others. Filaria, that's all. Peripheral smear diagnosis of filaria, and the question had a man with a leg swelling. Man or woman doesn't matter for us. A person with a leg swelling. The reason is, what is the reason for leg swelling? If you actually identified filariasis, you will definitely write it's obstruction and fibrosis of the lymphatic channels, right? Filaria causes lymph node destruction. The lymphatics, everything will be destroyed, sclerose. That's why lymphatic drainage will not happen, which results in edema or elephantiasis, right? Okay. Great chest harmony. The other options may be similar, may not be similar, but the right answer here has to be an obstruction and fibrosis of the lymphatic channel. That will not let the lymph flow properly, right? Great. So let's go to the next one. This is actually an old question. I don't know how many of you have seen this PYT. There's actually a similar question on pseudogouty arthritis. The only addition what they have made here is they have added this positively birefringent crystals. Some of the students, when they saw this positively birefringent, they imagine it's negative and went to gouty arthritis. There are few things which is against gout here. Gout does not generally happen in the knee. And gout does not have rhomboid shaped crystals. Rhomboid shaped crystals, knee joint, An elderly person, positive birefringent crystals, all these point to pseudogouty arthritis. Also keep this in mind, the old PYQ was related with hemochromatosis. There's a risk of pseudogouty in patients with hemochromatosis as well, right? Perfect. Okay, let's go to the next one. This will also be discussed in your OPG. Just this is a gross specimen I have discussed as well. 65-year-old, bleeding per vagina, underwent a hysterectomy. I'll just zoom this image. You see the uterine, it's a cut open surface of an uterus. You can see all this irregular necrotic mass, right? It's filling the cavity and it's also kind of going into the wall. What's the diagnosis here? Do you think it will be an 65-year-old? Do you think it will be an endometriosis or adenomyosis? Definitely not. It's a classical case of an endometrial adenocarcinoma. Postmenopausal women, hysterectomy done, almost always think of a cancer as a primary diagnosis. Obviously, other things also can come, right? Great. Let's go to the next guy. Was this question there? Some students said this question was there. Some students said the question was not there. The first question is, was this question there? If so, let's go to the answer. 35-year-old person, imaging shows non-specific upper quadrant pain. Liver mass was surgically resected or excised. The gross specimen showed like this. Quite a few students said that the gross specimen had a central scar. See, central scar will be there only, perfect, Dugu. If central scar was there in the question, there's only two differential diagnoses with respect to liver. One is your focal nodular hyperplasia, other is fibrolamellar variant of hepatocellular carcinoma. Can I differentiate them grossly? Actually, no. But either one of them should have been in the option. Most of your friends said the question option which was there was focal nodular hyperplasia, right? Stellate scar in the liver specimen, the gross specimen of the liver has to be only two things. If focal nodular hyperplasia was there in the question, I'd mark that as the right answer. And I don't think it will be an hepatocellular adenoma or a carcinoma or metastasis. Mets will be multiple. Hepatocellular carcinoma might be more ill-defined and infiltrated, won't have a central scar. Was the option there? Focal nodular hyperplasia? Yes, no. Navjot, Dugu, Gupta. If it was there, the answer is perfect and straightforward. Focal nodular hyperplasia. Fine. Okay. Again, this has been stressed in the classes. This is, I won't say this is a PYQ or a PYT. Focal nodular hyperplasia gross specimen is not that commonly or frequently asked, but we do read them as a differential diagnosis for fibrolamellar HCC. Fine. Perfect. Now let's go to the next one. So here I want to ask a suggestion. What was the exact question? Some students said, which of the following didn't have or they don't show heart failure cells or hemosiderin lateral macrophages? Some students said, which of them showed hemosiderin lateral macrophages? If the question is which has, I would say this is the answer. Left heart failure. Because the left heart failure, the pulmonary veins will not be able to drain. So there'll be back pressure and there'll be a little bit of pulmonary edema and hemorrhage, which forms your hemosiderin lateral macrophages, right? Perfect. Okay, Dugu and Anirban, if it is not or least likely associated, then I'll go with obviously your protein losing enteropathy. That has nothing to do with hemosiderin lateral macrophages. Least associated means if it's least associated or if it's not, I would prefer the answers to be protein losing enteropathy, right heart failure, left heart failure, pulmonary venous thromboembolism, again might result in heart failure. All of them might cause your hemosiderin lateral macrophages, fine? Perfect. If it's not, the answer has to be option B. If it is, where do you see? The most preferred answer is to be left heart failure, right? It's actually a very old second year topic. It's not even something which is heavy for entrance exam, but I'm sure it's a very simple thing. You must have known this, right? Okay. This question was there. A very classical question, a beautiful question actually. Anti-SCL70 or anti-topoisomerase antibody. This is very specific for which type of systemic sclerosis. So here you have to know very specific. This is for diffuse systemic sclerosis, right? For an limited systemic sclerosis, anti-centromeric antibody. And diffuse systemic sclerosis, the biggest problem is lung problem. Interstitial lung disease or pulmonary fibrosis is a bigger problem for your diffuse. If it was CREST syndrome, let's say next time the question comes on CREST syndrome, anti-centromeric, I'll think of a calcineuris cutis, right? So it's a classical case of a diffuse systemic sclerosis with anti-topoisomerase antibody, and option A should be the most likely answer, right? Great. Let's go to the next guy. We had two questions, no? Similar, like one is systemic sclerosis, one is Sjogren's syndrome. I feel the entire exam is going to what's happening in real life. More questions on cancers, more questions on inflammatory autoimmune conditions. Classical case of Sjogren's syndrome, what do I see in microscopy? Any autoimmune disorder, you will see only one thing, lymphocytic infiltration, that's all, right? You'll have salivary gland infiltrated by lymphocytes leading to acinar destruction. Hashimoto's, lymphocytes into thyroid. That's all, right? If it's lacrimal gland, lymphocytes, same. Any autoimmune disorder, you'll have lymphocyte infiltration because they produce the antibody and they cause the destruction, right? Lymphocyte infiltration and destruction of the salivary gland. This is something you take a lip biopsy or the minor salivary gland biopsy to diagnose, and there's a score called as focus score. If it comes next time, please do remember that focus score is something which is useful to diagnose this Sjogren's syndrome in a biopsy, right? Let's go next, guy. I think a couple of more. We'll move on to OBG. This will be dealt in your ENT as well. It's a very simple one. Antony A, Antony B, Verrecke bodies. Nothing else required. It's a classical case of a schwannoma, right? There are very simple questions as well. At least with respect to pathology, I felt there are a little bit of more simple questions only, right? Okay, that is a classical case schwannoma. I'm not going to talk much about that. Classical case again, intense pruritus, right? And I think this was there. And also some students said it was negative for ANA. That's fine. It could be primary or secondary. Primary should be AMA positive and ANA negative, right? It's a classical case of one primary biliary cholangitis, right? All these might look bigger, but they are very, very easy questions. This is something I felt was a very good googly. What do you guys think is the right answer? This is the last question. What do you guys think is the right answer? Next, we'll go to OBG soon. 58-year-old, prolonged prothrombin time. APTT also is a bit elevated. Factor 9 deficiency was shown, so it should be an APTT, not a prothrombin time. Fine. Ignore that. It's a mistake, typing error. Okay. Himanshu says option D. What do you think is the right answer here? Which is a vitamin K dependent clotting factor. I'm not sure if this was given there. 2, 7, 9, 10 are vitamin K dependent clotting factor. The most important thing here is, was this there in the question? It was corrected after giving parental vitamin K. If this was there, the answer totally changes. If it is not there, my answer is different. Was it there? Did the question have parental administration of vitamin K corrected the deficiency? If it is there, my answer would be bile duct obstruction. Because when bile duct is obstructed, you will not be able to absorb the fat and the metabolism bit alters. So the vitamin K dependent clotting factors will not work properly. But when I give a parental injection of vitamin K, I am not required for absorption. It goes directly to the blood, and that is correcting the deficiency. If it corrects the deficiency, it cannot be hemophilia. Hemophilia will not be corrected by vitamin K because in hemophilia, you don't have factor 9, right? It will not correct the vitamin K injection. It might correct with factor replacement, right? So if this was there, answer should be in bile duct obstruction, and that could be the most probable answer if this was the premise of the question. Fine. Okay. That's Midun, least as I told, that's about your protein losing enteropathy. Fine. Okay. So this is the questions which came from pathology. I hope you did very well in pathology. They are simple questions. This was a googly. If you've done this thinking the important clue statement there, you're amazing. I'm sure you'll do very well in the real life as well, right? So quickly, let's go to OBG. I think Dr. Oshika is ready. It might take a couple of seconds for Dr. Oshika to come. Yeah, thank you, Oshika.
Hello, sir. Thank you, sir. So, hi guys. I hope you guys did well. How was the exam? So, I don't know about the rest of the subjects. I've been talking about the rest of the subjects. Some people said it's moderate, some people said it's tricky, but OBG ka general consensus was that it was quite a simple paper, very straightforward. And that is what I keep saying all the time, ki OBG is actually the easiest major subject. You can get 100% marks correct in OBG. It is very, very possible. There is a very limited, very finite syllabus. उसी में से घूम घूम के हर चीज आती रहती है. ठीक है. So with that, let's begin. So what I'll be needing your help with in today's session is giving me, so a lot of people, what they were saying was कि questions were very straightforward. They felt very happy when they read the questions, but then when they went to the options, between two options, they were getting very confused. So I'll be needing your recall in telling me what the options were so that we can take care of that confusion. All right. So with that, let's begin. All right. So with that, let us begin. Let us begin with this. So there was apparently one question on cord prolapse. There was a 36-weeker pregnancy and she was dilated at around 8 centimeter and there was cord prolapse. So the question was, what will you do next? So I want you to tell me what were the options. So the options that I got, number one was, obviously the management is going to be, you're going to prepare for LSES, right? But I don't think that was there in the options. What was there in the options was that you can either go for a vaginal pack after repositing the cord, The second was push up the presenting part and retrograde filling of bladder. What were the third and fourth? So this is something that we have done in class already, that whenever there is cord prolapse, by the time you get the patient to the OT, there are certain things you have to do. Cord was still pulsating was there in the history. Very good. That is an important history. Cord was pulsating. Why? Because cord was pulsating tells me that the baby is still viable, the baby is alive. I need to take it out fast via cesarean section. Right. Agar cord pulsations nahi hote, if cord pulsations were absent, that would mean that it is an IUD, and then we would have gone for a vaginal delivery. Right. So cord was pulsating. So we will do an LSES. By the time we take her for an LSES, I want the cord to not get compressed. So I will push up the presenting part head if it was the case over here. And the second thing I can do is I can fill up the bladder retrogradely so that the bladder pushes the head up. Right. So this will be your answer if this was there in the options. If anybody can help me with what was option C and D, then that would be helpful. But for now, this is the recall that I have. So can anybody tell me? Then there was another very straightforward question, and this is actually something that one of the people at the exam center told me. She was a first timer who had just taken her exam after internship, and she told me, "Ma'am, OBG में से बहुत सारे ऐसे questions थे." There were a lot of questions from OBG that were based on what I have seen in internship, and I believe this was one of them. So what was the order of repair of mediolateral episiotomy? So the first thing that we repair is mucosa as done in class in a continuous suture, followed by muscle in interrupted suture, finally matrix suture in skin. So that would be your answer. So cord was pulsating. So the options were wait and watch, oxytocin and amniotomy. So remember, if cord prolapse has happened, your membranes have already ruptured, so there is no point of an amniotomy, right? If you give oxytocin, then due to the contractions, what is going to happen is that this baby is going to have further distress. This baby is alive, this baby is salvageable, we need to take out this baby fast, and before that, we need to ensure that the cord is not compressed by contractions, by the presenting part, by anything. So definitely we will not give oxytocin and amniotomy, but thank you for the option. Oxytocin and amniotomy. And finally, wait and watch. Wait and watch would be the option if the cord pulsations were absent, then you would wait for a vaginal delivery, right? Because IUD hai. Okay, coming to the next question. So there was this post-menopausal lady. So these are all keywords. Even when you get a clinical question, look at the keywords. Don't get confused in all the flowery language. Post-menopausal lady with hypertension, right? And she has blood and vaginal discharge, not normal in any age group. Vaginal discharge mein blood, but what basically they are saying is she has post-menopausal bleeding. So I believe one of the options was refer for cardiology opinion. The second one was reassure her. This is not normal. Never reassure her. Refer for cardiology opinion, definitely. But what do I do about the vaginal discharge? Was there any option on endometrial biopsy or endometrial aspiration? Was there any option on pap smear? Was there anything of any sort? Or was there at least a transvaginal sonography? Yeah. So of these, if all of these were also there, the best answer over here is going to be your endometrial biopsy, because we are looking at a postmenopausal lady coinciding with the peak of endometrial cancer and endometrial hyperplasia, and she is hypertensive. Remember, corpus cancer syndrome, right? So even if we do a TVS, if she has a blood mixed discharge and if the TVS is slightly more than 4 mm, we are going to do an endometrial biopsy. So if TVS with pap smear was the option, so pap smear is also accurate. Was endometrial biopsy was there? Was endometrial biopsy there? So if biopsy was there, that would be the best. That would be the best answer. But if you had TVS plus pap smear and no biopsy, then obviously that would be the answer. So can anybody tell me what was do PV, ultrasound and pap smear? So do PV, ultrasound and pap smear in the absence of endometrial biopsy is the best answer. But if they ask you what is the first step that you will do, so this is the first step and this is going to be the best step. So what was the question that was asked? It will depend on that. So if anybody can tell me what was the question, that would be helpful. The first step is going to be physical examination. plus TVS and pap smear, right? The second one is going to be your second thing, or the best thing is going to be endometrial biopsy. So depending on whether they asked you what is best or what is first, your answer would change. Yeah, so option 2, yeah, definitely you'll refer to the cardiologist for BP management, but before that, we want to rule out cancer, right? That is much more pressing at this point. So the next question, very similar in a similar vein, was 46-year-old with an 80 of 14 mm. What is the next step? Endometrial biopsy, hysterectomy, laparotomy, wait and watch. So postmenopausal bleeding has very clear-cut criteria, more than equal to 4 mm, do a biopsy. In a younger woman, especially if she is perimenopausal, remember, if she has abnormal uterine bleeding, especially one that is not medically managed, then you have to do a biopsy. And at any time, if your ET is more than equal to 12 mm, even if she does not have symptoms, you will do an endometrial biopsy. So the answer was endometrial biopsy. They ask for confirmatory. If they ask for confirmatory, then it is going to be the best investigation, which will be your endometrial biopsy. So if they ask immediate next step will be your PV, will be your pap smear followed by PV and your TVS. Right. Now, the next thing that they asked you was the sequence of maneuvers in shoulder dystocia. Right, endometrial biopsy was there. So in the 46-year-old, we are going to do an endometrial biopsy. Definitely more than equal to 12 mm endometrial thickness in any age group is abnormal, could be hyperplasia. So you will have to take a biopsy and send it for histopathology. So the next question that they asked was sequence of maneuvers in shoulder dystocia. So this is one mnemonic helper that has been told to you multiple times. And there were 4 options. So if you could just tell me just tell me if this was given to you. So the first is going to be, of course, your McRoberts. Helper, remember, call for help, episiotomy, L for legs, McRoberts, P for pressure. So suprapubic pressure. Right, if this was there, fine. If it was not there, then move on to the next one. After that, you will have E, enter maneuvers. So in enter maneuvers, you will have Rubens and wood corkscrew. If that also does not work out, you will tell the woman to stand up like an animal on all fours. That will be Gaskins, all fours. And if this also does not happen, then the last resort is either Zavanelli, you push the head back, do a cesarean section, or you cut the clavicle of the baby, or you cut the symphysis pubis of the mother. So what were the options that were given to you? Please tell me. So McRoberts, Rubin, Gaskin, Zavanelli. So very good. Remember McRoberts is great. Around 90% of the babies are going to deliver with this. So this is going to be maneuver 1. Maneuver 2 is going to be your Rubens. If this does not work out, then it is going to be your Gaskins. And finally, remember, these are not preferred at all. This is the last resort. When the baby is almost dead, dying, and nothing is possible, then you push the baby back inside, the head back inside, and you do a cesarean. So this would be your correct option, right? Okay, then this was another that I keep telling you in class, This is a maneuver that has been asked multiple times. So I believe they showed a baby that is lying in breech position and the arm is lying like this. There is an extended arm or nuchal arm. Was this there? Extended arm or nuchal arm? And I told you the baby is being dramatic like it is in love. This is called your love set maneuver, and this has been done in class. There was no question on love set. Dr. Nandini. Love set was there. Yeah, okay, yeah. So love set, remember, love set, the baby is going to pretend like it's in love. It looks dramatic, doing things like this and that. So in the picture, typically you will see a nuchal arm. The arm will be on the side of the head. Okay, fine. Okay, we'll do the answers fast. Then identification of maneuver. So either this is controlled cord retraction, this would be the answer, or same thing, modified Brand Andrew. Any other options that are there? Just let me know. There was then another question, absolutely correct, CCT, another question about prolapse. So there was this woman who had two deliveries by a thigh, and which ligament is responsible for this condition? So remember, your ligaments, the strongest ligaments would be your cardinal, uterosacral and pubocervical. Pubocervical is the weakest of the lot. So in these options, these were the options that I got. Transverse cervical ligament, guys, remember I keep telling you, do not get confused, is the same as cardinal, also known as Mackenrod. So round ligament provides a little bit of anteversion. Broad ligament is no support at all. Sacrospinous ligament is also not a support for prolapse. Mackenrod was an option, great. One option was Mackenrod, yeah, so Mackenrod is the option. Then there was another question straight out of class, G2P1L1 at 38 weeks, previous LSES, she is in labor and she is feeling a continuous suprapubic pain. The contractions are going, but with the contractions, without the contractions also she has pain, and with that there is fetal distress and maternal tachycardia. What are we talking about? This is an impending scar rupture. And what do we do in an impending scar rupture? We take the patient straight away for LSES. Excellent, guys, excellent. Yeah, that's correct. Okay, then there was one MRI question. There was one MRI where they had showed you a uniformly enlarged uterus, and with that they had given you certain keywords. What were the keywords? There was pain, there was heavy menstrual bleeding, and there was heaviness. So a uniformly enlarged uterus with these symptoms, what are we talking about? This is adenomyosis. This is adenomyosis. So was there a uniformly enlarged uterus, or could you see a very well encapsulated fibroid? So Venetian blind, Dr. Nandini, is an ultrasound feature. It is not an MRI feature. You also have to look at what are the clinical scenario that is given to you. So the clinical scenario is pain. So pain is much more common in adenomyosis than in fibroid, right? So encapsulated fibroid was given. Age was how old? It was not very well defined. So remember, adenomyosis is not going to be very well defined. So 35-year-old adnexa was normal, right? Adnexa was normal. And if it was not well defined, see over here also, if it is not well defined, I don't know if you can see the picture. So if it is not well defined, usually your fibroid is very well defined, but adenomyosis, you will see a uniformly enlarged uterus. Even adenomyosis you can diagnose with an ultrasound, but the point is you have to look at the clinical features, and the thing that you had to look for in the MRI was, in an MRI the fibroid will look like a ball. Could you see a ball? Could you see a circle, very well defined circle in the MRI? If yes, then it was a fibroid. If you could not see a well defined circle, there was just a thick uterus, then it is adenomyosis. So tell me, what did you see? Was it a circle? You will be able to see a proper circle on MRI. No. So the diagnosis for adenomyosis nowadays is ultrasound. If it was very well defined, if it was a proper circle, guys, if it was a proper circle like a word, then it would be a fibroid. If it was ill-defined, with thick uterine walls, So if anybody can WhatsApp, Telegram me or Instagram me the exact picture, thick uterine walls, then it would be adenomyosis. If it was a circle, then it would be a fibroid. Alright, then this was a picture Ranjit sir has also discussed. I believe this was the picture given to you. So what you can see is that the endometrium is very dirty looking, it is very friable, and it is sort of going into the walls. Plus again, this is a post-menopausal lady in the age group for your endometrial cancer. Right, so this we are dealing with endometrial cancer, and this has also been done in class. We have talked about AUBM. This is what endometrial hyperplasia and endometrial cancer looks like. You will see a growth, a dirty, unhealthy looking growth in your image was confusing. What was confusing about the image, guys? Just let me know what was confusing so that we can talk about it. So loading dose of Maxelf and Pritchard regimen, 4 grams IV given slow 20% and 5 grams in each buttock 50% IM. So 5 plus 5, 10 plus 4, 14. The answer is 14, guys. Okay. All right. Then there was another question. I believe there was an ovarian mass, a gross specimen given to you that had some septae. Now the thing about ovarian mass gross is that no matter, mostly वो आपको mass दे देंगे unless and until it is a very specific tumor like mucinous or something, you will not be able to identify it. All of them pretty much look the same. They will look either solid or they will look cystic or they will look solid cystic, and you will not be able to make out. What you had to pick out from the question were other keywords. What were the other keywords? CA125 is raised. It is raised in which tumor? It is raised in serous cyst adenocarcinoma. Cyst adenocarcinoma. And there is ascites also. So remember your ascites, your papillary excrescences, your omental caking with your increased CA125, this is going to be serous cyst adenocarcinoma. Then there was one very simple question, elevated levels of FSH, LH and low AMH, I believe it was less than 0.05 or less than 0.5, is suggestive of what? So high FSH, LH means what? It is sending signals to the ovary ki release karo, hormones release karo, but estrogen, AMH, inhibin, ye sab nahi ban raha hai. So what is this? Premature ovarian failure, excellent, or premature ovarian insufficiency, absolutely correct. Ascites was mentioned, then it is definitely serous cyst adenocarcinoma. Moving on to the next question, very straightforward question. I believe they had told you that there is a woman with CA cervix and she has hydroureteronephrosis. This is something I keep stressing in class all the time, all the time. Okay, so the other options were what? Thanks guys. The other options were hypothyroid, hyperprolactinemia. The age was given as 35 years old, right? So she's 35 with this. So this is called, this is either menopause. If the age is after 40, before 40, it is premature ovarian failure, right? So the next question was CA cervix, hydroureteronephrosis given. Straight away, I told you hydroureteronephrosis you see in CA cervix, it is going to be 3B. And this is a very common question they have been giving since years on CA cervix. PCOS was also one option. Thanks. So PCOS was also another option. So remember in PCOS, your LH might be a little high. It is normogonadotropic. FSH, LH are in the normal level. FSH is little towards the lower side. LH is little towards the higher side. Then I believe one question was on toxoplasma IgG positive women. So if she is just IgG positive and if she is IgM negative, what this means is this is an old infection and there is lifelong immunity and you will do nothing. So was reassurance an option? Was reassurance an option or continue as normal pregnancy? Same thing. Was this an option, guys? So what was the question given to you? Yeah, so IgM negative, IgG positive means पुराना infection है, पहले कभी हुआ है. And ऊपर से 5-year-old history they have already given, right? So 5-year-old अगर पहले पुराना infection हुआ है, they need not give you the IgG status also. 5-year-old history means she is not going to get toxoplasma again, right? And what that means is you can continue the pregnancy as usual. So other question was to terminate the pregnancy. No, definitely even toxoplasma, I keep telling this in class, toxoplasma is one of the good congenital infections because we have drugs to prevent transmission to the baby in case the mother gets it, and we also have drugs for treatment of the baby. So terminate the pregnancy is rarely ever a choice in toxoplasma, but in this case, in any case, कुछ हुआ है. In any case, over here, we are going to reassure and we are going to continue with the pregnancy. It does not even require any treatment with any drugs. Moving on to the next question. So the next question was, there was, I think, a constriction, give some treatment was also in the options. So what treatment? Give treatment. So treatment also we don't need to give. Treatment we would need to give if there was a recent infection, and we would need to terminate the pregnancy if the child had sequelae ultrasound पे on severe infection. तो ये पुराना है, कुछ भी नहीं कर रहा है, ठीक है. Nevirapine यहाँ पे नहीं, Nevirapine is in treatment of HIV, guys. So Nevirapine, we'll just talk about that question also. I believe there was one question, I don't know if it was image based or what, there was a question and a finger was probably amputated or there was a constriction band around the fingers or hands. So what is this? This is oligohydramnios, and with oligohydramnios we see, okay, so lady had So there was an absent index finger of right hand. This is something that we see in amniotic band sequence seen in oligohydramnios. So what was the question exactly? What was the question exactly? Image based, first digit amputated, and knee had band. So knee had band, what was this? Yeah, so this is going to be amniotic band syndrome seen in oligohydramnios. Then I think there was a very, very standard question on your algorithm of PPH. Toxoplasma was continue pregnancy, exactly. So there was another question on algorithm of PPH. So patient was an LR having PPH, not responding to medical management. I believe this was the question. What was the next step? So the next step is going to be what, guys? Balloon tamponade. Balloon tamponade. What were the other options? Constriction mark on left leg. Yeah, so balloon tamponade was the options. I believe other options were uterine artery embolization, B-Lynch sutures, and one more. But the answer is going to be balloon tamponade. Devascularization. Devascularization is the last but one step, just the step before your hysterectomy. It is quite towards the end. And patient is still in the labor room, you can quickly slip in a balloon tamponade and see. Beelan suture will also be done in the OT if your balloon tamponade fails. And remember, uterine artery embolization, radiologists are, very delicate people, very nicely. They'll take their time and do it, clean, drape. UAE takes time. So in a patient with active PPH, vitally unstable, you will not be able to do a uterine artery embolization, and this patient is likely to be vitally unstable because medical management चल रहा है. Medical management से नहीं हुआ ठीक. Right. Okay. Now another very simple question could be embryology, anatomy, or OBG. Umbilical cord has how many vessels? Quite simple. 2 umbilical arteries and 1 umbilical vein. Right. This was quite simple. So very straightforward. Hysterectomy was also one option. So hysterectomy, definitely that is the last step. वो हम एकदम से नहीं कर देंगे if medical management fails. This is a simple algorithm based question that we've done multiple times in class, in rapid revision, in our marathon. Right. Okay, moving on. There was one question on HIV. A pregnant woman who is HIV positive started on ART during her pregnancy and she delivers and the baby is HIV negative. Was this given? What is the recommended treatment for newborn if breastfeeding is planned? So what I want you to tell me for this question is कि had they told you कि ART कब start हुआ है, how long before the pregnancy, or had they told you anything to indicate what was the viral load of the mother, was any clue given? HIV titer was given, so HIV titer was 1200. Okay, had they told you when she started her ART, when she delivered? CD4 was not done. CD4 not done. So ART was started. Excellent. ART was started at 34 weeks. And when did she deliver? It was started in the last trimester. Okay. So this question could have been a little tricky, but we have discussed this. So basically what will happen is if an HIV positive mother gives birth to a child and she is willing for breastfeeding, and remember breastfeeding is not contraindicated in HIV in India. Right, in India. In other countries, they say no, but in India, we encourage breastfeeding. No mixed feeding is to be done. So breastfeeding अगर करा रही है तो baby को what prophylaxis are we giving? We are giving just nevirapine, not zidovudine, just nevirapine. Now the question is for 6 weeks or for 12 weeks, that will depend on whether the mother is high risk or low risk. By which, what do we mean? By which, what do we mean? If the mother has been started on ART since the beginning and she has a low viral load, then we will need to give nevirapine just for 6 weeks. But if she has a high viral load and she has been started towards the end of her pregnancy, then we will do nevirapine for 12 weeks. Nevirapine for 12 weeks. Okay. Was there any question and continue breastfeeding? Yeah. So we are giving the baby these drugs so that breastfeeding could be done. With these drugs, your mother to child transmission becomes as low as 1%. All right. Now coming to this, was this a question? Day 21 to day 25 May, what are the hormones that are more? What are the hormones that are less? What are the hormones that are more and what are the hormones that are less? So hormones that are more, as seen in the graph, we have done this in class multiple times. So your progesterone will be more, your estradiol will be more, but what will be less? Your LH and FSH will be less. So was this an option? Was this an option? So if nevirapine 12 weeks was not an option, then the next best is going to be your nevirapine and zidovudine for 12 weeks. If you have to give nevirapine for 12 weeks, either you give it in combination or you give it singly, but you have to give nevirapine for 12 weeks if the ART was started later in pregnancy. Right, correct. So that was the answer. So was this a question? Was this the exact question? Venous thrombosis postpartum you want to prevent after LSES, what do you give? So for prevention and for treatment, because of its fast nature of action, we give low molecular weight heparin. Low molecular weight heparin. So this was the answer. Now, was there any question by chance? Some kids have been giving me this. Some people have missed it out. Was there any question on absent end diastolic flow, FGR, absent end diastolic flow, AEDF? Any question? We can give nevirapine for 6 weeks. So had this mother, this is why I asked you, did they tell you when the ART was started? अगर question होता कि ART मम्मी ने शुरू से start किया है, viral load कम है, right? So if she had been taking ART since the beginning, so this is what NACO says, what NACO says specifically, if ART is started late in the pregnancy, then the baby has to be given nevirapine prophylaxis for 12 weeks. If the mother has been on ART throughout her pregnancy, then she can be given, the baby can be given nevirapine for 6 weeks. Okay, Dr. Shubham? So there was no question on AEDF. Okay, then we will ignore it. Also tell me, okay, ma'am, one option in BP high was to check for bladder fistula. So bloody discharge, bladder fistula, dekho, unless and until there is any history. Thank you for telling me the option, but unless and until there has been any history of chemo radiation or any surgery that will cause a fistula, we will not suspect the fistula in such an old patient. Young patient may, if there is a history of childbearing and uske baad bloody discharge, watery discharge that looks like urine has started coming out, only then it is required. Okay, started it during pregnancy, but 34 weeks pe, that is late in pregnancy, so it's going to be 12 weeks. Right? Okay, so if there was no question on ADF, we will move on. Just tell me, was there any question on the POXO Act? Was there any question on the POXO Act? I did not get it exactly. Was it there? Was it not there? Okay, so POXO Act may it was there, and I believe they had asked you it is for who is benefiting from the POXO Act, who is it for? So it is for children below how many years of age? 18 years of age, and it protects both male and female, both male and female children. Age group included. So less than 18, any child, be it a boy or girl. Exactly, Dr. Apurva. All children, exactly, Dr. Surmai. All children below 18 years of age are protected again under the POXO. Then the next question, was this their best method for determination of gestational age? Very, very straightforward question. I was toxoplasma node was positive. What node? Lymph node. Was this a question, guys? Was this a question? Best method for determination of gestational age? If so, yes, a crown rump length in the first trimester is going to be okay. Yeah, in irregular periods. So definitely, even if periods are regular, most accurate is going to be your crown rump length unless the woman is very, very sure of her dates. So first trimester, 9 weeks was given. In 9 weeks, CRL will be the best. Was there any question? Acha, with 2 months amenorrhea. All right, great. Irregular periods, okay. Okay, thanks guys. So CRL will be the answer. CRL will be the answer. And OCP was also taken. OCP is taken. So CRL is going to be the answer, guys. Was there any question on NST? Was there any question on non-stress test? So this is the last question that I feel was from OBG. Can anybody? So what was the question on NST, guys? Okay, so the patient had decreased fetal movement, and NST1 acceleration was there and no deceleration. What will you do next? So what were the options? What were the options, guys? one acceleration. Okay, so they had given one acceleration in 20 minutes. So what you will do next is you will extend the NST by another 20 minutes because we need two accelerations at least, right? Plus she has a complaint also. So total 40 minutes we will do it. What were the other options? Was this there in the options or were there other options? Continue for a total of 40 minutes. Yeah, extend by 20 minutes. Yeah. Termination we don't require. There are no decelerations. There is an acceleration. Great, great. So that was the answer. So I think this is it. These are all the OBG questions that I could get. Please let me know if I'm missing any question. Was there any other question? So these are about 30. Was there fetal distress was there from last day? Okay. Immediate LSES, NS. Okay. So immediate LSES. There's no need to do that. NST for 40 minutes. Chadwick sign was given. Chadwick sign, what was Chadwick sign for identification? It is a probable sign. So Chadwick sign, okay, I will just add this and I will also, we will discuss this later when we are discussing in detail. So Chadwick is going to be a probable sign. Yeah, but if Chadwick was given, it is not a definitive sign. Probable and presumptive. So this is going to be probable, guys. Yeah, so these are going to be probable signs of pregnancy. Okay. So Chadwick was given, Linea nigra was given, and what else was given? Montgomery tubercles and Chadwick's. And they had asked you whether it was probable or presumptive or what? Definitive. So this is going to be probable. All right. Size of abdomen was also given. All right. So I think that's it. Were there any other questions? So there was no question on AEDF. You told me no question on AEDF. So I will cross that out. So this was not there. Any other questions, guys? Enlarged uterus was also there. Okay. Right. So this is going to be a probable sign, guys. So I hope you guys did well. And without taking much of your time, if this was it for OBG, without taking much of your time, I'm going to hand it over to the next person. Probable. Question on maneuver of delivery was also there. Loveset maneuver, breech delivery. Uterine prolapse, yeah, I already discussed uterine prolapse. I think the question that they had asked you was which ligament is not, which ligament is responsible. So in that, I think McEnroe was given. Loveset has been discussed, prolapse has been discussed. So the answer was Loveset maneuver in the maneuver, and for prolapse, the answer was McEnroe. All right, okay. Order of maneuvers is also done, Dr. Binoy. We have talked about McRoberts followed by your Rubens and Gaskins and Zavanelli. No, Pinard was not there. Okay. So I think you guys are joining in a little bit late. So if you just rewind a little, you will be able to see everything has been discussed, guys. So maneuvers, Loveset maneuver, hand was like this. Control cord traction image, yeah, that was also discussed. So this was, I think, pretty obvious. This was given, right? Okay. So manual removal was one of the options, I believe. Manual removal ka picture nahi diya tha. Okay. So we will come out with a detailed recall now that I have a few more options. Okay. Thank you, Dr. Dugu. I'm so happy that the marathon was helpful to you guys. That was the point of the marathon. All right. Thank you. And I will hand it over to the next person. Thanks, Dr. Purva. I hope you guys did really well and then I don't have to meet you guys ever again. This is it. This is the last time you guys are doing OBG, except for those who get OBG, of course. Right? Okay. So I'll hand it over to the next person. Except for those who get OBG, of course. Right? Okay. So I'll hand it over to the next person.
Thank you, Ashika. Thank you for that crisp and exhaustive discussion on OBG. Now let's quickly come to radiology recall. Just give me a quick confirmation that I'm audible and I'm visible, and then I'll start. Yeah, I think we are good to go. So around a lot of questions came in radiology this time, and I would say that one of the question was a new question as well. And so let's quickly go on to the radiology recall. Right. So just quick request from all of you that please do mention whether this question was asked or not. And if you are able to recall the exact options, please mention them in the comments, right? So we'll start with the first question. So a lot of students have said me that this is the question that was asked. A 70-year-old lady with severe back pain and X-ray lumbar spine was shown. Now, what is the diagnosis? Now, if this was the image which was given to you, now at first tell me whether in this image you could see a step off. What do I mean by step off? That the distance between the posterior spinal column is different at L4 and L5, right? These are the two levels that we are talking about, L4 and L5. So if this distance was there, then the answer is spondylolisthesis. Whereas if there was no distance, for example, if there was no offset like this, it was in line, then the option becomes spondylolysis, right? So tell me in the comment section in the chat box whether there was a step off, and if there was a step off, the answer is spondylolisthesis. Okay. ओके या सो स्टेप ऑफ वाला इमेज था, इट वाज द स्टेप ऑफ वाला इमेज, ये वाला इमेज था, तो ठीक है. थैंक यू फॉर कंफर्मिंग. लेट्स गो ऑन टू द नेक्स्ट. So this was the next question. Which of the following statements is true regarding the investigation shown? Now, which is the investigation that we are talking about? It is IVP, right? So IVP is a invasive or non-invasive. Now you give IV injection in IVP. So not naturally, what do I call an invasive test in which we do some kind of an operation? Now we are breaching the skin, so it's sort of a micro-invasive, but I don't call it an invasive investigation. So it's a non-invasive investigation. And where do I use it? I use it wherever there is any urinary tract obstruction. Urinary tract obstruction. Now the same image, sort of identifying the procedure, came in FMG exam also, wherein they had asked what is this investigation, and one of the options was MCU. Now this is not an MCU. Why? Because you are not able to see the urethra. And if you're not able to see the urethra, that means the patient is not micturating, and hence it is an IVP only. So everybody is clear on IVP. It is a non-invasive test. Now where is it used? It is used to diagnose urinary obstruction. So let's see the options. Invasive method to diagnose bladder cancer? No, it is not an invasive method. It's non-invasive method. And whenever we want to see bladder cancer, what do? We do a cystoscopy. Cystoscopy and guided biopsy. Now, second option, non-invasive method to diagnose PUJ obstruction. So yes, it is a non-invasive method, and PUJ obstruction is sort of a urinary obstruction at the level of pelvis and ureter. So yes, this is a correct option. Now, can be used in percutaneous guided procedure? No, in percutaneous guided procedure, the procedure name is percutaneous nephrostomy, PCN. What do we use? We use either an ultrasound or we use a fluoroscopy. Now, urologists use something known as, the name of the investigation is RGUP, retrograde uretropielogram, right? And if you remember my main notes, in the main notes, we have talked about RGUP as an investigation, which is an invasive investigation. This is an invasive investigation. Here the urologist uses a cystoscope, goes into the bladder, sees the ureteric orifice, cannulates the ureteric orifice and puts in a dye. So in RGUP, number one, it's an invasive, and only one side ureter and PCS is opacified. So this is not an RGUP because bilateral ureters you are seeing, bilateral PCS you are seeing. And last option, invasive method used to diagnose bladder stone. No, bladder stone, again you use ultrasound to diagnose. So the correct answer here is B, non-invasive method to diagnose PUJ obstruction. ठीक है, clear है सबको? ठीक है थमीम? तस्लीन, sorry. Dr. Apurva, B ही answer. Yes. Okay, thank you. Now let's go on to the next question. Now first tell me whether this was the image, exact image which was asked, and what was the framing of the question. Now history of pulsatile mass neck, a lot of students saying this was given in the question. Now DSA image was given. So first of all, tell me whether it's a DSA image or a CT image was given. So if a DSA image was given, now some students are saying there was carotid compression, and in the question it was mentioned that the mass reduces when does not show blush when you are compressing the carotid, but when you release the carotid, again the blush appears, right? So DSA image ही थी Dr. Apurva. Yes, यही वाली image थी Dr. Apurva. Yes, okay. So this was the image which was given, and what do you see? You see there is splaying of the internal and external carotid. There is splaying of ICA and ECA. क्या साइन बोलते हैं इसको? हम बोलते हैं लायर साइन, LYRE, right? And this is significant. This tells you it's a CBT or a carotid bodies tumor. ठीक है. पल्सेशन नेक मास CT इमेज. ठीक है. सो एन्यूरिज्म क्यों नहीं है? एन्यूरिज्म क्यों नहीं है? सो फर्स्ट ऑफ ऑल, अच्छा हेमांजियोमा नहीं था, आई थिंक एक ऑप्शन था एन्यूरिज्म. या एन्यूरिज्म क्यों नहीं है? सो पहली बात, कैरोटिड में एन्यूरिज्म्स बहुत रेयर है. एन्यूरिज्म्स होते हैं ऊपर, ये वाली इमेज थी, ये वाली इमेज नहीं थी. एन्यूरिज्म ब्रेन में होते हैं, MCA, ACA एटसेट्रा में. सेकेंड, पल्सेटाइल मास एन्यूरिज्म भी करेगा, बट वो बहुत रेयर होगा. सेकेंड, इफ यू सी दिस वैस्कुलैरिटी विद इन दिस मास, एन्यूरिज्म अगर होगा तो कैसा दिखेगा? एन्यूरिज्म अगर होगा तो पूरा everything will be filled black. It will fill like a vessel. So if it's filling like a vessel, it's round, then it's an aneurysm. But if you see vascularity within and the EC and IC are splayed, then it's a tumor. ट्यूमर में थोड़ा पैरेन्काइमा भी होगा, पूरा वेसल नहीं होगा ना. तो पैरेन्काइमा के बीच में वेसल्स जाएंगी तो ऐसे जाले से दिखेंगे, नेटवर्क दिखेगा, whereas aneurysm will be completely black. ठीक है. तो आंसर हियर इज CBT और कैरोटिड बॉडी ट्यूमर. सर ट्यूमर कैन बी हार्ड, नॉट कंप्रेसिबल. कंप्रेसिबल स्वेलिंग हो सकती है सम. ठीक है. सो इफ लायर साइन वाज सेम इमेज था, सो दिस इज एन इमेज ऑफ लायर साइन. नाउ नेक्स्ट, a 30-year-old male patient, MRI brain is shown. What is the diagnosis? So first of all, tell me whether this was the exact image which was shown, right? If this is the image, then what is this tumor? So it's a extra-axial tumor. You are seeing that these two are the dural tails. Dural tail and dural tail sign दिख रहा है आपको. So this is an extra-axial tumor. The answer becomes a meningioma. Rest all the options that are there, they are of an intra-axial tumor. Intra-axial मतलब brain parenchyma से originate हो रहे हैं. Now pilocytic astrocytoma कहाँ पर दिखता है? Mostly cerebellum and optic chiasma. ठीक है. ऑप्टिक chiasma में NF1 में दिखता है. Then gliomas again brain parenchyma में दिखते हैं, but gliomas, remember, they do not enhance. They do not enhance. And ependymoma किस चीज का ट्यूमर है? Again main notes में we have covered. Ependymoma is a tumor of fourth ventricles. Right. So similar image we also discussed in our main notes of radiology, and the answer here is meningioma. थोड़ा सा लेफ्ट साइड मिड लाइन में था ट्यूमर. ठीक है, ठीक है, ठीक है. ऑलमोस्ट द सेम. राइट. ग्रेट. Now, next image, a 35-year-old female, lower abdominal discomfort. MRI is shown below. What is the diagnosis? So, was this the same image that was asked? Tell me, guys, was this the same image? यही आई थी image? So, image में क्या दिखा रखा है हमने कि जो पोस्टीरियर मायोमेट्रियम है वो बल्की है, एंड उसके अंदर मल्टीपल सिस्टिक स्पेसेस हैं, टाइनी सिस्टिक स्पेसेस. नाउ इसको अगर हम रेडियोलॉजी टर्म्स में देखें तो रेडियोलॉजी में हम इस एरिया को बोलते हैं जंक्शनल जोन, एंड दिस वी हैव ऑलरेडी कवर्ड इन आवर क्लासेस. Junctional zone and widening of junctional zone more than 12 mm. I told you, if the junctional zone is more than 12 mm, then we suspect adenomyosis. Right? For adenomyosis, the investigation of choice is MRI. Okay, next image. Identify the structure marked by the arrow. Now, what is this investigation? What is this? What is this investigation which is shown? So, first of all, this is not a X-ray of the neck. This is not a neck X-ray. This is a barium swallow. Right? Whenever you do a barium swallow, the first phase that you see is the upper airways. So upper में आपको larynx की anatomy दिखती है. And tell me which of these two arrows was asked, whether it was a black arrow or whether it was a white arrow. So if it's a white arrow, then this is the pyriform sinus, and the black arrow is the vallicula. Black arrow is the vallicula. ठीक है, white arrow ही बोल रहे हैं. Most of the students are saying it's white arrow. So the answer here is pyriform sinus. It's the pyriform sinus. Okay, now next question. Let's see the next question. A male patient with back stiffness and red eye. Early diagnosis of an ankylosing spondylitis has been made. Okay, now X-ray was normal. We know that in early ankspond, SI joint X-ray is normal, which is the best imaging modality now to diagnose ankspond. So SI joint से start होता है, and which is the investigation of choice? It is MRI. And what do you see here? You see bone marrow edema. Bone marrow edema. And which sequence? I've also told you the sequence in the class. Stir sequence. Stir sequence is used. ठीक है, we have discussed angspond in detail. Now angspond हर बार क्वेश्चन आता है, कभी INI में आता है, कभी नीट पीजी में आता है, कभी साइंस पूछ लेते हैं, कभी MRI पूछ लेते हैं. So angspond is the most important arthritis that you have to learn from PG point of view. ठीक है, okay, let's see the next. Now this was a new question. This was not a PYT. This was not a PYQ. Right? This was a new question in radiology from nuclear medicine and a very good question. A neonate is diagnosed with a congenital hypothyroidism. Thyroid ultrasound shows normal gland in C2. ठीक है, thyroid gland is present. So हम क्या क्या लिखेंगे इसमें? Thyroid gland present है. Now, but radio iodine uptake scan shows no uptake. But thyroid scan is negative. राइट, सो क्या मतलब है कि थायराइड ग्लैंड एनाटॉमिकली प्रेजेंट है, बट उसमें अपटेक नहीं दिखा पा रहे हैं. क्यों? क्योंकि रेडियो ट्रेसर अंदर नहीं जा पा रहा है. दैट इज व्हाट इट मींस. सो व्हाट इज द लाइकली डायग्नोसिस बेस्ड ऑन दिस गिवन क्वेश्चन? ठीक है, नाउ व्हाट वर द ऑप्शंस? यू आर सेइंग वन ऑप्शन वाज डिफेक्टिव ट्रांसपोर्ट. सो डिफेक्टिव थायराइड अपटेक. सो डिफेक्टिव ट्रांसपोर्ट लिख देते हैं इसको. डिफेक्टिव ट्रांसपोर्ट, डिफेक्टिव आयोडीन ट्रांसपोर्ट ऑफ आयोडीन. ठीक है, ये ऑप्शन था. ठीक है, तो अगर एब्सेंट थायराइड ग्लैंड होगा, तो इसमें क्या मिलेगा हमें? अल्ट्रासाउंड में भी नो ग्लैंड एंड थायराइड स्कैन, जिसको मैं टीएस लिखूंगा आगे से. थायराइड स्कैन भी नो ग्लैंड, बट हमारे में तो थायराइड ग्लैंड प्रेजेंट है अल्ट्रासाउंड में, सो दिस इज नॉट द ऑप्शन. नाउ थायराइड डिसहार्मोजेनेसिस, आयोडीन डिफिशियंसी. नाउ अगर थायराइड डिसहार्मोजेनेसिस होता है, सो फर्स्ट ऑफ ऑल व्हाट इज थायराइड डिसहार्मोजेनेसिस? Here the thyroid gland is present, but there is defect in the production of thyroid hormone. At what level? At the level of peroxidation. ठीक है, तो आपने नहीं पढ़ा होगा थायराइड डिसहार्मोजेनेसिस क्या होता है, बट थायराइड डिसहार्मोजेनेसिस में देयर इज यूजुअली द अपटेक इज नॉर्मल, बट जो H2O2 के लेवल पर पेरोक्सीडेशन होता था, दैट इज एबनॉर्मल. सो क्या अपटेक होगा इसमें? अपटेक होगा. सो थायराइड डिसहार्मोजेनेसिस में इफ आई सी हियर, अल्ट्रासाउंड विल बी नॉर्मल and thyroid scan will also be normal. ठीक है. Now next, iodine deficiency. Whenever there is iodine deficiency, what happens? T3 and T4 becomes low, so TSH rises. ठीक है, न्यूट्रिशनल अनीमिया में, न्यूट्रिशनल हाइपोथायराइडिज्म में. तो आयोडीन अल्ट्रा डिफिशियंसी में क्या मिलेगा? अल्ट्रासाउंड नॉर्मल होगा, एंड क्योंकि टीएसएच हाई है, देयर इज हाई अपटेक ऑफ आयोडीन, सो हियर thyroid scan will also be normal. We are left with only one option: defective transport of iodine. It is a receptor based defect. Here what happens? There is defective uptake of iodine by the thyroid gland. So what will happen? Ultrasound will show us a normal thyroid, but thyroid scan will show us no uptake because iodine receptor is abnormal. So this is the answer. D is the answer. ठीक है. सो अगर आपने ये आंसर ठीक कर लिया, सो कंग्रेचुलेशंस. थोड़ा लॉजिकल है आंसर. इफ यू कुड गेट टू द आंसर बाय लॉजिक, then it is awesome, then it's amazing. If you haven't, don't worry, it was a new question. ठीक है. सो सही था आंसर. थैंक यू अपूर्वा, ग्रेट, यू गॉट द आंसर राइट. थोड़ा लॉजिक ही था कि नॉर्मल अल्ट्रासाउंड पे दिख रहा है बट अपटेक नहीं आ रहा है, तो मतलब रिसेप्टर में दिक्कत है. डिफेक्टिव ट्रांसपोर्ट रिसेप्टर, डिफेक्टिव ट्रांसपोर्ट रिसेप्टर ऑफ आयोडीन. सो डी इज द करेक्ट आंसर. ठीक है. चलो नेक्स्ट, इसके बारे में थोड़ा पढ़ लेते हैं. डिसहार्मोजेनेसिस एंड कॉन्जेनाइटल हाइपोथायरॉयडिज्म. सो कॉन्जेनाइटल हाइपोथायरॉयडिज्म दो तरह का होता है, एक टेम्परेरी होता है और एक परमानेंट. और टेम्परेरी ऐसा होता है कि मदर ने एंटी थायराइड हार्मोन्स दे लिए थे, सो जो बेबी हुआ उसमें भी रिसेप्टर टेम्परेरी ब्लॉक हो गया, सो दैट इज ट्रांजिएंट. जो परमानेंट कॉन्जेनाइटल हाइपोथायरॉयडिज्म होता है, इट हैज टू इंपॉर्टेंट कॉजेज. एक होता है थायराइड एजेनेसिस एंड दूसरा होता है थायराइड डिसहार्मोनोजेनेसिस. नाउ एजेनेसिस में क्या होता है कि थायराइड ग्लैंड ही नहीं बनती, एंड डिसहार्मोनोजेनेसिस में क्या होता है, आपके जो प्रोडक्शन ऑफ थायराइड हार्मोन्स होता है उस लेवल पर डिफेक्ट होता है. अब वो ट्रांसपोर्टर अपटेक में भी हो सकता है, वो पिरोक्सिडेशन में भी हो सकता है, थायरोग्लोबुलिन प्रोडक्शन में भी हो सकता है, डिपेंड करता है. बट दैट इज द ओरिजिनल एक्सप्लेनेशन विच आई हैव ऑलरेडी टोल्ड यू. नाउ नेक्स्ट क्वेश्चन. Patient presented with right flank pain. A coronal CT image was given. What is the diagnosis? So first of all, tell me what was the exact question. What was the exact question? And what were the options? So whether this image was given, was this image given? A, whether B image was given or a C image was given. Which image was given? Anushka, Apurva, are you there? Which image was given? So most of the students have told me that this was the image which was given, that the kidneys were visible. So if it was the level of the kidneys, left kidney अगर दिख रहा है तो किडनी का लीजन है. अगर किडनी का लीजन है तो आंसर है आरसीसी. अगर गॉल ब्लैडर दे रखा होगा ऑप्शन में, तो गॉल ब्लैडर यूजुअली एक एंटीरियर सेक्शन मिलेगा, तो किडनीज नहीं दिखेंगी उसमें. एंड अगर लिवर का लीजन होगा तो लिवर से ओरिजिनेट करता हुआ दिखेगा. सो सॉर्ट ऑफ एनाटॉमी क्वेश्चन है. इफ यू गाइस टेल मी विच वन इज द करेक्ट इमेज, देन अकॉर्डिंगली द आंसर विल बी देयर. जीबी न्यूप्लाज्म, राइट किडनी न्यूप्लाज्म, न्यूप्लाज्म ऑफ द किडनी, किडनी अफेक्टेड. बोथ किडनीज वर नॉट विजिबल सर. इनमें से कोई भी नहीं है सर. ओके, इमेजिंग मोडालिटी नहीं था. जीबी कार्सिनोमा था. जी हेट्रोजिनस मास इन द किडनी. सी अगर किडनी का ओरिजिन है ना, तो किडनी आपको अलग से दिखेगी. इसमें नीचे नॉर्मल किडनी दिखती है आपको. ठीक है. अगर लिवर का मास है तो लिवर से ओरिजिन दिखता है. तो व्हाट द एग्जामिनर इज एक्चुअली आस्किंग यू इज द क्लॉ साइन. क्लॉ साइन टेल्स यू ऑर्गन ऑफ ओरिजिन. ठीक है. तो व्हाट विल डू इज मे बी इफ पॉसिबल विल ट्राई टू गेट द एग्जैक्ट इमेज, बिकॉज इमेज के बिना इस क्वेश्चन का आंसर बताना बड़ा मुश्किल है. राइट. ओके. Now let's see this image. A 8-year-old child with painless limb. Again, this will be covered in orthopedics as well. Painless limb के बड़े ही specific से causes होते हैं. 8-year-old child में अगर this was the image which was given, and you can see that the epiphysis is flattened and deformed. What does it tell you? It is an avascular necrosis of the epiphysis. And बच्चों में avascular necrosis is usually Perthes disease. Right? So this is Perthes disease. ठीक है. Okay. A 45-year-old male presents with cough and low-grade fever. Chest X-ray shown below. What is the likely diagnosis? So what do you see here? There is opacity in the right upper zone, upper and mid zone. And what do you see? What is happening to the trachea? जब भी हमें opaque hemithorax मिलता है या फिर radio opacity मिलती है, lobar consolidation, collapse, malignancy, lung abscess, these are the differential. Now lung abscess तो नहीं होगा because it will have what? It will have an air fluid level. तो ये तो ऑप्शन नहीं है, ये तो आंसर नहीं है. Now between collapse, consolidation and malignancy. Now collapse will have what? It will show ipsilateral shift of the trachea. अगर शिफ्ट नहीं हो रहा है सेंट्रल में ही है तो या तो मेलिग्नेंसी है या कंसोलिडेशन है. नाउ मेलिग्नेंसी में यूजुअली क्या होता है? मेलिग्नेंसी हैज अ वेरी इरेगुलर आउटर बॉर्डर्स एंड consolidation usually have a straight border or a bulging border. So according to me, this looks like a right upper lobe consolidation. Again, you guys tell me, question में भी दे रखा है cough and low grade fever. Again, which favors consolidation rather than a malignancy. All right, so this is consolidation. Now, this is not really a radiology question, but we've covered this when we were discussing DAI. 25-year-old patient had a road traffic accident and initially was conscious, but later became unconscious and subsequently died. So he died very immediately. That means there was a severe brain injury. Now, on post-mortem examination, multiple petechial hemorrhages were seen in the corpus callosum. Very, very important. Now, whenever we are talking about petechial hemorrhages mainly at gray matter, white matter junction. This is a hallmark of diffuse axonal injury. Now, what were the other options? NCCT was done, it was normal. Okay, ये भी दे रखा है क्वेश्चन में दे रखा है NCCT was normal. Again, it favors our DAI hypothesis. Right? What were the other options? What were the other options? I think some students have messaged me. EDH नहीं था, diffuse vascular injury था एक option. And एक option था ischemic injury. Ischemic injury was also an option. Right? So the answer here is DAI, diffuse axonal injury, gray matter, white matter junction hemorrhages, road traffic accident, NCCT normal. Diffuse vascular injury भी था ना. हाँ, ये नहीं होगा. Diffuse vascular injury में you get big hemorrhages. You don't get petechial hemorrhages. Here you get big hemorrhages. All right, next question. So a neonate presents with severe respiratory distress. So buzzwords here are on neonate. Shortly after birth. Again, buzzword is immediately after birth and was admitted to ICU within 24 hours. So respiratory distress at birth. So we are talking about respiratory distress at birth. A chest X-ray is shown to you. What is the likely diagnosis? So here, see respiratory distress at birth, हमें क्या क्या देखना है? Mainly respiratory distress syndrome due to surfactant deficiency. एक CDH important diagnosis बनता है because उसका ही spot आता है हमारे पास mostly commonly. So what is the likely diagnosis? I see there are multiple lucencies in the left hemithorax and in the abdomen. I don't see any stomach bubble or remaining bowel lucencies. So this is what is a congenital diaphragmatic hernia. Due to defect, there is herniation of bowel loops. ठीक है, so यही इमेज था डॉक्टर राज. डॉक्टर मोहक, was this the same image which was given? Pulmonary embolism बच्चों में नहीं होता है, स्पेशली नियोनेट में तो बिल्कुल नहीं होता है. Again, this is out. Pneumothorax में you won't see whitish areas, you will see a complete air on one side. So ऐसा भी नहीं था, so pneumothorax is out. Now respiratory distress syndrome, again you will see white out lungs. So confirm whether these were the options. These were the options. Confirm. Here the answer is congenital diaphragmatic hernia. Okay. CPAM was one of the options. CPAM था क्या option? बाकी लोग confirm करो एक बार. Apurva, Jasleen, Dr. Raj, was CPAM also an option? इस वाली क्वेश्चन में CPAM भी था क्या ऑप्शन? Pulmonary malformation was also an option. Okay, pulmonary malformation भी अगर था, if CPAM was an option, then usually remember CPAM right में ज़्यादा common होता है as compared to left, and usually first 24 hours में it is usually not the cause of respiratory distress. Okay, ठीक है, CPAM भी option में था. Thank you. Now again, this is something which will be covered in surgery also. What is the best method for diagnosis in this barium swallow? So first of all, tell me any clinical history as well given कि dysphagia to liquids more than solids ऐसा कुछ दे रखा था, regurgitation हो रहा है. So क्या देख रहे हैं हम यहाँ पे? Achalasia देख रहे हैं. This is achalasia cardia. And what is the gold standard? Gold standard is esophageal manometry. Right? So this is the answer. Esophageal manometry. ओके, जस्ट इमेज. ओके, बस इमेज ही दे रखा था और कोई क्वेश्चन नहीं था. ठीक है डॉक्टर राज, थैंक यू. थैंक यू. All right. Now the last question, a 30-year-old man underwent knee surgery 7 days ago. He now presents to the emergency department with sudden onset chest pain and shortness of breath. So typical history किसकी दे रखी है? एक orthopedic surgery हुई है, patient is bedridden and now presents with chest pain and shortness of breath. What are we dealing with? We are dealing with pulmonary embolism. And what is the investigation used to confirm the diagnosis? It is CT pulmonary angiography, CTPA. So answer is CTPA. CTPA is the investigation of choice for pulmonary angiography. Yes sir, how will you confirm it's CTPA? CTPA ही है ना? CTPA was the option. ठीक है, CTPA, CTPA. ठीक है, thank you, thank you, thank you. So that is all from the radiology recall. We'll now hand over to the next teacher. And if you have any queries, you can please message me personally.
Thank you, Dr. Rishabh. So we will be starting microbiology. Right. Okay, microbiology, basically 14 to 15 questions have come to me based on your recalls, and direct questions were not there this time. Hardly 1 or 2 direct questions were there, and very, very clinical scenario heavy and very much buzzword heavy questions were there, right? So kar lete hain. We will quickly start. Basically, what we discussed at the time of initial discussion also, you basically needed a conceptual understanding and you needed a lot of stamina to attempt this paper, I feel, because reading all the long questions and then focusing on the buzzwords in those questions was very, very important this time. So, first question से start कर लेंगे. Right. In a rural village, multiple individuals developed dysentery after consuming raw unpasteurized milk. ठीक है, तो buzzword एक तो यही है आपका raw unpasteurized milk, and stool microscopy revealed gram-negative coma or S-shaped rods with abundant polymorphonuclear leukocytes. Most likely causative organism for this outbreak. So first of all, they're talking about an outbreak and gram-negative बोल के the options: Clostridium perfringens, Staph aureus, Vibrio parahemolyticus, and Campylobacter jejuni. Now, very smartly, they have tried to distract you by giving milk in the. Acha, comma shaped was not there, Dr. Purva. Okay, right. So you have told me that comma shaped was not there. Now, milk bolke, they have tried to confuse you with Staph aureus, but then gram negative they have given in the option. So Staph aureus is GPC and Clostridium perfringens will be your gram positive rod. So that goes out of the question. Okay, rods was there. Okay. And Vibrio parahemolyticus and Campylobacter jejuni. So I felt that if they had given the S-shaped question, they would have wanted to confuse you between Vibrio and Campylobacter. Also with dysentery, they have tried to confuse you between parahemolyticus and jejuni. So the thing is, the thing you had to focus on here was the unpasteurized milk. And as we have also discussed in lectures, the exposure to poultry is the answer will become Campylobacter jejuni, because for parahemolyticus they would have mentioned seafood, oyster, shellfish ingestion, right? So S shape was not there. Okay, so we will remove this S shaped word here. It was just gram negative rods. Okay, thank you. Thank you, Dr. Apurva. Thank you, Anshul. Right. Okay. So I think it clears the confusion, because exposure to poultry, cattle, ingestion of uncooked chicken, and especially raw milk, unpasteurized raw milk, that is associated with campylobacteriosis, and definitely it leads to dysentery also. Great, great. Chalo. 6-year-old child is brought to clinic with complaints of intense perianal itching, especially at night. मतलब आंसर ही बता देते. It was straightforward. And mother also reports occasional abdominal discomfort in child. Examination, scratch marks. So of course intense pruritus in the perianal region. Perianal cellophane tape test. This was given, right? Same image. Okay, thank you. Thank you for confirming, Dr. Apurva. Same image. And cellophane tape test was also mentioned. If you can tell me, early in the morning. Now, was it early in the morning or was it late in the night? Though it does not matter really, because they have given almost every clue in this question now. Microscopic image given to you. Of course, it's Enterobius vermicularis, the pinworm, with these D-shaped plano-convex eggs, as you can see. Tape test was not mentioned, Bhumika. Okay. Okay, so you've written that tape test was not mentioned. Okay, okay. So what sample had they given? Said that this image that they had shown, what they said it was seen in stool microscopy, or did they say NIH swab, or what did they say? They must have definitely mentioned the sample if they mentioned the image. Clothes had threads. Okay, okay, right. Okay, okay, fine, fine, fine. Identified by mother. So yes, mother reporting was major pointer there. Pin in inner clothing. Okay, so mother reports, and mother only reported that there were thread in inner garments. Okay, so this is also very, very classical history, very specific classical history. Okay, chal. Enterobius done over here. Right. 19-year-old college student suddenly developed fever, headache, vomiting, altered sensorium. They are definitely talking about meningitis. They have written also. They'd written, right? Okay. They had written diagnosed with meningitis, died within 24 hours. Post-mortem examination of the brain showed purulent exudates over the convexities and bases of the brain, especially around cerebral vessels. So they are trying to ask you about an acute onset meningitis. So all of the options, other options that they had given, the only one which is fitting the acute bacterial with the purulent exudates, right? So the acute bacterial type of a picture, only one which is fitting is Neisseria meningitis. Cryptococcus will lead to an chronic type of a meningitis. So will TB, and poliovirus will be associated with the flaccid paralysis or the tripod sign they should have mentioned. Hemorrhagic meningitis. हाँ ठीक है, great, great. चलो, so Neisseria meningitis. Now this was very, very clinically heavy, so you had to understand the etiologies of acute meningitis, chronic meningitis, hemorrhagic meningitis. Hemorrhagic meningitis कैसे किस तरह was mentioned? Fetal bradycardia. Okay, specimen of the brain was given. Okay, they had written or they had given an image of the brain specimen. Okay, so we have to add this image of brain specimen. Okay, with hemorrhages. Right. Okay. Okay. Image was there. So there were hemorrhages on the image, or there were the exudate, purulent exudate. Image of the brain. So if any of you do have come across that image, then please share with us. Thank you, Dr. Purva. Thank you, Bhumika. Okay. Hemorrhages. Hemorrhagic picture was given. Great, great. Then too, of course, hemorrhagic picture was shown, then you will definitely think about Neisseria. Chalo. A 35-year-old man presents with low-grade fever, weight loss, generalized lymphadenopathy. So TB type of a history. He works in an old building undergoing renovation. Chest X-ray reveals bilateral hilar lymphadenopathy and lymph node biopsy shows small intracellular yeast with on the macrophages. ये तो मतलब very typical pathognomic of histoplasma. And always you will find these macrophages laden with these yeast cells with the crescent moon type gradual staining, hai na? We always talk about that. But they have said GMS also. So of course, if they're talking about intracellular yeast, then it's a pointer for histoplasma. And to make things even easier, they have given you the morphology of the SDO growth. Narrow base budding was mentioned. Acha, okay. Yeast-like organism with narrow base budding. But of course, they were talking about intracellular inside the macrophage, right? That is very, very characteristic and pathognomic. Now, was it GMS stain or did they say GIMSA stain? Because these intracellular macrophages in should be, I mean, a better history would have been if they had said GIMSA stain. So, what is GMS or GIMSA stain? Yes, of course, it's histoplasma because they have also given this image of the tubercles. The classical image with tubercles on culture. So this is the LPCB image that they had given, taken from an SDA growth. An LPCB image they had shown. Now, if you can just help me with this, whether GMS nahi tha, right, Dr. Apurva? So was stain not mentioned or they had said GIMSA instead of GMS? If you can remember, narrow base budding, I understood. LPCB image was there. Okay, chalo theek hai, then this remains a confusion whether it was GIMSA, whether it was GMS or whether stain was mentioned at all or not about the intracellular macrophage yeast cells. White color. Okay, white color on STA they must have said. White color they had mentioned on STA, growth they had mentioned. White colored growth and STA with LPCB showing this image. Was that a part of the question? If I can get some responses. No, just the image. Chalo, theek hai. But we all know that the controversy has been settled. It is histoplasma only. Theek hai. Fine. 22-year-old woman presents with painful vesicular lesions around the lips that progress to shallow ulcers. Also complaint of low-grade fever with malaise. Was there a mention of trigeminal neuralgia? Was there a mention of any neuralgia? Any neuralgia mentioned? Okay. Low-grade fever and malaise. A Zank smear from the lesion base revealed multinucleated giant cells, intranuclear inclusions. Matlab they have, okay, trigeminal neuralgia was mentioned. So they mentioned trigeminal neuralgia. Okay. No, okay. Some of you are saying yes, some of you are saying no. CMV was in the option. So Coxsackie virus was not in the option. It was CMV. Okay. Zank name was not given. Okay. Zank smear name was not given. Smear from lesion revealed multinucleated giant cells. फिर भी ठीक है. Now this in fact was a direct FMG repeat. This year only FMG they had asked about the multinucleate giant cell. Okay, you are saying trigeminal neuralgia not mentioned. Some, okay, one of you are saying mentioned, some of you are saying not mentioned. So this remains a query for us. Okay, now I have gotten two people saying it was mentioned. It was there. Chalo, then we will take your word that it was mentioned. Okay, okay, fine. What next? 40-year-old male agricultural worker presents with slowly progressive painless swelling over right foot Examination reveals multiple discharging sinuses with black granules. Now, this black granules is what makes it very easy for us. Soft tissue swelling with multiple lytic areas. Clinical image shows the typical appearance of the lesion. Now, was this, it was this swelling in the foot which was shown? Kind of like this image? Kind of like this? HPV was there, but not varicella. Okay. You're saying varicella was not mentioned, HPV was mentioned. Okay, fine. So it was HPV, HSV, CMV, and EBV. So had they mentioned short forms? Multiple sinuses on the foot was being visible. Okay. Of course, it is now, you might get confused between actinomycetoma and eumycetoma, right? So, yes, short forms. Got it. Got your point. I have changed the question accordingly. So it is the short forms given. Okay, correct. So, of course, the black granules is what is pointing towards eumycetoma as your answer in this. So, okay, you're saying trigeminal. I already did that. Diagnosis was not mentioned. Arthrospores was there in the options. Options of what? Okay, so that is another question that has come to me. Eumycetoma was not in the option then. So the arthrospores that you're talking about, that's a different question that I have received. That a 30-year-old male agriculture worker from rural area presents with chronic swelling. Now, was there a mention of along the lymphatics and they tried to ask the morphology? So if they were talking about eumycetoma, it would be septate hyphae. But if their question was more focused on the flower-like arrangement and they meant to ask sporotrichosis, then they should have mentioned that the lesions were along the lymphatics. So there is two questions, similar two questions. Okay, so this first was the black granules with the multiple discharging sinuses, and the answer was eumycetoma because of black granules. And the other question in which they wanted to ask about septate hyphae and septate hyphae with flower-like arrangement, was there any mention of lesions along the lymphatics? Or was it simply a chronic swelling with discharging sinuses and granules? Diagnosis were not asked, options were different. Eumycetoma. Yes, so these two questions have come up with a lot of confusion because two very similar questions were asked. That is the thing about this exam. Eumycetoma was not there. So are you saying it was a single question or these were two different questions? You're saying eumycetoma was not there. And they have mentioned black granules, septate, arthrospore, thin septate, yeast with pseudo hyphae for black granule question. Okay, so you are saying that over here they had said there were black granules in this question and they had given pseudo hyphae with yeast. Single question. I have gotten three responses saying it was a single question. Now, so what you're telling me, it was a single question with this image. This image was there. Single question of an agricultural worker with black granules, and they had asked which of the hyphae would be seen. Okay. Okay. So then the answer would be septate hyphae. They had not mentioned along the lymphatics, nothing about along the lymphatics. Now you're seeing two different questions, Dr. Darshan. The response that I have also received is actually two different questions and very, very similar two different questions. Okay, Dr. Anushri, there was an image of black granules given. Image of foot, yes. So image of foot is what I have, the confirmation what I have also received, that the image of foot was given. Okay. So there seems to be a lot of confusion. So if it was a black granule question with the image of the foot and the options were arthrospore, pseudo hyphae, septate hyphae with flower-like arrangements, then flower-like arrangements would be sporotrichosis. And sporotrichosis would come with the option of nodules along the lymphatics. And if they wanted to ask you about mycetoma, whether actinomycetoma or eumycetoma, with the question of black granules, then it would simply be septate hyphae. Okay. Okay, so that is what I'm gathering from all of you, that it was a single question with black granules mentioned in the image of the foot. So, and the option would be septate hyphae. Then your answer would be C. Chalo, we can move on, I think. That settles the controversy by a lot. A farmer presents with painless ulcer with a black eschar. Now, black eschar, very, very pathognomic on his forearm, along with significant surrounding edema. So, they are talking about the malignant pustule. Yeah, I know mycology is confusing, but it is actually not confusing if you try to build the concepts right from second year, because they're very specific images which are shown. So, of course, in this question, they were talking about the malignant pustule. And farmer, I believe that this paper, they were very fond of asking farmers. So many questions on farmers. Now, very specifically, they have told us smear from lesion stained using McFadden stain, large bacilli with purplish capsule. We all know the big A, the biggest bacteria, the big A, Bacillus anthracis is what they're trying to ask. Malignant pustule was the buzzword here. Black eschar was the buzzword. McFadden stain, purplish capsule, everything was mentioned, right? So it was a straight giveaway question. Abbot or worker? Okay, okay, okay. Not a farmer here. Not a farmer? Okay, fine. But lots to do with zoonosis actually. Lots to do with zoonosis in this paper. A 22-year-old woman presents with her third episode of meningitis, recurrent meningitis they are talking about. Each episode confirmed caused by Neisseria meningitis. They have mentioned only. There is no significant past medical history. Otherwise, vaccination history is up to date and HIV is negative. So HIV ELISA goes out of the question, right? Which of the following investigations more appropriate to evaluate the underlying cause of a recurrent infections? So complement component assay, because they wanted to ask about the C5 to C9 deficiency associated with Neisseria meningitis. We have discussed this in our lectures. So this was actually immunology that they asked. They wanted to check your knowledge on complement deficiency disorders and complement mediated immune mechanisms by the bacteria. So Neisseria पूछ के they wanted to ask you about the C5, C9. So even if you did not know what CH50 was, complement component assay itself was your marker. It was not a new question, because the C5 to C9 is a PYQ, but it was not put forth in this manner. So they have made the question a little twisted, but actually this is a PYQ, looks new, but it is a PYQ. Group A streptococcus, what factor helps in adherence to nasopharynx? Yeah, naya word. Yes, abator they use, but ठीक है, it does not matter ना. They gave so much. McFadden stain बोलते ही, they're talking about Bacillus anthracis. वैसे भी एस्चार की हिस्ट्री है तो क्लोस्ट्रिडियम परफेरेंस पहले ही आउट हो जाता है ना? यर्सीनिया फ्रांसिएला, बैसिलस एंथ्रासिस, ये सब आपको कंफ्यूज करने के लिए विद द स्किन ऑफ द एनिमल्स. चलो कोई बात नहीं. ग्रुप ए स्ट्रेप्टोकोकस इज अधेरेंस टू नेजोफैरिंक्स. कैप्सूल है ही नहीं, फ्लैजेला है ही नहीं. ग्रुप ए स्ट्रेप्टोकोकस कोई बात नहीं है. लाइपोप्रोटीन एंड लाइपोटिकोइक एसिड. नाउ दिस वाज अ वेरी स्मार्ट क्वेश्चन, है ना? Okay, you don't remember seeing this question. So was this question mentioned? Because I have gotten the feedback of this question being there. जिसमें लाइपोप्रोटीन, किसी ने बोला लाइपोइक एसिड. Actually, yes, it was there. Okay, you have said it was there, Dr. Bhumika. So lipoticoic acid आपका ज़्यादा important इसमें is a better answer, because this is a minor factor. This is a minor virulence factor and this is not a major associated virulence factor. Now, most of you would have wanted to see M protein in the options, and very smartly they have not given M proteins. M protein, right? तो लाइपोटिकोइक एसिड आ जाएगा. नाउ इवन दो हम ग्राम पॉजिटिव में पढ़ते हैं टिकोइक एसिड, लाइपोटिकोइक एसिड, इसीलिए लाइपोइक एसिड या लाइपोप्रोटीन लिख के विद बिकॉज ऑफ द लाइपोपॉलीसैकेराइड दे रियली वांटेड टू कंफ्यूज यू. तो इसका आंसर, आई होप यू गॉट इट करेक्ट. I hope a lot of you got it correct, and those who did, congratulations on that. And it was a direct question, and I feel a difficult question. So the clinical questions were exhausting क्योंकि इतना लंबा लंबा you had to read the options. Lipoprotein was there. ठीक है, okay. But they then gave very nice buzzwords, so you could very easily decode those questions. Person from endemic state, कोई state mentioned थी या just endemic region was mentioned? Is this real? Person from endemic state with a history of lymphedema. What is the mechanism of action of lymphedema? They basically wanted to ask you lymphatic obstruction because of the worms. Image was given. I have come to believe that image was given for the microfilaria. A microfilaria image was given. Only endemic state was written. ठीक है. अब हाइपोएल्ब्यूमिनीमिया, हाइपोप्रोटीनीमिया, इंक्रीज हाइड्रोस्टैटिक प्रेशर, ये माइक्रोफाइलेरिया की इमेज देके तो दे मेड इट वेरी वेरी इजी फॉर यू दैट दे आर टॉकिंग अबाउट एलिफेंटियासिस, है ना, एंड लिम्फेटिक ऑब्स्ट्रक्शन एज अ क्रॉनिक फाइलेरियासिस. ओके, एंड एंडेमिक स्टेट देके भी बहुत इजी कर दिया क्वेश्चन. 25-year-old sewage worker with 1 week history of fever and weakness since 1 day lab investigation showed elevated bilirubin, so you know liver is affected, decreased urine output, conjunctival redness. आपका buzzword क्या था यहाँ पे? Conjunctival redness. So of course they wanted to ask you about Weil's disease caused by leptospira. So leptospirosis they wanted to ask you. बहुत अच्छे से कंफ्यूज किया है डेंगी हेमोरेजिक फीवर के साथ, है ना. वर petechial rashes mentioned? petechiae या कुछ conjunctival hemorrhage was there. Conjunctival hemorrhage. Word was hemorrhage you are saying. Okay. कुछ petechial rashes, कुछ ऐसा mention? I think most of you have gotten this correct. Weil's disease. सीधा सीधा conjunctival hemorrhage बोलते ही सबको समझ आया Weil's disease. No. अच्छा, ठीक है. petechiae नहीं है तो फिर कहाँ से हम डेंगू हेमोरेजिक फीवर से कंफ्यूज होने वाले हैं? बाकी दोनों तो अलग ही बात है. बढ़िया, गुड. चलो, lung infection, any more history mentioned about lung infection? Bowel sample shows separate hyphae with dichotomous branching. Answer ही बता देते. It is so easy. They're definitely talking about aspergillus. Septate mention कर दिया. Dichotomous का क्या मतलब होता है? Equal branches. So if you have this one hyaline hyphae with the septations, if it will branch out, the breadth of the two branches is going to be equal. That is the meaning of dichotomous. कोई दिक्कत ही नहीं है aspergillus मार्क करने में. बाल सैंपल में of course you can see these cut off. It is going to increase because of microbiology it seems, but actually not. बहुत सारा exhausting paper था. Acute angle branching. So lung infection में कुछ और mentioned या बस ऐसे डायरेक्टली दिया हुआ था lung infection बाल सैंपल showing this में? तो ये तो बहुत ही सिंपल क्वेश्चन हो गया. Becomes very very easy. Abscess showing gram positive filamentous bacteria, Zedin stain positive and paraffin bait technique. इसमें भी बता ही देते नोकार्डिया खुद ही, है ना. If you can remember more options, so the options that I have gotten is mycobacteria, nocardia, and any other two options were also given. Nocardia is the answer correct, but other options which were mentioned, abscess दिया है, so एंटियंस के साथ कंफ्यूज करना चाह रहे हैं. एक्टिनोमाइसिस था. Very easy paper. Yeah, topics, previous year topics were definitely there. Previous year questions directly were not there. अच्छा, aspergillus भी दिया था options में, so you are saying actinomyces. एक्टिनोमाइसिस देखो बोल के आपको बहुत, अब इसमें यही पूछना चाह रहे थे वो कि पॉजिटिव फिलामेंटस बैक्टीरिया बोल के दे वांटेड टू आस्क बिटवीन नोकार्डिया एंड एक्टिनोमाइसिस। अब वहां पे एसिड फास्ट बोल के उन्होंने आपको जेडन स्टेन बोल के दे हैव गिवन यू द ऑप्शन। फोर्थ ऑप्शन किसी को याद आ रहा है? सो अप टिल नाउ आई एम गेटिंग एस्परजिलस, ठीक है, एस्परजिलस, ठीक है, बिकम्स वेरी क्लियर कट बेस्ड ऑन जेडन एंड पैराफिन बेट टेक्निक। पैराफिन बेट स्पेसिफिकली नोकार्डिया के लिए ही है। अब एक दीज वर द 14 शॉर्ट क्वेश्चंस दैट आई हैव रिसीव्ड, जिसमें भी आपने बोला कि द यूमाइसिटोमा क्वेश्चन वाज अ सिंगल क्वेश्चन। सो 13 हो गए। अब कोई मुझे, दिस इज द ओनली इंफॉर्मेशन दैट आई हैव बीन एबल टू रिसीव फ्रॉम मेनी स्टूडेंट्स, that there was some question about gram negative and positive bacteria in which the answer was supposed to be of a gram positive bacteria. So I thought maybe it is they're talking about the Neisseria question, or maybe they're talking about the Campylobacteriosis question जिसमें they have said gram negative bacteria, but some of you said कि gram positive वाला option select करना था। Pharyngitis, किसी को अगर कुछ याद है then you can get back to us, otherwise डायरेक्ट क्वेश्चन तो हमारे पास नहीं आया है। Campylobacter jejuni, bloody stool, acid fast something, yes, so we have discussed na, nocardia we have discussed, then they said Zn stain, so did they say Zn stain positive or they said acid fast positive? Doesn't matter, कुछ भी बोला हो, कुछ भी बोला हो, they basically wanted to test you if you know the difference between actinomyces and nocardia. Orange tonsil, Zn stain positive. Thank you Bhumika, Dr. Bhumika, thanks a lot. ठीक है, mostly controversies have been settled. Orange tonsils, अच्छा, so आप लोग बोल रहे हो that there was some question on pharyngitis which they had mentioned orange tonsils. Biochem, okay, fine, I'll remove it. So up till now I can gather that there was no such question on gram negative, gram positive. Okay, so we'll remove this. So 13 questions we've been able to figure out. Thank you so much guys, you've been really helpful, बहुत अच्छा feedback आया. So and mostly questions I think you were able to crack, है ना? PYT से था पूरा माइक्रो, बट बहुत स्मार्टली दे हैड फ्रेम्ड द क्वेश्चंस. सो ऑल द बेस्ट फॉर द रिजल्ट, सब कुछ बहुत अच्छा होने वाला है. बढ़िया, ओके, थैंक्स, थैंक यू गाइस, थैंक यू. सो ओवर टू द नेक्स्ट फैकल्टी.
All right, hi guys, let's get started with the pharmacology recall. So roughly we got around 21, 22 questions from pharmacology. And since this is a quick recall, at any point of time, if you feel that this question was not there or the option was slightly changed, please feel free to let me know what was the question that was asked. So the first question that I got is about a female who is diagnosed with HIV at 34-week age of gestation. So she's getting diagnosed at this week. CD4 count is not done, but viral load is 1200. See, she is not on any antiretroviral drug, and the CD4 count is, I mean, the viral load is 1200. That means this is going to be actually a high risk mother. Any viral load more than 1000, it is considered as a high risk. She delivered a healthy baby 2.5 kg. What is the recommended prophylactic management? So we directly discussed this from our class also. We got this one. Nevirapine plus zidovudine is always given in a mother who is a high risk mother, and in any high risk mother when we are using this one, remember 12 weeks ke liye we are going to give 12 weeks nevirapine plus zidovudine, nevirapine plus zidovudine 12 weeks if the mother is going to give exclusive breastfed. So this was the question, that nevirapine plus zidovudine for 12 weeks within with the exclusive breastfed, that is going to be high risk mother. Mein we will be using these two drug combination. The two drug combination that we are going to use in a high risk mother has been explained here for all of you guys. Again, this is the lecture screenshot that we have. A patient with a history of episodic headache, palpitation, एंड हाइपरटेंशन डायग्नोज विद द फियोक्रोमोसाइटोमा, इमेजिंग पे भी कंफर्म हो गया. विच ऑफ द फॉलोइंग एजेंट इज यूज प्री ऑपरेटिवली. सो फियोक्रोमोसाइटोमा का ड्रग ऑफ चॉइस वी हैव कवर्ड इट ऑलरेडी हियर एज वेल, दैट इज गोइंग टू बी फेंटोलामिन. नाउ एट एनी पॉइंट ऑफ टाइम वंस अगेन आई एम टेलिंग यू व्हाट वाज द एक्चुअल क्वेश्चन दैट वाज आस्क्ड. अगर क्वेश्चन था इंट्रा ऑपरेटिवली पोस्ट ऑपरेटिवली दोनों को कंट्रोल करने के लिए, तो वी कैन इवन यूज बीटा ब्लॉकर, शॉर्ट एक्टिंग बीटा ब्लॉकर लाइक एस्मोलोल एज वेल. बट अगर क्वेश्चन का लैंग्वेज ऐसे था, देन रिमेंबर वी विल बी गोइंग अहेड विद द नॉन सेलेक्टिव बीटा ब्लॉकर. इट इज द non-selective beta blocker, non-selective alpha blocker that is going to be utilized here in this case scenario. So correct answer for this one is going to be phenoxybenzamine. What is the mechanism of action of P-glutticase? Screenshot of the lecture has been given here already. Remember, P-glutticase is a recombinant uric acid. They are going to convert uric acid to allantoin, that is a water-soluble metabolite. So question was like this, and option is like this. Inhibition of xanthine oxidase. So here the answer will be your allopurinol or febuxostat. तो वो ऑप्शन में है ही नहीं, वो क्वेश्चन पूछा ही नहीं. यूरेट 1 दैट इज गोइंग टू बी योर प्रोबेनेसिड लेसिनुराट, दैट वाज आल्सो नॉट देयर. ऑक्सीडेशन ऑफ uric acid to allantoin. So correct answer for this one is going to be option number C. They are utilized mainly for the chronic gout. So in one of the examination, examiner actually asked which of the following can be used in chronic gout. Same topic पे क्वेश्चन पूछा गया. Now previous year topic जितने भी क्वेश्चन मैंने आपको बताए हैं, ये सारे के सारे प्रीवियसली पूछे हुए क्वेश्चन है. दिस इज वन ऑफ द क्वेश्चन डायरेक्टली रिपीटेड फ्रॉम 2023 एफएमजी. ये वाला एफएमजी का रिपीट क्वेश्चन है, रिमेंबर दैट. फेंटोलामिन आल्सो हैज बीन आस्क्ड प्रीवियसली, फेनॉक्सीबेंजामिन हैज बीन आस्क्ड प्रीवियसली, राइट. फियोक्रोमोसाइटोमा का ड्रग ऑफ चॉइस हैज बीन मेंशन्ड हियर ऑलरेडी. देन वी हैव द नेक्स्ट वन दैट इज एलेंटोइन. आपका P-glutticase, rasburicase, that is going to be recombinant uric acid. 60-year-old CKD patient and presenting with the OPD with paleness, progressive dyspnea and signs of congestive cardiac failure. Okay, so if there is a severe anemia, there will be definitely congestive cardiac failure. In that case scenario, there is a pale, normocytic, normochromic, anemic patient. What is the most appropriate management? So we have to give epoetin या darbepoetin. The correct answer for this one is going to be darbepoetin. Parental infusion of iron can be done, but उस कंडीशन में आपका एक प्रॉपर गाइडलाइन है कि कितने हीमोग्लोबिन लेवल पे दोगे. यहाँ पे ऑलरेडी सीकेडी का पेशेंट है एंड ऑलरेडी द पेशेंट इज हैविंग हार्ट फेलियर का सिम्टम ऑलरेडी स्टार्ट हो चुका है. तो इन दैट केस सिनेरियो darbepoetin alpha will be given. This is the lecture screenshot already included along with this one. Next one is about a young patient with the emergency department, high grade fever, headache, nuchal rigidity. The meningitis के symptoms, meningitis के physical examination were positive like Kerning and Brudzinski sign. CSF analysis revealed high protein and gram stain shows gram negative diplococci. That is directly pointing towards your meningococcal meningitis. And meningococcal meningitis के लिए the drug that we'll be using among the given choices is going to be your rifampicin. Rifampicin के uses को अगर मैं देखूं तो I have discussed with all of you already that you can remember very easily by the simple mnemonic of burn lamp. Brucellosis, leprosy, ATT, meningitis like meningococcal, H influenza meningitis के prophylaxis के लिए we can utilize. So prophylaxis के लिए मैंने already लिखवा रखा है, we can use rifampicin in this case scenario. A patient with history of cough, breathing difficulty is on ipratropium and salbutamol already. On a metered dose inhaler, this is MDI is metered dose inhalers. At night the condition worsens. Okay, so night में condition worsen हो रहा है, that means she is taking which two drugs? Salbutamol, that is a short acting drug. And she is also taking ipratropium, that is also a short acting drug, right? Ipratropium is going to be SAMA and this is going to be your salbutamol is going to be SABA. Both of them are short acting. So prophylactically we have to add a longer acting. Among the given choices, if you are going to see, add long acting muscarinic agent. Muscarinic antagonist should be the better choice, but muscarinic agent दिया हुआ आगे पढ़ते हैं. Inhaled corticosteroid with salmeterol. तो salmeterol क्या है? Salmeterol is one of the LABA, long acting beta 2 agonist. LABA is something that can be added. और साथ में अगर inhaled corticosteroid है तो this is the best one that we are going to choose because inflammation को भी कम करना है, longer acting देना है. Because question था कि evening में at night the condition worsens, so you can give longer acting, साथ में steroid दे दिया तो right the condition will further improvise. Leukotriene receptor antagonist they can also be added, लेकिन ये later part में add करते हैं for the prophylaxis. Later part में in the step 2 step 3 में हम इसको add करते हैं. Remember that there is no point of increasing the dose of salbutamol because they are again going to be the shorter acting ones. This one again Bronchodilator में we, as I have given you here already, for the prophylaxis look at this salmeterol formoterol. तो अगर आपको याद होगा तो बार बार मैंने बोला भी था पहले भी कि ये क्वेश्चन, इस तरह के क्वेश्चन पहले भी आए हुए हैं और आएंगे। जब बोला था तो कोई ना कोई वजह था और वजह आपके सामने है। जीना गाइडलाइंस के अकॉर्डिंग एनी पेशेंट ऑफ मोर देन 12 ईयर्स, आप अगर उसको कंट्रोल करना चाहते हैं तो यूजुअली बोलते हैं कि स्टेप 1 में फॉर्मेट्रॉल प्लस जो है कि इनहेल्ड कॉर्टिकोस्टेरॉइड देंगे। बट सिंस फॉर्मेट्रॉल वाज नॉट इन द ऑप्शन, द अदर लॉन्गर एक्टिंग बीटा 2 agonist that we can utilize is going to be salmeterol. The correct answer for this one has been mentioned here for all of you, that is option number B. अगर मैं कोई कमेंट मिस कर रहा हूं तो लेट मी नो। फिल्ग्रास्टिम वाला भी क्वेश्चन हम देखेंगे। ग्रेनुलोसाइड स्टिमुलेंट होते हैं, अगर फिल्ग्रास्टिम ऑप्शन में था, दे आर द ग्रेनुलोसाइड स्टिमुलेंट्स। ठीक है, दिस वन ऑल्सो वी हैव डन। अ पेशेंट इज ऑन सब मेडिकेशन, कंप्लेंट्स ऑफ वायोलेशियस लीजन। नाउ सम ऑफ द स्टूडेंट्स सेड कि सर इसमें एक इमेज था। ठीक है, इमेज बेस्ड क्वेश्चन था, ओरल कैविटी एंड इज ऑन मेडिकेशन फ्रॉम द लास्ट 6 months. तो शी इज टेकिंग सम मेडिकेशन from last 6 months and he is having burning sensation, not she, I think gender mention nahi hai, to he or she, anything, right? So burning sensation on intake of spicy food. Which of the following medication is responsible for it? Now among the given choices, the one that itself is having high risk of causing burning sensation, इसको बोलते हैं BMS, burning mouth sensation syndrome. Burning mouth sensation syndrome, burning mouth sensation syndrome. This is mainly actually associated with the drug that is called your lithium. Among the given choices, the best drug that I'll be choosing will be your lithium, that is going to be associated with this case scenario. ठीक है, so mouth का image अगर दिया था, as rightly mentioned by Dr. Darshan, oral cavity purple patches. ठीक है, चलो मैं इसको ऐड कर दूंगा, जो आपके पास PDF आएगा उसमें इमेज ऐड होगा, इमेज ऐड करके मैं ये PDF आपके पास भेज दूंगा, ये वाला इमेज का। ठीक है, A female with history of severe eosinophilic asthma, she continues to have frequent exacerbation. तो बार बार एक्सर्वेशन हो रहा है, आस्मा का हिस्ट्री है, एंड शी वाज स्टार्टेड ऑन बेनरालिजुमाब। मैंने बार बार भी बोला था, पहले भी बोला था, बेनरालिजुमाब याद कर लो, ओ माई रेस्पिरेटरी सिस्टम, है ना। तो मैं एक ऑफलाइन में भी आपको बताता हूँ, ओ माई रेस्पिरेटरी सिस्टम, बेन, है ना, बेन से कुछ और आता है जो कि मैं बोल नहीं सकता, अब आप समझ सकते हो, है ना। तो ओ माई रेस्पिरेटरी, ओमालिजुमाब, मेपोलिजुमाब, रेस्लिजुमाब, ओ माई रेस्पिरेटरी सिस्टम, बेन, बेनरालिजुमाब, इंटरल्यूकिन 5, राइट, इंटरल्यूकिन 4। अब अगले एग्जाम में इन दोनों में से कोई होगा, नीचे वाले दोनों में से कोई एक होगा। इंटरल्यूकिन 4 इज द डी इज द फोर्थ लेटर, ड्यूपिलुमाब। 13 ट्रैलोकिनुमाब, TR ट्रैलोकिनुमाब से होगा 13 ट्रैलोकिनुमाब। सो करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी योर इंटरल्यूकिन 5। इंटरल्यूकिन 4 क्या होगा, ड्यूपिलुमाब। इंटरल्यूकिन 1 एनाकिनरा होता है, जो आस्मा में यूज नहीं करते हैं, आस्मा में यूज नहीं करते हैं, राइट। TNF अल्फा इनहिबिटर मैंने बताया था, आइस और आग दोनों का कॉम्बिनेशन बहुत ही खतरनाक होता है, शोला और शबनम एक साथ, आपको अच्छे से मैंने बताया था। ठीक है, ऑप्शन इज ओरल कॉर्टिकोस्टेरॉइड। लेट मी सी, किस क्वेश्चन की बात कर रहे हैं आप? आई थिंक आप इस क्वेश्चन की बात कर रहे हैं, एड इनहेल्ड कॉर्टिकोस्टेरॉइड विद साल्मेट्रोल। अगर एक ऑप्शन में ओरल है तो ओरल तो स्टेटस एस्मेटिकस के लिए बचा के रखते हैं ना यार। इस कंडीशन में पेशेंट को आप दोनों शॉर्ट एक्टिंग ड्रग दे रहे हो, वो करेस्पॉन्ड नहीं कर रही है। अगर मान लीजिए एक अदर ऑप्शन है, दैट इज यू आर गोइंग टू ऐड ओरल स्टेरॉइड, तो वो भी सही नहीं होगा। ओरल स्टेरॉइड अभी के लिए हम नहीं देंगे, बिकॉज दैट इज यूटिलाइज मेनली फॉर द स्टेटस एस्मेटिकस पेशेंट। ठीक है, ओरल स्टेरॉइड इज गोइंग टू यूटिलाइज फॉर द स्टेटस एस्मेटिकस पेशेंट। ठीक है, आगे चलेंगे। एट द गिवन इमेज विच ऑफ द फॉलोइंग साइट ऑफ एक्शन ऑफ एमियोड्रोन। तो एमियोड्रोन कौन से ग्रुप का ड्रग है, आपको कई बार बताया गया, दिस इज वन ऑफ द क्लास 3 एंटी एरिथमिक ड्रग। और ये तो रेगुलर क्लास के मैंने स्क्रीनशॉट डाले, मैं आपको बता रहा हूं, जब आप आरआर के नोट्स देखोगे उसमें से भी मोस्ट ऑफ द क्वेश्चन आपके आरआर नोट से भी मिल जाएंगे। और ये ड्रॉ करके आपको दिया गया, देखिए QT इंटरवल के प्रोलॉन्ग कर रहा है, और ये यूजुअली जो डॉटेड लाइन है वो ड्रग है। तो क्लास 3 एंटी एरिथमिक पोटेशियम चैनल ब्लॉकर, करेक्ट आंसर इज गोइंग टू बी योर 3। तो अगर इसमें कुछ और भी था, 3 रिपोलराइजेशन या 3 डिपोलराइजेशन फेज 0, तो करेक्ट आंसर पे अगर आपका नजर है तो बस नजर टिका के रखिए, है ना। मैं बोलता भी हूं कि दीदार की तलब है तो नजरें जमाए रखिए, राइट। तो नजरें जमा के रखिए, आपको आपका आंसर डेफिनेटली मिल जाना है। ठीक है, अगला क्वेश्चन है, अ पेशेंट विद हिस्ट्री ऑफ गर्ड विच ऑफ द फॉलोइंग इज प्रोकाइनेटिक। तो प्रोकाइनेटिक देखिए बहुत सारे 4-5 ड्रग मैंने बताया था, जैसे प्रूकालोप्राइड बताया था, प्रूकालोप्राइड प्रोकाइनेटिक, फिर मैंने बताया डोमपेडोन मेटोक्लोप्रोमाइड। तो पहले क्या आया था 2022 में भी 23 में भी सेम क्वेश्चन आया था कि विच ऑफ द फॉलोइंग प्रोकाइनेटिक एजेंट विल बी एसोसिएटेड विद एक्स्ट्रा पिरामिडल सिम्टम, दैट इज गोइंग टू बी मेटोक्लोप्रोमाइड। अमंग द गिवन चॉइसेस दैट वी हैव, मेटोक्लोप्रोमाइड इज द ओनली वन दैट इज गोइंग टू बी प्रोकाइनेटिक एजेंट। वोनोप्राज़ान, कीवर्प्रजान, टीकोप्रजान, प्रजान एग्जाम से पहले मैंने बार बार बोला था भाई ये नए क्लास के ड्रग हैं, या तो डायरेक्टली क्वेश्चन आएगा या इसके ऑप्शन में आएगा। तो अगर आपको पता है वोनुप्रजान क्या है, दे आर द पीकैप्स, पोटेशियम कम्पिटिटिव एसिड ब्लॉकर, दे आर लिटिल बिट सुपीरियर कंपेयर टू द पीपीआईस अकॉर्डिंग टू द स्टडीज दैट वी हैव, राइट। सो सुपीरियर इन मेनी टर्म्स, जो हमने क्लास में डिस्कस किया है वोनुप्रजान पीपीआई के कंपैरिजन में। ओमेप्राजोल, वोनुप्रजान, ये ओमेप्राजोल क्या है, दिस इज द प्रोटॉन पंप इनहिबिटर। मेगल्डरेट इज वन ऑफ द मैग्नीशियम और एल्यूमिनियम का, राइट। सो दिस इज गोइंग टू बी योर एंटासिड. This is going to be antacid. So they are not going to have a prokinetic property. Look at this, metoclopramide, domperidone, they are the D2 blocker, and D2 blocker को आप block करते हो तो acetylcholine activity will increase, and that will increase the motility, and also that will increase the tone. Why? Because the dopamine always is having inhibitory action, where dopamine has an inhibitory action on the acetylcholine, right? So that is about this question. ठीक है। स्टिमुलेटिंग गैस्ट्रिक एम्पटिंग, अगर वर्ड स्टिमुलेटिंग गैस्ट्रिक एम्पटिंग था तो उसका मतलब ही तो सेम हुआ ना बच्चे। स्टिमुलेटिंग गैस्ट्रिक एम्पटिंग अगर था तो उसका भी मतलब तो सेम ही होगा ना, उसका भी मतलब सेम ही था, ठीक है। दैट इज गोइंग टू इंक्रीज द मोटिलिटी। Next question, which of the following agent is preferred for the prevention of postpartum venous thromboembolism? So venous thromboembolism, this is also one of the previous year question. Anticoagulation pregnancy, पहले trimester में क्या करेंगे, 13 to 35 week में क्या करेंगे, we have covered this already. Look at this, we are going to use low molecular weight heparin, पहले कई बार पूछा जा चुका है। 12 to up to 12 week, 13 to 35 वारफरिन हमने दिया, and 30th 36th week में we are going to switch to low molecular weight heparin। फिर नीचे मैंने 2 लाइन लिखा हुआ देखिए हाईलाइट करके, 4 to 6 आवर हम हेपरिन वारफरिन दोनों पे रखेंगे, लेकिन ये हिस्ट्री था 3 दिन बाद। तो 3 दिन बाद क्या रखेंगे, वी आर गोइंग टू कीप द पेशेंट ऑन वारफरिन डायरेक्टली। एवरी लाइन दैट आई एम मेंशनिंग हियर हैज बीन ऑलरेडी डिस्कस इन योर क्लासेस, वारफरिन। और ना सिर्फ इसमें रेगुलर क्लास में, बट आपके जो रैपिड रिवीजन क्लासेस हैं या जो 4 घंटे का यूट्यूब वाला सेशन है, आप उसमें भी देखोगे, उसमें भी हमने इसको कवर किया है बहुत अच्छे से, ठीक है। सो दिस इज द स्क्रीनशॉट ऑफ द एंटीकोगुलेशन ड्यूरिंग प्रेगनेंसी, एक एक टॉपिक जो हमने डिस्कस किया था। देन फेब्राइल सीजर का क्वेश्चन था, तो आइदर वी नीड टू गिव इंट्रानेजल मिडाजोलाम। आई ट्राइड टू आस्क द स्टूडेंट कि वाज इंट्रानेजल मिडाजोलाम इन द ऑप्शन, इट वाज नॉट देयर। तो अमंग द गिवन चॉइसेस यू आर नॉट बी यूजिंग अदर अपार्ट फ्रॉम डायazepam. So diazepam will be utilized, immediate drug to utilize here is going to be diazepam. So either midazolam या diazepam is something that can be utilized, right? In this case of the febrile seizure. 40-year-old man newly diagnosed with HIV infection, presenting with the low-grade fever, productive cough, weight loss. Sputum, gene expert, it revealing Mycobacterium tuberculosis with rifampicin resistance. Okay, so rifampicin resistant को हम कैसे ट्रीट करते हैं? Even the rifampicin resistance is also treated as ड्रग रेजिस्टेंट टीबी। एमडीआर टीबी में अगर रिफाम्पिसिन रेजिस्टेंट है तो उसको भी हम ड्रग रेजिस्टेंट टीबी के फॉर्म में यूज करेंगे। ऑप्शन में जो बच्चों ने बताया कि सर 3 ड्रग सब ऑप्शन में थे, लाइक आइसोनाजिड, इथाम्बिटोल, पायराजिनामाइड, और या तो अमाइनोग्लाइकोसाइड देंगे, आइसोनाजिड, इथाम्बिटोल, पायराजिनामाइड, या लाइनेजोलिड देंगे। स्टार्ट कानामाइसिन बेस्ड MDR रेजिमेंट फॉर 20 मंथ। अगेन 20 मंथ वाला थेरापी अभी नहीं देंगे, 18 मंथ तो लॉन्गर रेजिमेंट। अगर इससे काम नहीं चलता, बीपाम से काम नहीं चलता है, तो हम यूज करेंगे। हमने अपने लेक्चर में जब दिया था, बीपाम उस समय पे नहीं था, बीपॉल था। बीपाम आई थिंक 4 या 5 महीना पहले ही आया है। तो जो हमारे अपडेटेड जो हिंदी वाला वर्जन है उसमें बीपाम अपडेटेड हो चुका है। बीपाम रेजिमेंट इज समथिंग दैट कैन बी यूटिलाइज फॉर योर ड्रग रेजिस्टेंट टीबी, ऑल्सो फॉर द pre-XDR TB and also for your IPD patient। मतलब अगर कोई IPD पेशेंट में आपको TB का दवा स्टार्ट करना है तो we can also utilize BPAM regimen। So you can easily see that we are going to give BPAM regimen because this patient is also having HIV, CD4 काउंट भी कम है। देन यू हैव टू मॉनिटर ऑन आइरिस ऑल्सो। तो आइरिस पे 2 क्वेश्चन आया हुआ था कि टीबी पेशेंट को HIV टीबी डायग्नोस हो रहा है साथ में, तो कौन सा दवा पहले दोगे, वो भी आया हुआ था। एंड दिस क्वेश्चन ऑल्सो, द करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी योर ऑप्शन नंबर A। Next is going to be a patient with history of type 2 diabetes mellitus, random blood sugar 500, sodium is 126, potassium is 4.3. Which of the following step is not used in the management? तो देखिए आपको 2 चीज ध्यान रखना है in a patient with the let's say diabetic ketoacidosis। आपको सबसे पहले IV जो फ्लूइड देना है, IV फ्लूइड आपको ध्यान में रखना है, हाइपोटोनिक IV सलाइन प्लस इंसुलिन, ये सबसे पहला चीज देना है। सेकेंड थिंग, यू आर गोइंग टू करेक्ट द इलेक्ट्रोलाइट इम्बैलेंस, correct the electrolyte, or third thing, you have to keep an eye on the potassium level, because when you give the insulin, right, when you give the insulin, hypokalemia is bound to happen. Abhi to potassium ठीक है, but you have to keep an eye on the potassium also. So IV fluid hypertonic यहाँ पे नहीं देंगे. We are going to give 0.9. So which is not used. The correct answer is going to be D. A lady with history of migraine started on sumatriptan. Okay, so sumatriptan, that is one of the drug that is going to be 5-HT1B by D agonist with no comorbidities, developing chest tightness and presenting with the family history of coronary artery disease. Now this is something very, very important. 24 का repeat question है ये, right? Even this question has been asked in 24 FMG also, same type of question. Which of the following agent will be preferred for the prophylaxis? Now you see in this case scenario, you will not be using naratriptan. Reason being, they are also the triptan. They are also one of the 5-HT1B by D agonists. And 1B by D agonist, what they do, they can always and always cause vasoconstriction, and they can always and always precipitate MI. They can always and always precipitate your coronary artery disease, yeah, any cardiac condition. Same like etoricoxib. Etoricoxib also will not be, etoricoxib to usually COX inhibitor hai, they are used for the pain, anti-inflammatory. So they should also not be utilized in this case scenario. Migraine वाले patient में यहाँ पे नहीं देंगे. Now हमारे पास दो ऑप्शन आता है, propranolol versus topiramate. क्या हम topiramate prophylaxis में यूज करते हैं? Yes. क्या topiramate का is there any contraindication in coronary artery disease? There is none. Propranolol, what is propranolol? Propranolol is a non-selective beta blocker. It's a non-selective beta blocker, and what we have learned about non-selective beta blocker, that this non-selective beta blocker, they are going to be contraindicated in bronchial asthma, they are going to be contraindicated in peripheral vascular disease, they are going to be contraindicated in diabetes mellitus, right? The peripheral vascular disease, इस patient को cardiac condition भी है, तो that is a peripheral vascular disease. We are not going to utilize, we are not going to prefer. तो प्रिफर, अगर प्रिफर के लिए पूछेगा जो इस पेशेंट को भी यूज कर सकते हैं, दैट इज गोइंग टू बी टोपिरामेट. टोपिरामेट विल बी प्रिफर्ड ओवर एनी अदर बिकॉज दे हैव गिवन ऑलरेडी द फैमिली हिस्ट्री ऑफ कोरोनरी आर्टरी डिजीज. एरगट भी फाइब्रोसिस कराता है. अगर एरगट ऑप्शन में है, इफ द ऑप्शन इज गोइंग टू हैव एरगट, they will also not be used. They are also associated with fibrosis and they are also associated with the vasoconstriction. वैसोकॉन्स्ट्रिक्टिव फाइब्रोसिस. तो एरगट अगर ऑप्शन में है तो भी नहीं देंगे. तो मान लीजिए इटोरिकॉक्सिब नहीं था तो भी कोई दिक्कत नहीं. इटोरिकॉक्सिब यूजुअली अगर आता है तो भी नहीं होगा, और एरगट था तो भी नहीं होगा. तो आपके ऑप्शन में जो पीडीएफ आपको मिलेगा वो एरगट के साथ पीडीएफ मिलेगा. एरगट अगर है तो भी नहीं देंगे. आई होप कि इट इज क्वाइट क्लियर विथ ऑल ऑफ यू गाइस. ठीक है, आंसर 2 होना चाहिए. नहीं, एमायोड्रॉन यूजुअली, अगर एमायोड्रॉन वाला क्वेश्चन पे आप दोबारा जाने के लिए बोले तो एमायोड्रॉन में यूजुअली देखिए जो 2 है, 2 का रीजन क्या है? 2 का रीजन पोटेशियम इन्फ्लक्स होता है और कैल्शियम इन्फ्लक्स होता है, पोटेशियम इन्फ्लक्स होता है. तो इसका रीजन यहाँ पे ऑलरेडी दिया भी होता है और स्टूडेंट ने बोला सर ये सेम इमेज एज इट इज आ गया था, रीजन भी दिया हुआ था. तो उस कंडीशन में मेनली जो हम पोटेशियम चैनल ब्लॉकर दे रहे हैं वो मेनली इस वाले एरिया पे ज्यादा काम कर रहा है, पोटेशियम इन्फ्लक्स वाले एरिया पे ज्यादा काम कर रहा है. ठीक है, नेक्स्ट इज अबाउट ये वाला क्वेश्चन देखिए अगेन लेक्चर का स्क्रीनशॉट. 5-HT1B by D agonist, they can precipitate the cardiac events contraindicated in cardiac patient. बार बार इसको आपको बताया गया है, इसलिए इस पेशेंट को हम क्या यूज करेंगे? दैट इज गोइंग टू बी योर टोपिरामेट. A patient with history of cough, weight loss, presented with the OPD, chest X-ray shows upper right lobe infiltrate and sputum is positive for acid fast bacilli. HIV पॉजिटिव पेशेंट है, व्हाट विल बी द प्रिफर्ड मैनेजमेंट? तो मैंने बताया था कि टू प्रिवेंट द आइरिस यू आर गोइंग टू स्टार्ट पहले क्या 2 हफ्ते के लिए ATT फॉलोड बाय ART. तो इन HIV प्लस TB स्टार्ट ATT फर्स्ट. लाइन बाय लाइन देखिए, 2 वीक प्रायर टू प्रिवेंट द आइरिस सिंड्रोम, इम्यून रिकॉन्स्टिट्यूशन, इन्फ्लेमेटरी सिंड्रोम. लास्ट ईयर में आया था, आई मीन FMG वाले में सेम टाइप का क्वेश्चन आया था, उसमें वर्ड दिया था क्यों साथ में नहीं देंगे, तो उसमें था टू प्रिवेंट द इम्यून रिलेटेड रिएक्शंस, ऐसे करके ऑप्शन में था. इस बार आपके सेम टॉपिक पे थोड़ा सा लैंग्वेज चेंज करके दे हैव गिवन हियर ऑलरेडी. सो वी आर गोइंग टू गिव विच वन? स्टार्ट ART आफ्टर 2 वीक्स ऑफ ATT, मतलब 2 हफ्ते का ATT पहले दे दीजिए, तब जाकर के आप ART दीजिए इस पेशेंट को. ठीक है, यू डू नॉट स्टार्ट 1 वीक का अंतर पे, यू डू नॉट स्टार्ट देम टुगेदर. ठीक है, डायबिटिक पेशेंट ऑन मेटफॉर्मिन, इजेक्शन फ्रैक्शन कम है, हार्ट फेलियर के फीचर आ रहे हैं, तो विच इज द बेस्ट ड्रग? देखिए मैंने बताया भी था कि आजकल एंडोक्रिनोलॉजिस्ट के पास जाओगे तो बेस्ट दवाई यही है, चाहे CKD का पेशेंट है, हार्ट फेलियर का पेशेंट है, डायबिटीज का है, तो द ड्रग दैट इज प्रिफर्ड नाउअडेज दैट इज गोइंग टू बी SGLT2 इनहिबिटर. मतलब वरदान का दूसरा नाम SGLT2 है डायबिटीज वाले पेशेंट में. तो आज के टाइम पे द प्रिफर्ड ड्रग इज गोइंग टू बी योर एम्पाग्लिफ्लोजिन विदाउट अ डाउट, दैट इज वन ऑफ द SGLT2 इनहिबिटर. इट इज एफिकेसी इज quite comparable to metformin and they are effective for heart failure also. तो heart failure का feature है, तो we are going to use empagliflozin. Another question that has been asked. Now this is one question that has created lot of controversy. टोपिरामेड किया, लेकिन ब्लॉकर तो नहीं होगा ना, टोपिरामेड ब्लॉकर ऑप्शन में तो नहीं होगा ना डॉक्टर. नाउ दिस इज वन क्वेश्चन जो था, a patient on chlorthalidone develops renal stone, what is the mechanism of stone formation? now अगर ये क्वेश्चन का ऑप्शन यही था, you guys can help it out here, क्योंकि देखिए chlorthalidone it's one of the thiazide derivative. मैंने क्वेश्चन मार्क इसलिए दिया because this is a you can say wrong recall, या ऑप्शन ठीक से नहीं है. अगर ऑप्शन यही था डिक्रीज ऑक्सलेट एक्सक्रीशन, इंक्रीज ऑक्सलेट, ऑक्सलेट पे ज्यादा असर नहीं होता है थायराइड का, ए डिक्रीज कैल्शियम एक्सक्रीशन, इंक्रीज कैल्शियम एक्सक्रीशन, तो क्या यही ऑप्शन में था, या क्या यही ऑप्शन में था डिक्रीज कैल्शियम एक्सक्रीशन? यूजुअली थायराइड इज मेनली गिवन टू, इट इज मेनली गोइंग टू प्रिफर्ड in patients with the history of, it is going to be preferred in patient with the history of renal stone. रीनल स्टोन वाले पेशेंट में या रिकरेंट रीनल स्टोन वाले पेशेंट है, उनमें हम इसको प्रिवेंट करने के लिए देते हैं, बिकॉज थायराइड्स व्हाट दे आर गोइंग टू डू, दे आर गोइंग टू इंक्रीज द कैल्शियम का रीएब्जॉर्प्शन एंड दे एक्चुअली डिक्रीज द एक्सक्रीशन, कैल्शियम के एक्सक्रीशन कम करते हैं. तो बेसिकली तो इसको जो डायरेटिक वाले जो पेशेंट होते हैं, लूप डायरेटिक जिसको दिया जाता है, उनमें रीनल स्टोन होता है, एंड इन दैट केस सिनेरियो वी आर गोइंग टू यूज दिस, वी आर गोइंग टू यूज दिस वन. तो एक बार देख लीजिए. Yes, I am looking at the comment. Decreased oxalate excretion was not there, it was citric acid. अगर citric acid वाला था, so do remember that will be the correct answer. क्योंकि देखिए डिक्रीज कैल्शियम एक्सक्रीशन ये करता है, डिक्रीज कैल्शियम एक्सक्रीशन की वजह से रीनल स्टोन तो नहीं होगा ना, कैल्शियम एक्सक्रीशन को डिक्रीज करता है, ये बात तो सही है. इंक्रीज कैल्शियम एक्सक्रीशन, इंक्रीज कैल्शियम एक्सक्रीशन करता ही नहीं है ये. इंक्रीज कैल्शियम एक्सक्रीशन इज अ फीचर ऑफ लूप डायरेटिक्स, राइट. तो अगर ऑप्शन आप थोड़ा सा बता देंगे तो सही हो जाएगा. कैल्शियम एक्सक्रीशन को कम करता है, बिल्कुल. मैंने बिल्कुल, आप जो बोल रहे हो योलो बोलो, आप जो बोल रहे हो मैं वही बोल रहा हूं. सिट्रेट ही था डिक्रीज, तो अगर सिट्रेट वाला ऑप्शन था देन डू रिमेंबर दैट वुड बी द करेक्ट. तो रिमेंबर इन सम पेशेंट इट हैज बीन फाउंड कि ड्यू टू इंक्रीज इन द लेवल ऑफ सिट्रेट, सिट्रेट के बढ़ने की वजह से देयर विल बी इंक्रीज इन द रिस्क ऑफ, सिट्रेट के बढ़ने की वजह से देयर विल बी इंक्रीज इन द रिस्क ऑफ renal stone due to altered pH of the urine, due to the altered pH of the urine, altered यूरिन पीएच. तो ये बहुत ही एक बोल सकते हैं पैराडॉक्सिकल कंडीशन है. यूजुअली तो आपको क्लास में ये पढ़ाया गया है कि दे आर गोइंग टू बी यूटिलाइज्ड इन अ पेशेंट विद हिस्ट्री ऑफ रीनल स्टोन, लेकिन यहां पे अगर सिट्रेट ऑप्शन में था, ऑक्सलेट ऑप्शन में नहीं था, देन वी कैन गो फॉर दैट. इंक्रीज इन द सिट्रेट अगर वो ऑप्शन में था, तो आई होप ऑल ऑफ यू गाइस हैव मार्क्ड दिस वन, बिकॉज सी और डी में नहीं हो सकता कोई भी ऑप्शन. सिट्रेट नहीं था, देखिए वही था मैं बता रहा हूं ना कि कम से कम 10-12 बच्चों से पर्सनली बात किया गया कि सिट्रेट था नहीं था, सिट्रेट नहीं था, जैसे बोला सिट्रेट नहीं था, डिक्रीज सिट्रेट था. देखिए योलो बोलो बोले डिक्रीज, जूही बोले सिट्रेट नहीं था. ठीक है. अब एनीवे ये थोड़ा सा क्वेश्चन ऐसा, इसलिए मैंने देखिए किसी भी क्वेश्चन मैंने क्वेश्चन मार्क नहीं लगाया था. इस क्वेश्चन मैंने क्वेश्चन मार्क लगाया बिकॉज आई फेल्ट ऑल्सो दिस इज अ रॉन्ग रिकॉल दैट रिक्वायर अ लिटिल बिट ऑफ मोर एक्सरसाइज. इस क्वेश्चन पे मैं बता रहा हूं हमें और चाहिए. डिक्रीज सिट्रेट था 100% श्योर. अगर डिक्रीज सिट्रेट एक्सक्रीशन तो इंक्रीज इन द सिट्रेट, फर्स्ट ऑप्शन सिट्रेट था. तो सिट्रेट वाला अगर आपने था, अगर आपने उसको सेलेक्ट किया है देन डेफिनेटली दैट विल बी द करेक्ट वन. अगर सिट्रेट आपने सेलेक्ट किया है तो मैं लिख दे रहा हूं सिट्रेट वाला सही है. सिट्रेट था तो वो वाला ऑप्शन अगर सेलेक्ट किया तो दैट इज वेल एंड गुड, दैट इज वेल एंड गुड. ठीक है, राइट. A patient with history of palpitation and chest discomfort presented in emergency. Now there are two things here. अब PS ECG is showing paroxysmal supraventricular tachycardia. Preferred drug for this case scenario. See, अगर PSVT, मैं दोनों बता दे रहा हूं क्या क्वेश्चन आया था, आप खुद सेलेक्ट कर लीजिएगा. अगर PSVT का एक्यूट इमरजेंसी में आ रहा है देन वी आर गोइंग टू प्रीफर एडिनोसिन, उसमें कोई डाउट नहीं है. लेकिन अगर क्वेश्चन में था कि इसके प्रोफाइलैक्सिस में क्या यूज करोगे, देन वी आर गोइंग टू यूज वेरापामिल. लॉन्ग टर्म के लिए हम वेरापामिल यूज करेंगे. तो क्वेश्चन में क्या था ये आप खुद ही जज हो ना, बेहतर जज हो, बिकॉज दिस इज रिकॉल. इसमें नॉलेज का कुछ मैं आपका ऑल्टरेशन नहीं कर रहा हूं, खुद आप जज हो. बताइए कि क्वेश्चन में क्या था. देखिए अगर इमरजेंसी में आ रहा है आई वुड गो अहेड विद दिस वन. verapamil, diltiazem, verapamil और diltiazem, दे आर द कैल्शियम चैनल ब्लॉकर। और एक और चीज मैं बता दूं, अगर इस पेशेंट को ब्रोंकियल आस्मा की हिस्ट्री थी तब उस कंडीशन में सिर्फ और सिर्फ कैल्शियम चैनल ब्लॉकर होगा। पीएसवीटी का ड्रग ऑफ चॉइस, रिमेंबर, ड्रग ऑफ चॉइस इन ब्रोंकियल आस्मा, इट इज ऑलवेज एंड ऑलवेज गोइंग टू बी कैल्शियम चैनल ब्लॉकर लाइक वेरापामिल और डिल्टियाजम। सो दिस वाज द प्रीवियस ईयर क्वेश्चन, ये पहले का क्वेश्चन है। अब इसमें क्वेश्चन क्या था, ओरल वेरापामिल था, प्रोफिलैक्सिस दिया था, योलो बोलो ने बोला ब्रोंकियल आस्मा था। ओके, सो अगर ब्रोंकियल आस्मा था तो डू रिमेंबर इन ब्रोंकियल आस्मा पेशेंट आंसर विल बी नन अदर देन डिल्टियाजम। और प्रोफाइलैक्सिस पूछा था इन ब्रोंकियल आस्मा फॉर प्रोफाइलैक्सिस, तो इसमें कंफर्म हो गया, इट इज गोइंग टू बी योर, है ना। तो इसके जस्ट पिछले वाले स्लाइड में जहां पे मैंने ये डिस्कस किया है एरिथमिया, इसके जस्ट पिछले वाले स्लाइड में मैंने वेरापामिल वाला ये इंफॉर्मेशन दिया हुआ है आपको, बिकॉज इट्स अ पीवाईक्यू, डू रिमेंबर दैट। आस्क फॉर प्रोफिलैक्सिस, अनडाउटेडली इट्स विल बी ए, दैट इज गोइंग टू बी डिल्टियाजम। ठीक है, प्रोप्रानोलॉल नहीं देंगे बिकॉज अगेन दिस नॉन सेलेक्टिव बीटा ब्लॉकर। अगर वेरापामिल था तो वो कर दो, कोई दिक्कत नहीं है, वेरापामिल कर दो, इट्स एब्सोल्युटली फाइन। वेरापामिल डिल्टियाजम दोनों ही नॉन डीएचपी से, ठीक है, आइदर ऑफ देम, दोनों था, दोनों में से जो होगा करेक्ट हो जाएगा। ठीक है, आदित्य तिवारी का आपका क्वेरी में ले लूंगा, डोंट वरी। पेशेंट ऑन क्रोनिक, लास्ट क्वेश्चन है, क्रोनिक हेलोपेरिडोल थेरेपी। हेलोपेरिडोल क्या है? इट्स वन ऑफ द टिपिकल एंटीसाइकोटिक्स, D2 ब्लॉकर, स्किज़ोफ्रेनिया प्रेजेंटिंग विद इनवॉलंटरी रिपीटेटिव मूवमेंट। घर वाले बोल रहे हैं कि ऐसा लग रहा है खरगोश के जैसा, तो उसको बोलते हैं पेरी ओरल ट्रेमर्स, या जिसको बोलते हैं रैबिट सिंड्रोम, जिस कंडीशन में वी आर गोइंग टू यूटिलाइज, है ना, VMAT2 इनहिबिटर, वेलबिनाजिन। करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी वेलबिनाजिन। इन दिस केस सिनेरियो वेलबिनाजिन इज द प्रिफर्ड वन, है ना। सो क्रोनिक थेरापी में दैट इज गोइंग टू बी वन ऑफ द एक्स्ट्रा पिरामिडल सिम्टम, जिसको हम टार्डिव डिस्काइनेशिया भी बोलते हैं, टार्डिव डिस्काइनेशिया, राइट, वी कैन यूटिलाइज वेलबिनाजिन। अगर ऑप्शन रॉन्ग है तो प्लीज फील फ्री टू करेक्ट मी, डॉक्टर भूमिका, राजेश, आई विल बी मोर देन हैप्पी टू करेक्ट द ऑप्शंस, राइट। ऑप्शन अगर गलत लग रहा है तो आप मुझे बता दीजिए। टार्डिव डिस्काइनेशिया में वेलबिनाजिन ऑप्शन में नहीं था, तो क्या था आप बता दीजिए, फिर क्विकली एक 60 सेकंड का रिकैप लेंगे, जो भी क्वेश्चन था हम लोग एक बार देख लेंगे, और साथ में आदित्य तिवारी का क्वेरी भी हम ले लेंगे, ठीक है। चलिए, एक्स्ट्रा पिरामिडल सिम्टम, लेट ऑनसेट एक्स्ट्रा पिरामिडल सिम्टम, टार्डिव डिस्काइनेशिया, वेलबिनाजिन इन दिस केस सिनेरियो, and in patient with the bronchial asthma for prophylaxis of PSVT we are going to use verapamil. In patient with the chlorthalidone, जो सिट्रेट वाला ऑप्शन था वो करेक्ट था। प्लीज आई वुड रिक्वेस्ट कि एक बार ऑप्शन को रिफ्रेम करिएगा, बिकॉज मुझे बच्चों ने बोला, मैंने कई बच्चों से पूछा और इसलिए मैंने इस पर क्वेश्चन मार्क लगा दिया कि दिस कुड नॉट बी करेक्ट ऑप्शन, ये हो ही नहीं सकता करेक्ट ऑप्शन, रिमेंबर, क्योंकि हमेशा हम थायराइड डायबिटीज को देते हैं इन पेशेंट विद हिस्ट्री ऑफ रीनल स्टोन। इट इज द लूप डायबिटिक दैट इंक्रीज द रिस्क ऑफ रीनल स्टोन, ठीक है। नेक्स्ट इज अबाउट डायबिटिक पेशेंट और हार्ट फेलियर का हिस्ट्री है, उसमें हम एम्पाग्लिफ्लोजिन SGLT2 इनहिबिटर दे रहे थे। HIV प्लस TB, यू ऑलवेज स्टार्ट 2 वीक प्रायर, आई मीन TB का दवाई 2 हफ्ते पहले स्टार्ट करें कंपेयर टू एंटी रेट्रोवायरल थेरेपी। और इन पेशेंट विद द कोरोनरी आर्टरी डिजीज यू शुड नॉट बी यूजिंग ट्रिप्टान्स, नॉन सेलेक्टिव बीटा ब्लॉकर आर आल्सो गोइंग टू बी कॉन्ट्राइंडिकेटेड। तो प्रीफर्ड अगर यही ऑप्शन थे तो आई वुड गो अहेड विद द टोपिरामेट। Type 2 diabetes mellitus, we are going to avoid IV 3%. There is no point of giving that. Other points are simply very correct. Then MDR TB regimen में अगर already rifampicin resistant है तो they are also going to be treated as a drug resistant TB. We are going to use BPAM regimen and monitor for iris. Febrile seizure में we are going to use diazepam. एंटीकोगुलेट ड्यूरिंग प्रेगनेंसी, पोस्टपार्टम देखिएगा यहाँ पे, पोस्टपार्टम वी आर गोइंग टू यूज 3 डेज का हिस्ट्री था, पोस्टपार्टम में वी आर गोइंग टू यूज वारफरीन। Next is going to be a patient with history of GERD, prokinetic agent इकलौता ऑप्शन में, that is going to be metoclopramide. And amiodarone का साइड अफेक्शन पूछा, that is going to be the repolarization phase और late repolarization phase 3 पे मेनली काम कर रहा है। इंटरल्यूकिन 5 is going to be benralizumab. लिथियम का वो जो इमेज वाला क्वेश्चन था, लिथियम is going to cause this burning sensation, burning mouth syndrome जो कराता है, ब्रोंकोडाइलेटर, स्टेरॉइड, जैसे मैंने बताया कि फॉर्मेट्रॉल along with the corticosteroid is going to be utilized in patient। शाम में उसको जो एक्सर्बेशन हो रहा था उस वाले क्वेश्चन के लिए। एंड रिफाम्पिसिन इज समथिंग दैट इज यूटिलाइज फॉर द प्रोफिलैक्सिस ऑफ मेनिंगोकोकल मेनिंजाइटिस। मैंने बताया था कि रिफाम्पिसिन, बर्न लैम्प इज द नेमोनिक, ऑलरेडी गिवन हियर, स्क्रीनशॉट भी मैंने इसके साथ लगा दिया। डार्बीपोटिन अल्फा फॉर द क्रोनिक एनीमिया इन CKD पेशेंट। And oxidation of uric acid, that is the mechanism of action of your your rasburicase, pegloticase. Phenoxybenzamine for your pheochromocytoma is going to be preferred. Now this was the question that is going to given. Now this information that we have taken is actually from the NACO guidelines, so usually 6 वीक के लिए हम देते हैं if there is no breastfeeding. मैंने लिखा दोनों ऑप्शन लिख दिया। ये देखिए पूरी बात मैं आपको क्लियर कर दे रहा हूं। हाई रिस्क मदर क्या है? हु इज अ हाई रिस्क मदर? दो लोग हैं हाई रिस्क मदर। एक, द मदर इज नॉट ऑन ART, तो सिंस शी ऑलरेडी डायग्नोस एट 34 वीक, तो दैट मीन्स पहले से दवाई नहीं ले रही थी, शी इज डायग्नोस एट द 34 वीक। एंड अगर जो वायरल लोड है, इफ द वायरल लोड इज गोइंग बियॉन्ड 1000, इन दोनों ही कंडीशन में, इस स्लाइड के जस्ट पिछले वाले स्लाइड पे मैंने इसको पूरा लिखा भी हुआ है, इस स्क्रीनशॉट में नहीं आ पाए, इन दोनों ही कंडीशन में वी आर गोइंग टू गिव अ कॉम्बिनेशन ऑफ नेविरापिन प्लस जीरोवुडिन, दिस इज गोइंग टू बी अ हाई रिस्क मदर। अब नेविरापिन जीरोवुडिन देना है तो कितने दिन के लिए देना, ये भी है। तो इसको हम आइदर देंगे 6 वीक के लिए और देंगे 12 वीक के लिए, डिपेंडिंग ऑन कि पेशेंट क्या कर रहा है। ब्रेस्ट फीडिंग में भी देयर इज लेस रिस्क, लेकिन रिस्क तो है। तो अगर ब्रेस्ट फेड है, अगर मान लीजिए ब्रेस्ट फेड है, देन इन दैट केस सिनारियो 12 वीक, और टॉप फीड है, देन इन दैट केस सिनारियो इट इज गोइंग टू बी 6 वीक। तो सिंप्लीफाई मैंने कर दिया आप सभी के लिए कि आप कैसे मैनेज करोगे इफ देयर इज अ हाई रिस्क मदर दैट इज कमिंग। ठीक है, ऑलराइट। So this was the one. Correct answer is going to be B. So this is everything about फार्माकोलॉजी रिकॉल। आई होप दैट यू गॉट मैक्सिमम करेक्ट। और मोस्ट ऑफ द क्वेश्चन जो मेरे पास आए, 23 क्वेश्चन आए थे, 22 क्वेश्चन आउट ऑफ दिस इज डायरेक्टली फ्रॉम द नोट्स, और सर रादर 23 आया था, 21 क्वेश्चन। दो क्वेश्चन जो थे, एक क्वेश्चन तो वो जो सिट्रेट वाला था, और दूसरा जो बर्निंग माउथ सिंड्रोम लिथियम वाला था, यूजुअली दैट वाज अनएक्सपेक्टेड। तो लिथियम वाला क्वेश्चन मैं खुद बोल रहा हूँ कि इट वाज नॉट डिस्कस्ड इन आवर लेक्चर, और यूजुअली वो ऐसा होता नहीं, काफी रेयर है जो लिथियम का बर्निंग माउथ सिंड्रोम होता है, काफी रेयर है। बट आउट ऑफ 23 क्वेश्चन, 21 डायरेक्टली फ्रॉम द नोट्स, और सबके स्क्रीनशॉट मैंने इसके साथ अटैच किए हैं। राइट, आप एंजॉय करिए बाकी के लेक्चर्स को। थैंक यू वेरी मच टू ऑल ऑफ यू। और मार्क्स और रैंक के बारे में देखिए, अभी समय भी नहीं है कि मैं इसके बारे में बात करूं, बिकॉज बाकी टीचर लोग रिकॉल के लिए वेट कर रहे हैं। तो हम लोग इसके बारे में किसी दूसरे सेक्शन में करें तो ज़्यादा बेहतर है। ठीक है, थैंक यू वेरी मच टू ऑल ऑफ यू।
So, hello guys. Just a quick thumbs up, audible and visible. So that was a very, very high yielding recall of pharmacology. So now let's start with the orthopedics. So this time orthopedics was full of clinical questions. So because it is a more of a clinical branch, probably they have asked more of clinical questions. And coming to limbs, always there is an integration with anatomy. So there were 3 or 4 questions which were integrated with anatomy, and few of them were tricky questions. So let's quickly recall all the questions and complete our session as early as possible. So the first question, guys, so this was the painless limb. Here the main clue which we have is the painless limb, right? So this painless limb and the x-ray was attached to it, and one more important clue which was given was an 8-year-old child. So this is the x-ray. So this is the X-ray, right? So X-ray, if this is the X-ray, undoubtedly the answer will be Perthes disease, right? So undoubtedly the answer will be Perthes disease. This is nothing but avascular necrosis of the femoral head. Okay. Yes, painless limb since 10 months. Okay, painless limb since 10 months was the question. Okay, fine. So first and foremost thing, usually painless limb can be there in DDH as well and your Perthes as well. Okay, but when it comes to your Skiffy and TB, it is usually painful. And when it comes to TB, there is other symptoms where the patient will have fever and all, low-grade fever and other symptoms are there, right? So if this is the X-ray and this is the avascular necrosis of the femoral head, and the answer would be Perthes. So painless limb, Perthes. Okay. Yes, marks. Oh, regarding marks, Rishabh sir has given a very good lecture before the starting of the session, so you can go back and watch that. Weakness in right arm and down needing 2 options. Okay, Dr. Nandini, I think your question is somewhat related to medicine as well. So we'll get through that also. So the first question, the answer would be Perthes. Okay. And coming to the second question. So this is one of the most important complications which we usually see, because as I keep telling in my lectures that TKR, that is total knee replacement, and total hip replacement, THR and TKR, that is arthroplasty department, has been a very, very important branch, right? So one of the most important complication what we usually encounter in this department is deep vein thrombosis, that is DVT. So that is why this question is put here. So if you see post-surgery, post-knee surgery, right, the patient has presented with sudden onset of chest pain and shortness of breath. So it is usually DVT that the thrombus is escaping and resulting in pulmonary embolism, right? And as you all know, the investigation of choice of this thromboembolism or pulmonary embolism is CT pulmonary angiography. So the answer for this particular question is this, CT pulmonary angiography. Yes, right? So far good. Two questions. One is Perthes, the second one is CTPA. I think you have all answered right, okay? Next, coming to the third question. Third question is again a complication. So if somebody is following, if any one of you are following our Telegram group, we have created a beautiful sessions only on the complications, right? So we have discussed all the complications there. So this was there, compartment syndrome, fat embolism was there, right? So all these questions were discussed in detail in that Telegram session. So what is the answer for this? This is very, very easy. Usually we keep telling in the class of ortho, that is whenever there is a fracture of the tibia and which is managed by analgesics and the patient now develops pain. So the first symptom is pain and it is not reduced by the analgesics, and now there is pain on stretch, that is on dorsiflexion and loss of sensation in the first web space. So what would be your management? So this is a purely clinical question. This is nothing but your compartment syndrome, right? Yes, guys, compartment syndrome. So what would be the answer for this? So the answer would be immediate fasciotomy, right? You have to shift the patient for the immediate fasciotomy, right? So this is the question of compartment syndrome. Again, a question on complication. Okay. Yes. Coming to the fourth question. A soccer player sustains an ankle injury while the foot is forcefully everted. Usually what happens is whenever we teach about the ankle injuries, we tell the most common ligament which is injured, right? So that is your anterior talofibular ligament, that is ATFL. But now what did they ask? They ask you whenever the foot is forcefully everted. So on the eversion, what happens is the injury usually occurs on the medial side. So medial side, what is there? Your deltoid ligament, right? Your deltoid ligament. So the answer for this would be your deltoid ligament, right? So the answer is deltoid ligament. Okay, so this is an integration with the anatomy. As I told you, whenever they ask you about the limbs, so they want to ask you something related to ankle injury and integrated with anatomy. So like these are the questions which we usually expect. Okay, any changes? So far, so good. Yes. So if it was inversion injury, then the answer would be A. Ravi Chaudhary, as you were answering for this, anterior talofibular ligament. If it was inversion injury, the answer would be ATFL, but here it is the eversion injury, so the answer is here deltoid ligament. Okay? Yes? Okay. Moving on to the next question. So this, I think Dr. Rishabh has already discussed regarding this, but this is one of the most favorite question again in orthopedics. What we see is a patient coming with chronic low back pain. And now we have taken an X-ray because that was the first investigation which we usually do. And on the radiological diagnosis, what we have found is this. So what you can see here, so you have to always draw a line along the posterior elements like this and along the anterior elements. So if you draw a line like this, you can see something called as the step sign, right? So this is a step sign. So this is nothing but forward protrusion of L4 over L5. So this is your L4 and this is your L5. So this is, sorry, L5 over S1. So this is your sacrum and this is your fifth lumbar vertebrae according to this X-ray. So this is nothing but your spondylolisthesis, right? Very good. So this is one of the most easiest questions. So spondylolisthesis is nothing but the forward protrusion. So forward protrusion, right? What is spondylosis? I think one of the option was spondylosis. Is that right? So spondylosis is nothing but just the degeneration of the spinal vertebrae, right? So whenever there is a forward protrusion, it is spondylolisthesis. Okay. Yes, that is the fifth question. We are done with it. And then coming to this question. So here I need the help of few of the students. So the where there were options, what they have given is, so most of the students have told me that the tenosynovitis was there, but image they couldn't recollect. So if the image is something like this, if you see something like this, so 4 conditions, one is the fusiform swelling, which is present, right? And the patient will have severe pain, tenderness, and now he has pain on stretch again. So pain on extension, right? Because of this pain and tenderness, what is there? Finger will be in flexion. Okay, if this is not the image. Okay, what was the question then? Edema of complete hand. But still, if the edema of the hand was also there, then oh, there was a line of demarcation, dry gangrene. Okay, then if it is just a finger, there is no blackish discoloration, then it would be tenosynovitis. But if there is some blackish discoloration present, right, and this could be gangrene. And I know you all know what is the difference between dry and wet gangrene. Dry gangrene is just the okay, all fingers are swollen and the color is changed. Okay, if there is a color discoloration, again, you have to think about gangrene. So dry gangrene is nothing but whenever there is a loss of blood supply. So blood supply is stopped, then it is dry gangrene. And when that is superseded by the infection, it is the wet gangrene. So this, I think we have to get a clear idea of it. So most of you think that the answer would be dry gangrene. Okay. Bluish black discoloration was there. So yes, if there is a bluish black discoloration, then it is definitely gangrene. It is definitely gangrene, no doubt in it. Then you have to see whether it is dry or wet. Again, dry is clearly demarcated, wet is not demarcated. Okay, line of demarcation was there. Okay, this is the one question we will get back again. So we'll see. Okay, if there was a laceration, again, this could be a gangrene again. Yes. The history said pressing upon the vessels. What happened? Okay, we'll get back to this question later. So what I want to try to say is if there is no blackish discoloration or any discoloration, the answer would be tenosynovitis. But if there is a mention of some discoloration, especially blackish discoloration, it would be gangrene. And if there is no clear demarcation, it is a wet gangrene. If it is a line of demarcation is there, it is a dry gangrene. So the image plays a very, very important role in this particular question. Okay. Yes, and I think this is again a one more easy question. So there was again a confusion between needle-shaped crystals and rhomboid-shaped crystals. So this particular question, whenever there is a rhomboid-shaped crystals with positive birefringence under polarized light, the answer is always pseudo-gout. Yes, the answer is pseudo-gout. And one more thing is it is seen in the joints like knee joints, larger joints, right? Whenever it comes to your gout, it is usually the first MTP. Here there are needle-shaped crystals and this is the rhomboid-shaped crystals, right? So maybe a few of them got confused because of the, usually we speak about the gout where that is a needle-shaped crystals, but pseudo-gout, it is a rhomboid-shaped crystals, and there is a positive birefringence. Okay, if it was Raynaud's would be only in the tips, and there will be various colors like the blue color, red and white. Yes, skin erosion was there and blackish discoloration. Yes, blackish discoloration again points towards your gangrene. Yes, that is what I want to tell you. Raynaud's is usually the tips, not the entire hand like. Okay, we'll discuss this question with the surgery faculty also. And what about this question? Eighth question. The question was mentioned about meralgia paresthetica. right? And now what they have asked you, again an integrated question with your anatomy, right? So they have asked you the root value, and now they have given the lateral part of thigh and nerve supply was asked. So this is the L2 and L3. So if you see, this is the lumbar plexus, and now for the lateral femoral cutaneous nerve, this is the supply. This is from the second lumbar and the third lumbar, right? Yes, dorsal division of L2 and L3, which supplies the lateral outer part of the thigh. And this is called the, whenever there is a compression of this particular lateral cutaneous part of the thigh, that results in what is called the meralgia parasthetica. So the answer here would be L2 and L3. Okay, the dorsal divisions of L2 and L3. Yes, Saha, you're right. Next one, I think this is again an medicine related question also. So here they have given you X-rays. So X-rays was showing lytic lesions, most of lytic lesions in the pelvis and the hip X-rays. And what is the most important clue we have? The head size seems to be increased over past years, and then there is an raised ALP. So every time in the class we would discuss that whenever there is an increased ALP, this is the one of the most important laboratory diagnosis for your Paget's disease. Yes, right. So the answer here would be Paget's disease. So because of some mutation, there would be sclerosis, and this sclerosis will result in increase in the head size. Ravi, don't worry about marking options A and C, because we don't put in that order of A, B, C, D. You just see the correct answer, whether you have marked Paget's disease or not. Okay, and this, the answer would be dorsal divisions of L2 and L3, right? Okay, yes. Then, yes, this is again an integrated question with anatomy. So here, why did I take up this question is usually this is a very rare phenomenon, and hyperextension causes this. So this is the hyperextension injury, where like rock climbing and all they do, and there will be a avulsion. Usually the avulsion will be at the olecranon process. Even if there is a triceps avulsion, usually at the olecranon process. But here they have asked you about specifically about the long head of the triceps, long head of triceps. So the attachment of long head of triceps is towards the infraglenoid tubercle. So the answer here would be your infraglenoid tubercle. Okay. So as you all know, triceps has 3 heads, and the long head of triceps is attached to the infraglenoid tubercle. So the answer is infraglenoid tubercle. Is that right? Yes. Same question. Yes. And finally, one of the most favorite questions, your ankylosing spondylitis. So they have told you a male patient coming with morning stiffness, which was improving later, but there was history of uveitis. So I always tell you this is an spondylitis, that is autoimmune disorder where other systems will also be involved, such as your eye, that is uveitis. And what would be the investigation of choice? First, usually we take the X-ray, and if you don't find anything in the X-ray for the early diagnosis, what is recommended? So what is recommended? The MRI. So we usually go for the MRI of the SI joint. So SI joint and the spine is one of the most important things which gets involved in your ankylosing spondylitis, one of the most important topics. So this is your favorite PYT, right? So this is your previous year topics. Yes, anterior uveitis is usually seen in your ankylosing spondylitis. Yes, what is the question was, as I came to know, they have given you the X-ray showed normal, but what is the investigation of choice for early diagnosis? So that was the question, right? So for early diagnosis, even though X-ray shows normal, because he has the symptoms of morning stiffness, which was improving and the uveitis was there, then we go MRI to confirm the diagnosis. So usually the investigation of choice would be MRI. Okay? Is that clear? Yeah. Usually what happens is in inflammatory disorders, what happens is as they as soon as they get up from the bed, they will have pain, and once they start moving their hands, or once they start doing the activity after 1 or 1.4 later, it will become better. Understood? So that is why they have given you specifically, it becomes better. That means it is somewhere related to the inflammatory arthritis. So this is an inflammatory arthritis which he was talking about, and they were more specific, told you that after 1.5 hours later the patient was feeling better. Okay, so the investigation of choice for early diagnostic is MRI, sacroiliac joint. Okay. And finally, the most important and direct question from whatever thing you take, marathon, your TND, your telegram sessions, everything. So this is one important question where everybody has to answer right. So that is your classical male patient and presenting with femur fracture. And then later he has the triad of symptoms, which is rash, confusion, that is respiratory, urological symptoms, and the rash, which is the triad of symptoms, and that will result in which syndrome? Yes, everybody has marked this right. This is your fat embolism syndrome. This never you can go wrong. Okay. So that is the question from the ortho. I think we are done with ortho. Anything if I have missed or anything? Oh, that one question. Yes, very good. So that one question of your tenosynovitis or wet or dry gangrene, we'll just make sure that we again discuss with few of the students and we'll find the correct image, and let's see, we'll come out with the correct answer. Otherwise, if anything else I have missed from ortho? How many questions were directly from my notes? Most of them were directly from the notes. Okay. Yes, we discussed the 5 terms of PIVD. Yes, most of them, see, direct questions were not there, but indirectly everything was there from the notes. Yes, during the PYQ series, we discussed that PIVD. Very good. Oh, Rocky, we'll meet again. Still, you're in second year. Enjoy your second year. Then we'll see you later. Okay. Okay, then, not wasting much of your time. Thank you so much, guys. And I hope you have all done really well from ortho point of view. See you all at the results time. Okay, bye.
Hello everyone, very good evening to all of you. So proceeding on with the recall, अब हम लोग आ चुके हैं into ENT. What were the particular questions asked in ENT? And ENT was pretty straightforward this time. I got a collection of 12 questions that were directly or indirectly asked from your ENT subject, right? And most of the questions were clinically oriented. Most of the questions were not straightforward, but still they were easy questions that I would say. You could come out with those questions somehow if you have learned somewhere those topics before. Okay, so let's start doing about what were the exact questions that were asked in your ENT perspective and what were the options given. Okay, so the first question that was asked was a clinical question which was correlated with anatomy. So there were 2 anatomy related questions which were popping out in ENT as well. And this was about, they had marked a structure which was over here. Now this is something that I have already discussed in the chapter of vestibular schwannoma, where I discuss a very important tumor, right? And what is this structure? This is your jugular foramen, right? So in my lectures, I have told you what passes through the jugular foramen. So most of the times I have already told you that jugular foramen, 3 important nerves pass. They are 9th, 10th and 11th cranial nerve. The glossopharyngeal, the 10th nerve, the vagus, and 11th spinal axis. We have told you these 3 nerves pass through that, right? And the only nerve which is given over here which does not pass through, which is only going through the hypoglossal canal, is your hypoglossal nerve, right? So Vivek sir will come after me. Vivek sir class will be just after me. Okay. Okay. So the answer would be hypoglossal nerve, jugular foramen से क्या pass करता है? 9th, 10th or 11th cranial nerve. This you see in your anatomy as well. ठीक है? चलो. Let's move on to the next question. The next question was already discussed in your radiology segment. This was a kind of a correlate question between 2 departments, and they have asked you about 2 important things over here. If they have given you the white arrow, I always told you in my previous lecture also, जब मैंने radiology of ENT लिया था, and that time also I told you कि trachea के बगल में अगर कुछ भी काला काला marked है, that has to be the answer for pyriform sinus, right? So pyriform sinus, if they have marked over on the lower white arrow, if they have marked over on the upper one, then the answer would be vallicula. But I hope you got pyriform sinus as your answer, because नीचे वाले को they had asked as an option. This is a barium swallow AP view. And what do you see over here? This white arrow shows pyriform fossas bilaterally. which are empty spaces and they get filled with air. तो हम इस तरीके का देखते हैं. Okay, fine. So this answer would be pyriform fossa straight away without a doubt. Now let's coming to the audiogram question जो आपसे पूछा गया था, right? In the audiogram question, they had given some 27-year-old male presented with reduced hearing in the left ear. He denies tinnitus or vertigo. Audiogram shows the following finding, right? Now in the audiogram, they might have got red color also. तो जो red color का audiogram था वो normal था. Air conduction and bone conduction जो red color का दिया है that was normal. I told you in my lectures R for right, R for red. और दूसरा वाला blue is left ear. So this is blue. And what do you see? I told you a very very simple way in which you see an audiogram. जब मैंने आपको बताया था I told you कि अगर air conduction गिरता है और bone conduction normal होता है तो that is conductive hearing loss. That is conductive hearing loss. अगर air और bone दोनों साथ साथ गिरते हैं तो S for साथ साथ S for sensory neural. इसमें क्या दिख रहा है? इसमें में दिख रहा है कि bone conduction की जो लाइन है that is normal and the air conduction line is going on. So the answer would be conductive hearing loss of the left ear. क्योंकि only the air conduction is dropping down below 25 decibels. Bone conduction is normal. और सिर्फ air conduction अगर गिरता है तो कौन सा loss हुआ? It is conductive hearing loss. It is of left side. Why? Because it is blue in color. So the answer here would become left ear conductive hearing loss. Without a doubt. Okay, fine. तो इसी तरीके के कुछ options correlated होंगे, but this was a kind of an audiogram that was there. Okay, fine. So Rocky is saying, I've taken a lecture of acute otitis media. Thank you so much. Okay, so I hope you guys have gotten most of the things correct क्योंकि ये सारे questions हम कहीं ना कहीं lectures में पढ़ चुके हैं. This is something I've taught you many of the time. सभी ये straightforward questions हैं. अब ये question बहुत easy था. This was a very very simple question. एक 55-year-old male है who has got hypertension and type 2 diabetes mellitus की history presents with profuse posterior epistaxis that does not respond to packing. मतलब नेजल पैकिंग करी, रिस्पॉन्स नहीं आया. अब हम कौन सी आर्टरी लाइगेट करेंगे? आई टोल्ड यू वेरी वेरी सिंपल, एक ही ऑपरेशन हम लोग करते हैं, which is there inside the nose, which is to ligate the artery of epistaxis. What is the artery of epistaxis? It is sphenopalatine artery, right? Sphenopalatine artery is the longest artery. It is the artery of epistaxis. तभी sphenopalatine artery is the right answer. Okay, fine. So this we have already discussed, and what do we call that? We call it as transnasal endoscopic sphenopalatine artery ligation, या फिर इसे हम TESPAL कहते हैं. Correct? This we have already discussed. तो यही आर्टरी होगी, and this is what will be the answer in your epistaxis question. Straightforward, और कोई आंसर नहीं है इसमें. Okay, चलो अब आते हैं नेक्स्ट पे. इसमें बहुत सारी कंफ्यूजन हुई. Most of the people. So Dr. Nandri is asking right का था. See, if it is red in color, it is right. If it is blue in color, it is left. What I got as an option from most of the people was कि blue color का audiogram में 25 decibel के नीचे conductive hearing loss दिख रहा था. So that is right. If it is blue, then it is right. Then it is left. If it is red, then it is right. But answer is conductive hearing loss because there is only a loss of air conduction. Okay, so that depends upon कि क्या question था. बस ये याद रखो, color के difference से you can come out कि right था कि left था. ओके, अब आते हैं कि इन्होंने ये वाला क्वेश्चन पूछा है. दे हैव गिवन यू द इमेज एंड दे हैव मेड इनटू अ स्टोमा ओवर हियर, राइट? एंड व्हाट एग्जैक्टली इज दिस स्टोमा ऑल अबाउट? अब बहुत लोगों ने इसमें गलती ये करी है. दे हैव एक्चुअली रिटन इट एज अ स्टैंडर्ड ट्रिक्योस्टमी, बट ट्रिक्योस्टमी में हम परमानेंट स्टोमा नहीं बनाते. दिस इज अ परमानेंट स्टोमा. एंड वेयर डिड आई टेल यू दिस, राइट? सो आई टोल्ड यू मेनी टाइम्स कि अगर ये स्ट्रेट फॉरवर्ड परमानेंट स्टोमा दिखता है, I have named it also as a permanent stoma in your lectures when I taught you about malignancy of larynx. This is malignancy of larynx की surgery and this is called as total laryngectomy. So in total laryngectomy we remove the whole of the larynx और trachea को हम suture कर देते हैं at the skin. That is why it forms a permanent stoma. So the answer here would be without a doubt total laryngectomy. It is not tracheostomy. उसे permanent stoma नहीं बनता. The stoma closes after the surgery is done. Okay, so this answer would be total laryngectomy, and this incision that they give is called as Gluck-Sorensen incision, right? We called it as Gluck-Sorensen incision. That is what is the incision name for total laryngectomy. Okay, fine. चलो अब आते हैं next question पे. Next question आता है फिर से anatomy पे, where they gave you a dissection of two important muscles, right? उसमें उन्होंने क्या बोला था? They had given you, I think, anterior belly and posterior belly of the digastric, right? So they had given you or marked over these two. So they must have marked over the anterior belly and the posterior belly of the digastric. और उसमें से उन्होंने एक क्वेश्चन पूछा था कि इन दोनों मसल्स की ब्लड नर्व सप्लाई कौन सी होती है? What is supplying the anterior belly? what is supplying the posterior belly, and they must have given you some kind of options like this, जिसमें दो nerve की mix and match options थे, right? Now what would be the right answer among them? अब ये बात हम लोग बहुत बार डिस्कस कर चुके हैं. In your laryngeal anatomy, in your muscles of larynx, I have discussed this in detail, जहां पे मैंने ये डायग्राम बना के आपको दिखाया है, that the anterior belly of the digastric is supplied by the mylohyoid nerve, which is a branch of V3 division of trigeminal nerve. And the posterior belly of digastric is a direct supply of the digastric branch of the seventh nerve or the facial nerve. तो ये स्ट्रेट फॉरवर्ड हमने पढ़ा है. दिस इज एग्जैक्टली द वे दे हैव आस्क्ड. दैट्स व्हाई आई वोंट रिगार्ड इट एज अ वेरी डिफिकल्ट क्वेश्चन. अगर आपने इसमें नर्व टू माइलोहायोइड एंड फेशियल नर्व मेंशन किया है एज एंटीरियर बेली एंड पोस्टीरियर बेली सप्लाई, देन इट वुड बी द राइट आंसर. ओके फाइन. सो दिस इज इट. अब बहुत लोग कह रहे हैं कि स्टोमा वाज सीन. यस, तो स्टोमा का जो आया होगा उसमें रेड कलर का कुछ लगा होगा, तो दैट इज द परमानेंट स्टोमा. डोंट कंफ्यूज, दैट वुड बी द परमानेंट स्टोमा और आंसर लैरिंजेक्टमी ही है. ओके फाइन, कोई प्रॉब्लम नहीं. अगर आंसर सर्वाइकलिस भी दिया है, दैट्स नॉट अ प्रॉब्लम. आंसर इसका माइलोहायोइड नर्व और फेशियल नर्व है. That's all you should remember about the right things what you have been asked. Okay, चलो अब आगे आते हैं into the next question. Now they have asked about a pathology related question with ENT where they have given about a CP angle tumor या cerebellopontine angle tumor and they showed about the HPE. HPE में दिखती है Verroque bodies with Antony A and Antony B cells. ओके, सो एंटोनी ए एंटोनी बी वेरोके बॉडी कौन से सेरेब्रोपोंटाइन एंगल ट्यूमर में आती है? एक ही ट्यूमर है और इसके बारे में हम लोग अपने वेस्टिबुलर शॉनोमा लेक्चर में पढ़ चुके हैं. आई टोल्ड यू वेरोके बॉडीज आर साइटोप्लाज्मिक प्रोसेसेस व्हिच आर सीन. तो ये जो एम्प्टी स्पेसेस हैं, दीज आर द साइटोप्लाज्मिक प्रोसेसेस व्हिच आर कॉल्ड एज वेरोके बॉडीज. एंड एंटोनी ए एंड एंटोनी बी सेल्स आर द बेसिक श्वान सेल्स. जब बहुत डेंसली पैक्ड होते हैं वी कॉल इट एज एंटोनी ए, व्हेन दे आर स्पार्सली पैक्ड इट इज कॉल्ड एज एंटोनी बी. And all of them are classical features of one important cerebellopontine angle tumor, which is called as vestibular schwannoma. So the answer of this tumor, which has got all the three, is vestibular schwannoma. Okay, fine. So this is what exactly is the question all about. Ye same, I think Dr. Ranjit sir also would have discussed with you. Okay, chalo, very good. किसी ने तुक्का मारा हो, सही हो गया, वेरी गुड, बहुत बढ़िया. सो दैट मींस दैट यू हैड द डे टुडे. ओके, अब आते हैं नेक्स्ट क्वेश्चन पे. नेजल बोन फ्रैक्चर्स. नेजल बोन फ्रैक्चर में हमें यहां पे दिख रहा है दैट दिस इज अ नेजल बोन फ्रैक्चर. दे हैव आस्क्ड व्हाट फोर्सेप्स विल वी यूज in cases of fixation of this nasal bone fracture. अब this is a displaced fracture of the nasal bone, क्योंकि हम देख रहे हैं एक बोन और दूसरी बोन डिस्प्लेस होकर टूट गई है. What will we use in order to fix, right? जब हमने पढ़ा था, I have told you multiple times, दो फोर्सेप होती हैं जो हम यूज करते हैं, वॉल्शैम एंड एश फोर्सेप. वॉल्शैम फोर्सेप से नेजल बोन को हम फिक्सेट करते हैं, एश फोर्सेप से सेप्टल करेक्शन करते हैं, सेप्टम की ऊपर नीचे डिस्प्लेस फ्रैक्चर्स ऑफ द सेप्टम उनको करेक्ट करते हैं. सो व्हाट एग्जैक्टली will be the answer here? This is a nasal bone fracture what they have shown you. एक बोन दूसरी से डिस्प्लेस्ड है. So the answer here would be that you will use Walsham forceps. Walsham forceps will be the answer. अगर ये septal fracture होता then we would have used Ash's forceps, right? Lux forceps is the one which is used in biopsy. Answer नहीं है. Killian speculum is something to use in anterior rhinoscopy. That is also not the right answer. Okay, fine. So ये सारी चीजें is something that we have already discussed. One of the other things, right? Please provide the notes of the recorded video, sir. They have already gone for printing. Will be released in this month itself. Okay, so don't worry. They are going to come. Chalo. Now we come to the next question. Okay. तो ऐश अगर नहीं भी दिया तो ऑप्शन में, दैट इज नॉट अ प्रॉब्लम. अगर वॉल्शैम ऑप्शन में था, वॉल्शैम ही राइट आंसर है. दैट्स नॉट द प्रॉब्लम कि कौन सा ऑप्शन था, पर वॉल्शैम फोर्सेप इंपॉर्टेंट है, जो वो समझना है, दैट इज द राइट आंसर. अगर नेजल बोन फ्रैक्चर है तो वी हैव टू यूज वॉल्शैम फोर्सेप्स फॉर करेक्शन. ठीक है, चलो अब आते हैं नेक्स्ट क्वेश्चन पे. दिस इज ऑल्सो वेरी स्ट्रेट फॉरवर्ड क्वेश्चन, बट इसमें कंफ्यूजन किस बात की आई? नाउ दिस माइट नॉट बी द एग्जैक्ट टिम्पैनिक मेम्ब्रेन परफोरेशन जो उन्होंने दिखाया था, but what exactly the people have told is that they could not see anything. The tympanic membrane was completely gone. That means it is a subtotal perforation of pars tensa. What they had given is that this is a chronic ear discharge patient with hearing loss. But in the case they have not mentioned about कि ये foul smelling discharge है. They have not mentioned कि ये scanty discharge है. That means they have not mentioned any history of atticoantral disease. If they have not mentioned any history of atticoantral disease, तो mastoidectomy primary option से बाहर हो गया. That means this is a simple tubotympanic disease. अब अगर tubotympanic disease है, we do two surgeries in tubotympanic. One is myringoplasty, one is tympanoplasty. अब दोनों में से better option क्या है? What is the most common surgery that is done, right? So इनमें से better option I would say is a tympanoplasty over a meringoplasty. Why? Because there is a subtotal perforation of the pars tensa and ossicular reconstruction हमें करना पड़ता है in most of the cases. So when I told you that when you discover meringoplasty means that you only repair the tympanic membrane, tympanoplasty means repair the tympanic membrane with the ossicular reconstruction. That is what we have discussed in our lectures also. Correct? So here, the answer that would be better between tympanoplasty and meringoplasty would be a tympanoplasty rather than a plain meringoplasty because there is a subtotal perforation. So most of the time we do the ossicular reconstruction or we check over the ossicles and then do a tympanoplasty and then do a meringoplasty. अगर tympanoplasty नहीं था and अगर meringoplasty ही option में था, then meringoplasty would become the right answer. पर अगर दोनों options से meringoplasty plus tympanoplasty, then इनमें से better option is tympanoplasty. So अगर meringoplasty option था, tympano नहीं था, तो meringoplasty is the right answer क्योंकि we will graft the tympanic membrane and we don't care about the ossicles. Right? But mastoid exploration is not supposed to be the primary option. ओके फाइन, तो इतनी बात हमारी क्लियर हो गई. ठीक है, टिम्पेनोटमी नहीं हो सकता. टिम्पेनोटमी का मतलब होता है एंटरिंग इनटू द मिडिल ईयर टू चेक इफ देयर इज अ डिजीज और नॉट. सो टिम्पेनोटमी इज नॉट द राइट आंसर. ओके फाइन, चलो 30 डेसिबल लॉस था, देन इट इज डेफिनेटली मेरिंगोप्लास्टी इज द राइट आंसर क्योंकि 30 डेसिबल लॉस का मतलब है कि ऑसिकल्स आर नॉट अफेक्टेड. If 30 decibel loss was given, then ossicles reconstruction is only done after 40 decibel hearing loss. More than 40 decibel hearing loss. So if the hearing loss was less than 30 decibel, the primary option will become meringoplasty if tympanoplasty was not the option. Okay, fine. So here meringoplasty will be right. If tympanoplasty दिया नहीं तो meringoplasty will be right. ठीक है, चलो अब आते हैं नेक्स्ट पे. नेक्स्ट क्वेश्चन है about a 2-year-old child unconscious state came to the OPD with choking episodes and there is a history of peanut ingestion, right? तो peanut ingestion है and there is a history of choking. अब मैंने आपको हमेशा बताया whenever you get airway foreign body और उसमें choking होती है, so choking foreign bodies are laryngeal foreign bodies. ये मैंने आपको in your lectures also I have told you straight away. And I told you there is a maneuver that we do, it's called as Heimlich maneuver. But when it comes to children, we do something called as back blows या back thrust. So दोनों तरीके से laryngeal foreign body निकाली जा सकती है. One is giving an abdominal thrust and giving pressure over the upper abdomen. दूसरा way है that you give a back blow. But among these two, if you have a child who has been the treating source, so in children we don't give abdominal thrust, we primarily give back blows. So here the answer would become that you give back slaps or you give back blows. Okay, because in children you don't have a very well formed chest cage and that is why it could lead to trauma. ठीक है, अब इसमें कंफ्यूजन बहुत लोगों को यह था कि इसमें एंडोट्रेकियल इंट्यूबेशन दिया था, क्या हम करेंगे क्या हम नहीं करेंगे. इफ एक्सीडेंटली यू ट्राई टू इंट्यूबेट दिस पेशेंट, यू माइट शिफ्ट द फॉरेन बॉडी डाउन इनटू द लोअर ट्रैक. दैट इज मोर डेंजरस. ठीक है, तो ये चीज याद रखना, चेस्ट कंप्रेशन से कुछ नहीं होगा. चेस्ट अगर हम चेस्ट पे ऐसे कंप्रेस करेंगे दैट विल नॉट सफाइस. तो हमें बैक ब्लोज देने होंगे या बैक स्लैप देने होंगे इन ऑर्डर टू गेट द फॉरेन बॉडी आउट. दैट इज द वे इन विच वी टेक आउट फॉरेन बॉडीज विच आर इन द लैरिंग्स इन चिल्ड्रन. If it is an adult, we give abdominal thrust. Okay, fine. This is what about the foreign body in the laryngeal airway is all about. Okay, so here answer will become give the back slaps to the child and try to recover the airway. Chalo. अब आते हैं next question पे. Now next question was about a tuning fork test which was given to you, right? And in this tuning fork test, there was about a patient who was in the OPD with hearing loss. Now he had been exposed to loud sounds. The tuning fork revealed Renee's test to be negative on the left side. लेफ्ट साइड का रिनी वॉज नेगेटिव. नाउ लेफ्ट साइड का रिनी वॉज नेगेटिव का क्या मतलब है? दैट द बोन कंडक्शन वॉज मोर देन एयर कंडक्शन ऑन द लेफ्ट साइड. ओके, एंड द वेबर्स ऑल्सो वॉज लैटरलाइज्ड टू द लेफ्ट साइड. नाउ ऑलवेज रिमेंबर वन थिंग, व्हेन द रिनीज इज नेगेटिव, then what will happen? If the Renee's was negative, then that means the patient has conductive hearing loss. And Weber's always lateralizes to the worst side in conductive hearing loss. यही हमने देखा है. So in conductive hearing loss, that is what I have taught you. Weber's is lateralized to the worst side. Renee's में bone conduction is always more than air conduction if it is a conductive hearing loss. Okay, fine. So in cases if this is what they have given, the answer here would become that this patient is of left ear CHL or left ear conductive hearing loss. Okay, ये option नहीं था because this was something that I got from the people as about there was a question related to tuning fork test, and this was the options that were given by me from the students. If this was not there, then it would have been some kind of a modification, but more or less this is what I got from the feedback from students. Okay. Not a separate question, it was from the same audiogram. Then also उसमें answer left CHL ही था, because audiogram में भी left CHL था, tuning fork also would be left CHL. So if they were the same questions, then also the answer would be left conductive hearing loss. Okay, अगर ये question was a part of your audiometry question, then answer in both the cases is left conductive hearing loss. Okay, fine. चलो अब आते हैं. Unconscious patient ही दिया था. I know it is unconscious patients. That is why we'll go for a back slap in order to get the foreign body out. We can't intubate that patient क्योंकि आप foreign body को ज्यादा push कर देंगे. ठीक है. Up, there was a patient in his 20s presented with complaints of nasal obstruction and recurrent spontaneous epistaxis. This was a question. Okay, can you guys confirm me? Was this the question? Because there was a nasal mass that was given to you. There was some photograph of a nasal mass, and there was about nasal obstruction history. And I always told you an adolescent male with recurrent epistaxis. What is there? An adolescent male with recurrent epistaxis and nasal obstruction. We have dealt multiple times. The answer would be close your eyes. It is juvenile angiofibroma. Right? ये सारी चीजें हमने देखी हैं. तो juvenile angiofibroma is something where we have got recurrent spontaneous epistaxis, juvenile adolescent male, and there is nasal obstruction. Correct? So this is what we have done before also in our lectures also, that whenever it spreads, it causes nasal obstruction and profuse epistaxis. और एक ही चीज मैंने बार बार कही है, हमेशा 20s दी है. So it is an adolescent. So juvenile male epistaxis, it has to be angiofibroma. ठीक है? So here the answer would become straightforward, juvenile angiofibroma. That finishes my 12 questions, right? जो nasopharyngeal carcinoma 20 साल के लोगों में is not common. Okay, it has a bimodal age distribution, but more commonly it will be seen in cases of adults. Also in nasopharyngeal carcinoma, the primary option that they will give you will be cervical lymphadenopathy. So here epistaxis is the first feature seen in juvenile angiofibromas. So angiofibroma is the right answer. Fine. So I hope you guys have done ENT well. I hope to see you all onto the other side. Now I'll take forward to the other faculty, that is Dr. Vivek sir, to take the session on physiology. Thank you guys. All the best.
Thank you, sir. Physiology questions which I got this time. तो एक तो सारे क्वेश्चंस कॉन्सेप्चुअल थे और शायद किसी स्टारलिंग प्रेमी ने उसको कोलेट किया था, ऐसा लग रहा था. सारे क्वेश्चंस में कहीं ना कहीं या तो स्टारलिंग्स लॉ चाहिए था या फिर स्टारलिंग्स इक्विलिब्रियम चाहिए था, फ्लूइड डायनामिक्स. सो लेट्स सी द क्वेश्चंस एंड आप मुझे बता सकते हो कि कोई ऑप्शन अगर दूसरा ऑप्शन था या ऐसा कुछ. ये ग्राफ आया था एंड at which point would there be greatest tension developed? मतलब फोर्स टेंशन रिलेशनशिप का ग्राफ, नॉट फोर्स टेंशन, लेंथ टेंशन रिलेशनशिप का ग्राफ है. और अगर आपको याद होगा, नॉर्मल रेस्टिंग लेंथ ऑफ द सार्कोमेर इज 2 microns, and by Starling's law, if you stretch the muscle fiber, its length increases, initial length increases. 2.1 micron length will produce stronger contraction. And here at point C, 2.2 microns is called as optimal length that produces strongest possible muscle contraction or greatest tension development. तो क्या ये ग्राफ दिया था? ओके, 2.2 मैक्सिमम, करेक्ट. तो अगर जिसको भी ये स्टार्लिंग्स लॉ पता था और उसका एप्लीकेशन कि यहाँ पे लेंथ कम है or B is the normal resting length, and when it increases and sarcomere length becomes 2.2 microns, that is the application of Starling's law. And beyond that point आप देख सकते हो D में actin myosin overlap has been lost completely, तो फिर contraction strength will become weak after that. Right. A student went to the next question. देखो सीधा पूछना चाहिए कि acute mountain sickness में cerebral edema क्यों होता है, तो वो थोड़ा स्टोरी डेवलप करते हैं. स्टूडेंट went from Delhi to Leh, मतलब कि माउंटेन्स में गया या लो बैरोमेट्रिक प्रेशर वाली सिचुएशन में गया, तो cerebral edema develop हुआ, which of the following is the cause for this? What was the question? Anyways, यही क्वेश्चन था, शायद बहुत सारे लोगों ने दिल्ली टू ले ये याद रखा था. तो अगर एक्यूट माउंटेन सिकनेस का कॉज पूछा गया है एंड ऑप्शंस, दो ही ऑप्शंस बहुत सारे लोगों ने रिकॉल कर सके, वेजोडाइलेशन एंड ट्रांसुडेशन ऑफ फ्लूइड्स, वेजोकॉन्स्ट्रिक्शन एंड ट्रांसुडेशन ऑफ फ्लूइड्स. एनी अदर? अच्छा, फर्स्ट का आंसर पूछ रहे हैं, फर्स्ट का आंसर मुकेश जी पूछ रहे, तो उसका आंसर सी था, पॉइंट सी, वेयर sarcomere length is 2.2 microns and that will produce strongest tension, maximum tension. Okay, so dream finisher कह रहे during flight he develops symptoms. ठीक है, anyways, so hypoxia causes vasodilation everywhere in the body except in the lungs. तो acute pulmonary edema होता है, acute cerebral edema होता है, दोनों जगह कारण अलग अलग है. लंग्स में वेजोकॉन्स्ट्रिक्शन करता है hypoxia, लेकिन cerebral vasodilation and therefore again increased hydrostatic pressure in the cerebral vessels resulting in the transudation of fluids. वो स्टार्लिंग्स इक्विलिब्रियम जिसने भी पढ़ा उसको ये 3-4 क्वेश्चंस, मतलब जो हमें मिले 3-4 क्वेश्चंस बेस्ड ऑन द स्टार्लिंग्स इक्विलिब्रियम, वो आसानी से सॉल्व कर सकता था. हाइपोक्सिया एंड सेरेब्रल वेजोडाइलेशन और इंक्रीज H प्लस वेजोडाइलेशन या डिक्रीज O2. करेक्ट, डिक्रीज O2 एंड वेजोडाइलेशन ऐसा ऑप्शन था, ऐसा अंबाड़ा कह रहे हैं. ओके, सो हाइपोक्सिया, vasodilation and transudation of fluids. And as I mentioned, why? Because of increased capillary hydrostatic pressure, more blood flowing and therefore leakage of fluid resulting in this cerebral edema. अच्छा, ये next question है. इसका ग्राफ बहुत सारे स्टूडेंट्स को याद नहीं आ रहा था, तो मैंने अंदाजे से ये ग्राफ निकाला है, शायद ऐसा ही कुछ ग्राफ रहा होगा. A physiology experiment records a graph of muscle contraction in response to increasing frequency of stimulation. So at which point on the graph there will be maximum force of contraction? Anybody remembers this graph or something similar to this graph? पहले सिंगल कॉन्ट्रैक्शन दिखाया है, फिर थोड़ा सा समेशन इफेक्ट, बेनिफिशियल इफेक्ट दिखाया है, उसके बाद फिर टिटैनिक फ्यूजन हुआ है, मतलब फ्यूजन ऑफ कॉन्ट्रैक्शंस दिखाया. तो ऑब्वियसली क्वेश्चन वाज मैक्सिमम फोर्स ऑफ कॉन्ट्रैक्शन किस में होगा, सिंगल ट्विच में होगा, अनफ्यूज्ड टिटेनस, फ्यूज्ड टिटेनस या मसल फटीग. एंड द आंसर इज फ्यूज्ड टिटेनस. अगर ये ऑप्शंस थे तो डॉक्टर श्रैना कह रहे हैं कि नो, ऐसा क्वेश्चन नहीं था या ग्राफ ये नहीं था, और समवॉट सिमिलर, नो सच क्वेश्चन कह रहे हैं. नॉट अ क्वेश्चन दर्शन जी. ओके फाइन. ओके नेक्स्ट, ये एक बहुत सारे स्टूडेंट्स ने बताया कि ऐसा कोई ग्राफ था ऑन वेंटिलेशन परफ्यूजन रिलेशनशिप. तो ग्राफ ऑफ वेंटिलेशन परफ्यूजन रेशियो which point indicates complete obstruction of the pulmonary blood flow. पल्मोनरी एम्बोलिज्म से पल्मोनरी ब्लड फ्लो कंप्लीटली स्टॉप हो गया है एक रीजन में, तो कौन से पॉइंट पे वो होगा? पहले मुझे ये बताओ कि लेफ्ट साइड का ग्राफ था कि राइट साइड का ग्राफ था. पहले तो ये बताओ कि ये क्वेश्चन याद आ रहा है आपको, क्योंकि बहुत सारे स्टूडेंट्स ने इसको रिकॉल किया है. वेंटिलेशन परफ्यूजन रिलेशनशिप का कोई ग्राफ दिया था, तो लेफ्ट वाला कि राइट वाला? फर्स्ट वन, लेफ्ट वाला. ओके गुड. तो यहां पे आप देख सकते हो वेंटिलेशन परफ्यूजन रिलेशनशिप में अगर किसी रीजन में पल्मोनरी एम्बोलिज्म से ब्लड फ्लो स्टॉप हो गया है तो वेंटिलेशन है लेकिन परफ्यूजन इज जीरो इन दैट रीजन. दैट मींस वेंटिलेशन परफ्यूजन रेशियो विल बी, अगर डिनोमिनेटर जीरो है तो रेशियो विल बी इनफाइनाइट. और इसलिए ये ग्राफ है जो यहां पे दिखा रहे हैं, उसमें दिस पॉइंट corresponds to the ventilation perfusion ratio to be infinity, क्योंकि यहां पे उन्होंने दिखाया PO2 जो है वो मैक्सिमम पहुंच गया है. Why PaO2 is maximum? क्योंकि ब्लड फ्लो नहीं है तो अल्वियोलाई में ऑक्सीजन बचा हुआ है और उसकी वजह से उसका PO2 जो है वो मैक्सिमम पहुंच गया है. एंड दैट्स व्हाट शोन ऑन द हॉरिजॉन्टल एक्सिस PO2. एंड वर्सेस PCO2, क्योंकि ब्लड फ्लो नहीं है तो ब्लड में से अल्व्यूलस में कोई कार्बन डाइऑक्साइड नहीं आ पा रहा है, तो वहां पे PCO2 0 हो गया और PO2 मैक्सिमम हो गया at this point, and that point indicates pulmonary embolism and lack of blood flow. Right, infinity पे है ये point, and therefore that was the answer. Next, अब ये 2-3 क्वेश्चंस शायद अलग थे या शायद एक ही क्वेश्चन था, लोगों ने अलग अलग उसको रिकॉल किया. लेट्स चेक इट आउट. In a capillary fluid exchange experiment, the following pressures are measured. Capillary hydrostatic pressure 18. Now this is based on the Starling's equilibrium. You know, capillary hydrostatic pressure. Okay, 18 mm of Hg. Capillary oncotic pressure 23 and interstitial fluid oncotic pressure 7. तो अभी इसमें capillary hydrostatic pressure is a force that favors the filtration, and interstitial fluid oncotic pressure that also favors the filtration, क्योंकि वो खींचेगा वाटर को बाहर, कैपिलरी के अपने तरफ खींचेगा कैपिलरी से बाहर. तो ये दोनों प्रेशर फेवर कर रहे हैं. 18 + 7 25 and capillary oncotic pressure was 23 mm of Hg. So if the net filtration is known to be 0, what is the interstitial hydrostatic pressure? Interstitial hydrostatic pressure is opposing filtration. तो वो कितना होगा जो इसमें आप ऐड करोगे कैपिलरी oncotic pressure में, तो वो दोनों फोर्सेस, मतलब फ्लूइड पुश आउट करने वाले और फ्लूइड को वापस कैपिलरी में खींचने वाले, वो इक्वल हो जाएंगे. यस, अच्छा 27 दिया था. 27 mm of Hg वाला भी एक क्वेश्चन कुछ स्टूडेंट्स ने रिकॉल किया है, वो भी देखते हैं. लेकिन फिलहाल यस, द आंसर विल बी -2 बिकॉज इफ यू सी द प्रेशर्स एंड कैलकुलेट देम, यस इसका आंसर -2 आ रहा है. अरे 18 + 7, द फोर्सेस दैट फेवर द फिल्ट्रेशन. पहले तो 27 था कि 23 था, जरा वो रिकॉल कर दो सो दैट वी कैन. दर्शन जी कह रहे 27 था. If we take it as 27, in that case, capillary oncotic pressure is a force that is opposing the filtration, वो 27, और फेवर करने वाले 18 + 7 25. तो इसका मतलब बचा हुआ प्रेशर जो है वो इंटरस्टिशियल फ्लूइड हाइड्रोस्टैटिक प्रेशर होगा. वो कितना होगा? -2 होगा वो, क्योंकि तब जाके ये इन दोनों का इक्विलिब्रियम होगा एंड देयर विल बी नो नेट फिल्ट्रेशन. -4 वाज नॉट इन द ऑप्शन. ओके, और ये 27 था. ओके, सो आई विल जस्ट करेक्ट इट एंड ऑफ कोर्स देन इट विल बी -2, क्योंकि बाकी जो दो प्रेशर है 18 + 7 25 है, और ये जो है अकेला प्रेशर अगर 27 था कैपिलरी ऑन्कोटिक प्रेशर, तो 27 -2 विल बी 25 इन दोनों का एडिशन. सो यस, आंसर विल बी -2. ओके, आई विल मेक द करेक्शन हियर 27. यू अंडरस्टूड द कॉन्सेप्ट ना. दो प्रेशर्स जो है फेवर करते हैं फिल्ट्रेशन को, दो प्रेशर जो है वो अपोज करते हैं, और फिर आपको उसके हिसाब से कैलकुलेट करना था बचा हुआ प्रेशर. 3 प्रेशर्स आपको दिए हैं और चौथा बस कैलकुलेट करना था. ओके, ये क्वेश्चन बताया गया, कुछ स्टूडेंट्स ने रिकॉल किया. व्हाट इज द टिपिकल वैल्यू ऑफ इंटरस्टिशियल हाइड्रोस्टैटिक प्रेशर इन मोस्ट टिश्यूज अंडर नॉर्मल फिजियोलॉजिकल कंडीशंस? Was that a question like this? मतलब उन्होंने पहले एक थोड़ी 2 लाइन की स्टोरी बताई थी कि कुछ एक्सपेरिमेंट चल रहा है, ये है वो है, और उसके बाद ये पूछा गया है व्हाट इज द टिपिकल वैल्यू ऑफ इंटरस्टिशियल हाइड्रोस्टैटिक प्रेशर इन मोस्ट टिश्यूज अंडर नॉर्मल फिजियोलॉजिकल कंडीशंस. ओके, मतलब ये क्वेश्चन फिर से वही वाला क्वेश्चन है, पीछे वाला क्वेश्चन -2 वाला, क्योंकि इसमें भी ऑप्शंस -2 है, ऐसा बहुत सारे स्टूडेंट्स ने बताया. फाइन, नेक्स्ट क्वेश्चन. आई होप दिस क्वेश्चन वॉज देयर एटलीस्ट, क्योंकि ये भी उसी से रिलेटेड है. सेम, इन अ रीनल फिजियोलॉजी एक्सपेरिमेंट द फॉलोइंग प्रेशर्स वेर ऑब्टेन्ड. ग्लोमेरुलर कैपिलरी हाइड्रोस्टैटिक प्रेशर वाज 18 plasma colloid oncotic pressure was 27 and Bowman's capsule hydrostatic pressure was 7. So how much is the net filtration pressure? This was the question. अच्छा, चेस हार्मनी कह रहे हैं कि ये क्वेश्चन था जो हमने पहले डिस्कस किया. ठीक है, मतलब स्टारलिंग्स इक्विलिब्रियम शायद स्टूडेंट्स को इतना याद रह गया कि उन्होंने उसी के ऊपर क्वेश्चंस 2-3 लोगों ने अलग अलग तरीके से बताए एज अ रिकॉल. ओके, मतलब सिर्फ वो पहला वाला क्वेश्चन जो हमने डिस्कस किया वही था ना. ओके, कोई बात नहीं, बस आपको ये स्टारलिंग्स इक्विलिब्रियम, ये जो 4 फोर्सेस है, 2 फेवर करते हैं 2 अपोज करते हैं, उनसे आपको कैलकुलेट करना था कि फाइनली चौथा प्रेशर कितना होगा. 3 दिए हुए हैं, चौथा प्रेशर कितना होगा. इतने क्वेश्चंस मिले हैं. सो आई थिंक दैट्स ऑल फ्रॉम मी. आई थिंक मंजुनाथ सर इज वेटिंग. वेलकम सर.
Thank you, sir. Thank you, Vivek, sir. Yes. Now, FMT questions. I think there was one question from POCSO Act, that is protection of children from sexual offences, right? Yes, Anu? Anu Vinit Bharti? POCSO Act, very simple question, right? So very simple question, that is, what do you mean by juvenile? What do you mean by juvenile? So, under the Protection of Children from Sexual Offences Act, a child is defined as, a juvenile defined as, very simple, male or female, less than 18 years. Okay, so the answer is A. So A would be the best answer, correct answer. Yes, guys? Just reply me in chat box. Yeah. Yes, Bhumika Rajesh, yes. Okay, fine. Fine. This is very simple, and we discussed many times in our classes and also in the POCSO Act. I think one question from identification, I'm not very sure about this question, that is about the talus. So talus, this is the question from my sources. The talus develops from a single primary ossification center in dash months of intrauterine life. Bhumika, Anu? No such question. Okay. Okay, this question was not there. Fine. So talus appears at 7 months. That is at the viability. Okay, 28 weeks. Okay, this question was not there. Not found. Okay, chalo, no problem. Then I think one question from asphyxial death, that is ligature strangulation or throttling. So I think this is the STEM and probable options. In case of asphyxial death, bruises were found at the neck. So bruises were there, probably 6 penny bruises above the thyroid cartilage and over the back and over the scapular region. What is the most probable asphyxial death? Okay. What about this question, Kuldeep Kumar? Darshan? Options are mugging, garroting, throttling, ligature strangulation. Okay, around the neck and around the hip posterior side. Okay, fine. So there are multiple bruises, probably the bruises because of the struggling. So the answer is throttling. Most probably 6 penny bruises and bruise over the back and the scapula and over the hip region. So it go in favor of throttling. Throttling. Ligature mark was given. Okay. If ligature mark was given, So guys, if ligature mark was given, then it is ligature strangulation. If ligature mark is there, ligature mark, then it is ligature strangulation. If ligature mark is not given, then it is manual strangulation, also known as throttling is the correct answer. Throttling. Okay. Throttling is the when it is not given means throttling. MS, that is a manual strangulation. Okay. It is done so many times in our classes. Okay. Chalo, next question. I think there was one question basically from smell. Garlicky smell. Do you remember that? Garlicky smell, vomiting, rice water stool? Yes or no? Okay, fracture of thyroid cartilage was mentioned. Fine. So the fracture of thyroid cartilage. Thyroid cartilage. So again, the answer is throttling. So in case of throttling, there will be inward compression fracture. Outward compression fracture in case of hanging. So answer is again throttling. No changes in that. Yes. Look at this. This was the question. A patient came with a history of unknown poisoning with a rice water stool, garlicky smell, vomiting. Diagnosis of this poisoning. Very, very simple question. King of all poison, that is the arsenic, ideal homicidal agent, resemble like cholera. The answer is acute arsenic poisoning. Simple, 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 very simple question. Right? Garlic order, rice water stool. Yes, fine. So the answer is acute arsenic poison. Okay. Chalo. I think one question that is from sexual offenses. So basically a male and a female. So male age around 25 and female age around 16 and sexual intercourse with the consent. I think this was the question probably. Yes, let me read the question. So a 16-year-old girl was brought to, okay, blood in the stool. Yes, blood in the stool, again, arsenic poison. So blood in the stool is uncommon in case of cholera. That's why. A 16-year-old girl was brought to medical examination by parents, okay, by parents. With consensual intercourse by 24-year-old male. The girl agrees to it, agrees to sexual intercourse basically. On examination, signs of recent sexual intercourse was found. There were no injuries, no signs of force. Following is true. Following is true. So this is something related to 63 BNS and 7 descriptions of rape. 7 descriptions of rape. Okay. Was this the question? Yes, guys. Consent is invalid is one of the option. Consent invalid. So consent is invalid. Will is present. So this is a very important question. Interesting question. Will is present, but consent is invalid. Why? Because age is less than 18 year. So less than 18 year, that is nothing but statutory rape. Statutory rape. The best answer is consent is invalid. That is the best answer. Or it amounts to rape. Examination of the girl has to be done. Yes, examination of the girl has to be done with the consent from the girl. That is the medical examination, any age more than 12 years, right? So the consent is invalid. That seems to be the correct answer. Yes. Fine. Okay. Consent is invalid. Yes, consent is invalid. The consent for sexual intercourse is invalid. But consent for the medical legal examination is valid. What is the consenting age for medical legal examination? 12 years. Okay. So, fine. This is briefly about the question number 4, basically 5 that is. Then the chemical factory wala question. So, release of fumes from a chemical factory, poisonous fumes. What would be the most appropriate step? Yes, yes or no? Was there any question? Something like this? Chemical factory leakage. Okay, chemical factory. Kuldeep Kumar. Immaterial was there. Okay, consent is immaterial. That is also fine. Immaterial. Yes. Okay. So there was a leak of toxic fumes from a factory, like in case of Bhopal gas tragedy. A siren sound was heard with the instruction to civilians. Some instructions were given to civilians. What would be the best next step or appropriate step is? So in case of any poisonous gases, the best answer is, so close the door and the window, stay inside the house, seal the cracks. So that would be the best answer, not the A. Don't follow instruction. Go out of house and inform others. No, the logical answer is very simple. That is B. So friends, it is a very simple question. It is B is the answer. Okay, that's fine. Yeah. Next. I think there was one question from supravital period, basically Zako phenomena. Do you remember that? Zako phenomena. So Zako phenomena that occurs in supravital period between the cellular death and the somatic death. Right. So this was the question most probably. Just reply me in the chat box. True about Zako phenomena. So options are specific muscular response to observed after death, basically tendon movements. I think there was one option, tendon movements after death. Increase in potassium level in vitreous, fragmentation of blood in the retinal vessels, collection of blood in the dependent area. So collection of blood dependent area is post-mortem staining. So this is not the answer. Post-mortem staining. So this is known as Kevorkian sign. Kevorkian sign, not the answer. So B, C, D, not the answer. The best answer is A. Zako phenomena. Mechanical excitability of the muscles during supravital period. Okay, chalo. That's fine. That's okay. Kuldeep Kumar, that's fine. So I think this question was there. The answer is tendon movements after death. Zako phenomena, right? Then there was a question, I think, from forensic psychiatry that is basically 22 BNS or 84 IPC. 84 IPC. So let's see the question. So here is the question. The murder, assault and murder committed by a person with a history of mental illness. So mental illness can be schizophrenia, bipolar disease, or any mental illness. Under the delusion of persecution, and voice told him to do that. So something like this. What is the next best step is? What is the next best step is? Can you just help me in this? Release him as he is mentally ill, option A. Psychiatric evaluation, that is option B. Proceed with the trial, that is option C. None. What would be the best answer? So here, definitely not it is A, not the D. So either it can be B or it can be C. So as you know, criminal responsibility of insane person. So when person is mentally ill, the trial investigation is invalid. It is not done. So yes or no? Already neural examination was abnormal given. Okay. So the best is psychiatric evaluation. Yes. So best is psychiatric evaluation. Then proceed with the trial. So B is more than C. B is more than C. That is the best answer as per your feedback in the chat box. Fine. Then this question, I think very simple question. Young male comes to your OPD with a certain presentation. So he sits down and he believes that the birding movement, flapping is telling him to move him in a particular direction, and he does so. So he believes that. So it's a disorder of thought. It's a disorder of thought. So what is the answer? So answer is delusional perception. Delusional perception is the best answer. And again, so this is as from the forensic psychiatry. So B is the best answer. It is not the third person hallucination. This is the delusion of perception, right? Then I think I don't know exactly whether this question was asked in the exam. So a case of fracture, right? So petechial rash over the body. A 60-year-old man presents with the multiple fracture following road traffic accident, and during examination, petechial rash was found, shortness of breath. Yes, what about this question? Darshan Kumar, Kuldeep, Manu Goyal. So this is very simple question. This is fat embolism. Fat embolism. So we will come up with a detailed explanation in upcoming classes. So all these are the questions from forensic medicine. So that's it about forensic medicine, guys. So wish you all the best. Thank you. Yes,
Thank you.
Pradeep sir.
Thank you,
Thank
sir.
you. Yes.
Thank you. So, hello students. कैसे था anatomy? Am I audible and visible? Like, I'm very happy. Anatomy was awesome. सब questions easy थे, सारे questions notes से थे. Everything was discussed. Correct? So let us just see these questions. अभी काफी questions they have been discussed in the other topic in the other subjects also by the other faculties. But ठीक है, we'll just starting with the first question. During an abdominal surgery, an artery located posterior to the epiploic foramen is accidentally injured. Which major vessel is most likely to be involved? बोल सकते हो बच्चों? ये हमने बहुत बार करा है. This we have been discussing epiploic foramen, epiploic foramen, epiploic foramen. बोल सकते हो? So this is the epiploic foramen. Yo, this is the epiploic foramen. Right. So इसके आगे क्या होता है? Anterior relations, lesser omentum containing hepatic artery, portal vein, bile duct. पीछे what is this big vessel? Yes, this big vessel is the IVC. Then we have the right suprarenal gland, and this is the body of T12 vertebrae. ऊपर है caudate lobe of liver, and नीचे is the first part of duodenum. Correct? So this is about the epiploic foramen, the entry from the greater sac into the lesser sac. Clear? So very easy MCQ. This is the IVC. ठीक है ना? Portal vein, hepatic artery, anterior relations होता है. Okay, will be fast. Easy MCQ, straightforward MCQ, directly from the notes. Okay, coming to the next MCQ. Which cranial nerve supply the anterior and the posterior belly of digastric respectively? बोल सकते हो बच्चों, anterior belly and posterior belly of digastric. This also we've been discussing in the lectures. That's the anterior belly, that's the posterior belly. Anterior belly is derived from, yes, first pharyngeal arch. Nerve supply is mandibular nerve. The posterior belly is derived from the second pharyngeal arch. The nerve is facial nerve. Facial nerve, right? Yes. हाँ, क्या बोल रहे हो? IVC is retroperitoneal. ठीक है ना? IVC is retroperitoneal. That's fine. Yes, it is retroperitoneal, correct? So answer would be the nerve to mylohyoid, that's mandibular nerve, and posterior belly is supplied by the facial nerve. Clear? The first and the second pharyngeal arches. Clear है ना? So that was a straightforward MCQ. I mean, no need to see the other options also. जैसे आपने सवाल देखा होगा, without looking at the options also, you should be able to answer this. Clear? Okay, we'll go to the next question. During neck surgery, the submandibular gland, along with its duct, is exposed and removed. Intraoperatively, a nerve running beneath the gland labeled as A. Which nerve is most likely to be? Yes, क्या लिखा है बच्चों? इसका आंसर क्या लिखा है? Bleeding was in the peritoneal cavity. नहीं, but injury होता है तो peritoneum is also ruptured, no? इंजरी होता है तो एपिप्लॉइक फोरामेन के पीछे आईवीसी ही है, तो इंजरी हुआ तो पेरिटोनियम रप्चर हुआ तो पेरिटोनियल कैविटी में होगा. ठीक है ना? ओके, सो व्हाट इज द आंसर फॉर दिस? सी दिस आल्सो वी हैव बीन डिस्कसिंग हियर. दिस इज द की मसल ऑफ द ओरल रीजन. क्या है ये? हायोग्लॉसिस. ये हमने कितनी बार डिस्कस किया है. की मसल ऑफ द ओरल रीजन, हायोग्लॉसिस. This is the nerve which is lying on the hyoglossus. That's a lingual nerve. That's a submandibular ganglion. ये है submandibular gland. ये है submandibular duct. And that's the hypoglossal nerve. So the nerve beneath the submandibular gland, answer है hypoglossal nerve for sure. मतलब बाकी के options देखने की भी जरूरत नहीं है. I mean, you must be that confident, right? No? So answer is hypoglossal nerve. हाइपोग्लॉसल करेक्ट है बच्चों, लिखा है, क्या बोल रहे हो, लिखा है ना सबने? अगर ऊपर है तो लिंगुअल नर्व है, हाँ लिंगुअल नर्व है ना, तो सबमैंडिबुलर डक्ट जो है ना, सबमैंडिबुलर डक्ट इज गोइंग टू वाइंड, आई मीन द लिंगुअल नर्व इज गोइंग टू वाइंड अराउंड द सबमैंडिबुलर डक्ट। अगर सवाल होता जो एफएमजी में ये सवाल आया था, द लिंगुअल नर्व वाइंड्स अराउंड व्हाट, तब आंसर है सबमैंडिबुलर डक्ट। द नर्व बिलो द सबमैंडिबुलर ग्लैंड, दैट्स अ हाइपोग्लॉसल नर्व which lies on the hyoglossus, and the nerve going deep to the hyoglossus is what, glossopharyngeal nerve, ठीक है ना? हाँ ओके फाइन, ठीक है, यस ठीक है, दैट्स क्लियर फाइन। यस, विच ऑर्गन इज दिस फ्रॉम, ये भी हमने डिस्कस किया था, ये हमने हिस्टोलॉजी सेक्शन में डिस्कस किया था। वी हैड ड्रॉन दिस अम्ब्रेला शेप्ड सेल्स, याद है बच्चों, अम्ब्रेला शेप्ड सेल्स, लुक एट दिस, द टॉप मोस्ट सेल्स, द अम्ब्रेला शेप्ड सेल्स, किस में होता है ये, ट्रांजिशनल एपिथेलियम, दैट्स अ कैरेक्टरिस्टिक ऑफ ट्रांजिशनल एपिथेलियम, ठीक है। वैसे ही ये देखिए, सी दिस आर द अम्ब्रेला शेप्ड सेल्स, द टॉप मोस्ट सेल्स स्ट्रैटिफाइड एपिथेलियम, टॉप मोस्ट cells are umbrella shaped, they can stretch and they have a special glycoprotein coat. What is that? Transitional epithelium. क्या बोलते हैं? What is the answer for this then? Answer would be ureter. ठीक है ना, ureter simple है, transitional epithelium है, so answer for this is ureter. ये एक्चुअली यूरेटर में स्टार शेप ल्यूमन दिखाना चाहिए था, बट दैट्स फाइन, एपिथेलियम पूछा है, एक ही ऑर्गन दिया हुआ है, यूरेटर। हैड इट बीन यूरिनरी ब्लैडर आई वुड हैव प्रीफर्ड दैट बेटर, बट ठीक है, आंसर इज यूरेटर फॉर दैट। फाइन, क्लियर टू ऑल ऑफ यू? ये question has already been discussed, but still we have been discussing this. Which of the following cranial nerve passes through this foramen? Yes, what is this marked foramen? ये है jugular foramen. ये भी हमने कितनी बार डिस्कस किया है। jugular foramen 3 कंपार्टमेंट्स होता है इसके, anterior, intermediate, posterior. एंटीरियर से क्या जाता है, इंफीरियर पेट्रोजल साइनस, इंटरमीडिएट कंपार्टमेंट से जाता है 9th 10th 11th cranial nerves, and the posterior compartment से जाता है sigmoid sinus, right? I mean, if you have read everything very well, all the MCQs were very easy, right? So answer would be 9th 10th 11th cranial nerves. This is the jugular foramen which I always draw and explain. Correct है? ठीक है बच्चों? कुछ डाउट्स है? कुछ if anything is not clear, fine. See the next. ये भी सवाल डिस्कस किया हुआ है ऑर्थोपेडिक्स में, बट स्टिल विल गो थ्रू इट। 25 years old athlete sustains a sport injury causing forced eversion of the foot, which ligament is injured? मतलब eversion है ना, eversion, so medial side का ligament of the ankle joint is going to be injured if it is eversion. अगर वो inversion होता तो then lateral side का ligament would be injured. The most commonly is anterior talofibular, ठीक है ना? तो ये था eversion of the foot. So who's injured? The deltoid ligament. ये भी हमने कितनी बार डिस्कस किया है, deltoid ligament, and the 3 parts of the deltoid ligament, tibio-navicular, tibio-talar and tibio-calcaneal part. So forceful eversion होता है तो that deltoid ligament is injured. ठीक है? Fine, clear to all of you? So that's a deltoid ligament. I mean, there's nothing else to be discussed about, a straightforward MCQ. ठीक है? Clear है? Okay, fine. ये बाकी anterior, posterior and calcaneofibular, this are on the lateral aspect of the ankle joint. You know this. So answer is deltoid. We'll see the next MCQ regarding the cranial nerve vagus. Which type of fibers are not carried by this nerves? चलो इसका आंसर बताइए, क्या लिखा है? हम ये हमेशा, this is one of my most favorite topic, the functional components of the nucleus. ये हमने बहुत बार डिस्कस किया है, बोल सकते हो? Which is that? What is the answer for this? क्वेश्चन था वेगस, तो वेगस में वो कौन सा कंपोनेंट नहीं होगा? विच कंपोनेंट इज नॉट प्रेजेंट इन वेगस? जनरल सोमैटिक एफरेंट कंपोनेंट क्या कैरी करता है? इट कैरीज जनरल सेंसेशंस फ्रॉम द बॉडी वॉल, राइट? जनरल सोमैटिक एफरेंट कहाँ गया ये? जनरल सोमैटिक एफरेंट हियर. सो जनरल सोमैटिक एफरेंट कैरीज जनरल सेंसेशंस फ्रॉम द बॉडी वॉल. ये कौन से नर्व में होता है? 5th नर्व, एंड उसके 3 न्यूक्लियस, राइट? मेसेनकेफलिक, चीफ सेंसरी एंड द स्पाइनल न्यूक्लियस. The next option is general visceral afferent. Yes, vagus does carry general visceral sensation, मतलब sensations from the visceral organs. Yes, that is carried by the vagus. So this would be present in the vagus. General visceral afferent होगा. General somatic afferent, the vagus supplies the external ear, external acoustic meatus. So this is going to be there in the vagus. General visceral efferent is there. जनरल विसरल इफरेंट क्या है, वो ग्लैंड्स को सप्लाई करता है. सो वेगस सप्लाइज द ग्लैंड्स ऑफ जीआईटी, ये हमको पता है. वेगस सप्लाइज द ग्लैंड्स ऑफ जीआईटी. सो विच कंपोनेंट इज नॉट देयर इन द वेगस? बच्चों ये पता है ना आपको, जनरल सोमैटिक efferent. And this general somatic efferent, what does it supply? It supplies the muscles derived from occipital myotomes. ये कौन से मसल होते हैं? The extraocular and the tongue muscle. So ये general somatic efferent कौन से nerves में है? 3, 4, 6 and 12th. Correct? ठीक है बच्चों, कुछ doubts? Yes? I'm not able to see the chat. कहाँ गया? ठीक है, that's okay. So this is clear. Answer for this is general somatic efferent. It supplies the muscles derived from occipital myotomes. ये भी हमने बहुत बार डिस्कस किया, मैंने चार्ट्स भी दिए आपको. I've given you all the details for this. ठीक है. Now, a newborn is diagnosed with patent ductus arteriosus on the left side. This vessel is derived from which embryonic aortic arch? Yes, बोल बच्चों, बोलो. What is the answer for this? एक मिनट, I'm not able to see the comments. Okay, chalo, you answer. I'll. So patent ductus arteriosus, ये भी हमने डिस्कस किया है. Third, this is the third arch artery, fourth arch artery, sixth arch artery. Sixth arch artery gives a lung bud, एक छोटा सा bud देता है for the lung. On the right side, the part of the sixth arch artery between the lung bud and the aorta disappears off. On the left side, it remains persistent and वो है ductus arteriosus. बच्चों कितना easy था ये सवाल. That is ductus arteriosus. Clear, no? That is ductus arteriosus. So ductus arteriosus is persistence of which aortic arch artery? Yes, which aortic arch artery is that? That's the sixth aortic arch artery. एक मिनट. Okay. Fine. That's the sixth aortic arch artery. Yeah, na comments दिख नहीं रहे. That's okay. चलो, I'll go ahead. So sixth aortic arch artery, that is the ductus arteriosus. So left side पे the recurrent laryngeal nerve winds around the ductus and goes up. Right side पे ductus नहीं होता. So the right recurrent laryngeal nerve is going to wind around the subclavian artery. ठीक है? So patent ductus arteriosus is due to persistence of the left sixth arch artery. Clear है? Easy था ये MCQ. And ductus arteriosus का एक diagram दिखाया था. There was a connection between the pulmonary trunk and the aorta. That was ductus arteriosus. Clear, students? I hope this was also easy to answer. चलो, ये भी सवाल डिस्कस किया गया था. Nerve roots affected in Meralgia parasitica. What is Meralgia parasitica? This also we have discussed. Meralgia parasitica is the compression of the lateral femoral cutaneous nerve of thigh against the inguinal ligament. Right? Okay, it's the compression of the lateral femoral cutaneous nerve thigh against the inguinal ligament. I mean, you must be very happy to see all these MCQs. No, एकदम straightforward है ना, सब आता है. Okay, so ये lateral femoral cutaneous nerve thigh कैसे form होता है? Yes, we had drawn this T12 joints with L1. Okay, this is iliohypogastric ilioinguinal nerve. That's genitofemoral. फिर L2, 3, 4 divides into dorsal ventral divisions. अब dorsal divisions of L2 and L3 से क्या बना? Lateral femoral cutaneous nerve of thigh. That's the dorsal divisions of L2, L3. That's the dorsal divisions of, to be very specific, the ventral rami of L2, L3, that is lateral femoral cutaneous nerve of thigh, and this is the nerve which gets out through the most lateral aspect of the inguinal ligament. This is the nerve which gets compressed, causing paresthesia, tingling and numbness along the lateral aspect of the thigh. That is Meralgia parasitica. Fine. So this also we've been discussing all the time. That's the lateral cutaneous nerve thigh. L2, L3 उसका root value होगा. Dorsal division of ventral limb of L2, 3, 4 क्या था? Femoral. And ventral division was obturator. ठीक है? If you attended all this, it would have been very easy. I mean, it is very easy. ठीक है? So that's about the lateral femoral cutaneous nerve of thigh. So answer इसका था L2, L3. हाँ? ये options मैंने बनाया. But इसमें अगर देखोगे तो this is the dorsal division. Yeah, this other dorsal division. ये L2 है, ये L3 है. So that's the lateral cutaneous nerve of thigh. L2, L3. फाइन है? ओके, ये एक सवाल था. आउटर एनल कार्सिनोमा स्प्रेड्स टू विच ऑफ द फॉलोइंग लिम्फ नोड्स? आउटर एनल कार्सिनोमा मतलब they meant to say it is कार्सिनोमा बिलो द डेंटेट लाइन, कार्सिनोमा बिलो द डेंटेट लाइन, क्या होगा इसका आंसर? क्या लिखा है बच्चों? एक मिनट, आई एम नॉट एबल टू सी द कमेंट्स. कैन एनीवन टेल मी व्हाट इज द आंसर फॉर दिस? क्या लिखा है आपने? जस्ट गिव मी 2 minutes. Okay, I got it. Yes, students, bolo. So what is the answer for that? Answer for this question would be, just give me 1 moment. कमेंट्स नहीं दिखते ना तो प्रॉब्लम होता है. ओके, गॉट इट. हाँ, चैट नहीं दिख रहा है. हाँ, किसका आंसर? ओके, फाइन. Subjit, you are able to answer everything. Chalo, so answer for this, the cancer below the dentate line. What is the answer for that? Cancer below the dentate line spreads to what? It goes to the superficial inguinal lymph nodes. Superficial inguinal lymph nodes, this we have been discussing. The inguinal lymph node, that's a horizontal group, that's a ventral group, that's the upper medial group, and this upper medial group क्या drain करते हैं? ये drain करते हैं anal canal below the dentate line. Okay, drains the anal canal below the dentate line. Okay, that's upper medial group. ठीक है ना? So superficial inguinal is the answer for this. Above the dentate line, internal iliac lymph nodes. Above the dentate line is internal iliac. फाइन, ये आंसर करिए. ड्यूरिंग हाइपर एक्सटेंशन लॉन्ग हेड ऑफ ट्राइसेप्स डिटैचेस फ्रॉम विच ऑफ द फॉलोइंग साइट? बोल सकते हो लॉन्ग हेड ऑफ ट्राइसेप्स. ये स्लाइड है ना, मेरे पास नहीं है. दैट्स द स्कैपुला, दैट्स द ग्लिनॉइड कैविटी. यह है सुप्राग्लिनॉइड ट्यूबरकल, यह है इंफ्राग्लिनॉइड ट्यूबरकल. एंड व्हाट इज द ओरिजिन ऑफ लॉन्ग हेड ऑफ ट्राइसेप्स? बच्चों बोल सकते हो. द लॉन्ग हेड ऑफ ट्राइसेप्स arises from infraglenoid tubercle. So if there is a hyperextension of the shoulder joint, the long head of triceps would detach from the infraglenoid tubercle. Answer is going to be the infraglenoid tubercle. Clear hai? Is this fine? Answer is infraglenoid tubercle of scapula. Supraglenoid tubercle, say what is the muscle which arises from supraglenoid tubercle? That's a long head of biceps. Long head of biceps. Very good. Very good. ओके, ये बताइए नॉर्मल कंपोजिशन ऑफ अम्बिलिकल कॉर्ड इंक्लूड्स ऑल द फॉलोइंग एक्सेप्ट. बोल सकते हो बच्चों नॉर्मल कंपोजिशन ऑफ अम्बिलिकल कॉर्ड? चलो, दिस इज वेरी इजी, वेरी इजी. बोलो बोलो बोलो. नॉर्मल कंपोजिशन ऑफ अम्बिलिकल कॉर्ड, 2 arteries and 1 vein. Which vein is that? The left is left, so it is 2. किधर गया? 2 arteries and 1 vein. It's the 2 umbilical arteries and 1 umbilical vein. That's the left umbilical vein. The left is left, so 2 arteries and 1 vein. That's the constituent of the umbilical cord, along with jelly, Wharton's jelly. Wharton's jelly. ठीक है ना बच्चों? हाँ, कुछ डाउट्स है बीच में? आई couldn't see the chat, sorry for that. हाँ, okay, fine. This anatomy तो सब easy था. I hope everyone must have answered. Straightforward MCQs थे. Everything from the notes, and everything, most of them were also from this marathon series of PG NEET. Okay, thank you so much. Thank you so much. Over to the next faculty. Subjit, all correct? सब right ही होगा. Hello,
Hi
sir.
guys, I
Over to
hope I'm
you.
audible.
Thank you.
So give me 1 second, I'll pick up the questions that had come from medicine and we'll start the discussion. And medicine was quite on the anticipated line, not many difficult questions. Most of you could probably predict the kind of questions that you were expecting. And hopefully, I guess you got the right answer for most of the questions. Just give me 1 second, I'm just pulling the questions. Just give me 1 second, guys. Okay, so guys, how did you rate the question appeared today? So let me know, how do you consider the questions that appeared today? Guys, just give me 1 second. I'm having a little bit of a technical issue. I'll just pull up the questions for you guys. And once the questions are pulled on this thing, we'll get going. Just give me a second. Okay, so let me start with the first question for the day. Okay, so I hope the questions are visible to all of you. So this was our first question. I think this has already been addressed by the pharmacology faculty, but I have a little variation in the answer. I'm also not very sure this is going to be a controversial question. So let us discuss the points, both the favorable and the points against the answer. So what do you think? Should I choose here in this circumstance, should I choose topiramate as the first line management for prophylaxis, or should we go ahead with the propranolol? What do you think? Because generally we have been taught that the drug of choice for prophylaxis of migraine is going to be propranolol. But here there is a context. What is the context? The 2 points are there. Patient was being treated with sumatriptan, but unfortunately sumatriptan did not go well for the patient because he has a family history of coronary artery disease. And when first dose of sumatriptan was given, he developed chest tightness, or probably he developed what we call as angina. It was precipitated. So then that means this becomes contraindicated in this case. So we have to pay more emphasis on the prevention of migraine. And when we have to think about the prevention of migraine, is propranolol or an propranolol being a non-selective beta blocker, is it contraindicated in ischemic heart disease or patients with angina? The answer is no. If I have to treat a patient of ischemic heart disease or angina with beta blocker, of course, I will prefer the cardioselective beta blockers. But non-selective are not an absolute contraindication. And in the context of migraine, it can be used. It can be used. And I have gone through a lot of studies and I have practiced this. So I would still go ahead with propranolol as the right answer for this question instead of topiramate. But I think in the main lectures, I've told you that I personally prefer giving topiramate. But for the exam, my answer will be propranolol. And this point we have discussed in the management of migraine. Okay, we will go to the next question now. So there was a question on the mechanism of action of a drug used for the management of asthma, which was primarily benralizumab. And I think all of you know benralizumab primarily acts on the interleukin 5 receptor. It is a interleukin 5 receptor blocker, and that will be our answer. This we have discussed in the main video, and I had asked you to remember a very easy way to remember the mnemonic for all these monoclonal antibodies. Interleukin 4 receptor is targeted by dupilumab. That you can remember it as fourth letter of alphabet is D, so which is targeting interleukin 4. Fourth letter of alphabet targeting interleukin 4. Remaining all are primarily targeting interleukin 5, and omalizumab is targeting interleukin immunoglobulin E. The point I had asked you to remember is that benralizumab is blocking interleukin 5 receptor, not interleukin 5 directly. It is blocking the receptor. And I had asked you to remember that you can read it as ban receptor aliruzumab. Ban receptor aliruzumab. That's how, if you remember it, you will always remember that it is blocking the receptor interleukin 5. So here the answer was pretty simple, and it was one of the straightforward question. And also, I'm reiterating, I've told you multiple times in various video lessons and live sessions that whenever you get a clinical STEM, always read the last line. Last line often clarifies what examiner wants you. So even if I don't go through this whole STEM, the question was pretty straightforward. So if I had just read the last line, I would have gone to the answer, and I would have saved a lot of time reading this long clinical STEM. Bhumika Rajesh, what was the option if flunarizine was not there in the option? What was the option we had in place of flunarizine? If you mention ergotamine, because that's what I heard from some students, like dihydroergotamine or ergotamine, still, you know, in a patient with coronary artery disease, ergotamine being a vasoconstrictor is contraindicated. So of course that won't be the answer. Okay. Now next up, this was a question on a patient with CKD, and having anemia, right? So CKD, and it is clearly a normocytic normochromic anemia. That means there is no element of iron deficiency, right? So that means there is no element, because remember in my CKD related complication video, I have told you that iron deficiency is very common in patients with CKD. And that's why whenever we diagnose a CKD with anemia, step number 1 is to rule out the iron deficiency. If iron deficiency is there, we correct it first, and then we start the main treatment, which is going to be either erythropoietin or darbepoetin alpha. Here, indirectly, they've told that there is no element of iron deficiency when they mention that it is normocytic normochromic anemia. So it's kind of ruled out. Ideally, we should do the serum iron profile to rule out, but kind of it gets ruled out. So in that case, there is no role of oral iron or parenteral iron. I have to think of the erythropoietin or its analog. So there is no APO option, only analog option is there. So we'll go ahead with darbepoetin alpha as the answer, right? So that will be our answer for this question. Blood transfusion is generally considered when the hemoglobin levels are less than 7 grams per deciliter. Otherwise, blood transfusion is not required. There is no mention of any hemoglobin level per se. So I'm not going to the blood transfusion. So we'll stick to darbepoetin alpha as the answer, right? So this is a step that we discussed in our video lesson. First, identify and correct iron deficiency. Here, examiner has helped us to rule out the iron deficiency. And then we go ahead with either erythropoietin or darbepoetin. In the option, we had darbepoetin, so we are sticking to darbepoetin. Simple, as good as that. Okay. Now, I think in the FMG also, we got this template that the examiners have just started elevating the same topic, but to the next level question. So I'm anticipating if you're someone who is preparing for the upcoming NEET PG exam, the next NEET PG exam, there may be a potential question asking you to differentiate between erythropoietin and darbepoetin, or why they may give both the options, erythropoietin as well as darbepoetin, and then they may ask you to choose one. So I put a table which helps you to make an informed choice. Darbepoetin being long acting, it is preferred. Okay, so this was the next question. This was a good clinical STEM, right? If you have done your internship or you presented cases, then you should have answered this question. So here, there was a history of patient presenting with PND, palpitations, dyspnea, breathlessness, and on evaluation, his JVP was elevated, irregular pulse, and tender hepatomegaly, heaving apex, and a mid-diastolic murmur heard at the apex. The moment you hear the mid-diastolic murmur heard at the apex, you know the question is talking about apex means mitral area, mid-diastolic murmur means we're talking about mitral stenosis. So this is a case story of mitral stenosis, which is a very simple, straightforward question. Second thing, all these features, see this paroxysmal nocturnal dyspnea is pointing towards what? It is pointing towards left heart failure. But this raised JVP is pointing towards right heart failure. The tender hepatomegaly, it's all pointing towards right heart failure. So mitral stenosis has led to right heart failure. And we also know that one of the complications of mitral stenosis is patients develop massive enlargement of left atrium, and that can lead to atrial fibrillation. So this is a classical case of, so here our diagnosis is, it's a case of mitral stenosis, and we know most cases of mitral stenosis are because of rheumatic heart disease. So there may be story of rheumatic fever in the past. They might have mentioned in the question or might not have mentioned in the question, but anyway, we know that if it is MS, it is RHD. So this is MS with right heart failure and a fib. That is our diagnosis for this question. Once we know the diagnosis, I think answering the options becomes quite easier. So what are the options? They're asking what is false. Okay. Now, one of the option was absent A wave on JVP, which is anticipated because atrial fibrillation means we will have absent A waves. So this is true. Okay. Then patient has features of right heart failure. Yes, it is evident patient has features of right heart failure. True. Okay. And then this patient has increased risk of stroke. This may not be clearly visible to you. This patient has increased risk of stroke was one more option. And we know that patient with atrial fibrillation carries higher risk of stroke. And to calculate the risk of stroke, we have a CHA2, DS2, VASC score, and based on that, we decide whether to go ahead with aspirin alone or go ahead with anticoagulation. So we're all familiar with that. So this statement is also true. The last statement, pre-systolic accentuation of mid-diastolic murmur is expected to be hallmark feature in this case. Now, this we have discussed in the video lessons as well. So first thing, mitral stenosis can lead to right heart failure because there is development of pulmonary hypertension, right ventricular hypertrophy, and eventually right heart failure. So all those features are there. Second, the murmur that we get in the mitral stenosis has this pre-systolic accentuation. The murmur becomes louder just before the systole. And just before the systole, which phase of cardiac cycle is happening? It is the active filling, when atria is actively contracting to push the blood into the left ventricle. It meets more turbulence, and that increased turbulence increases the murmur intensity. But what if I have atrial fibrillation? Does atria contract? We know that in atrial fibrillation, atria does not contract. It is merely fibrillating. So when it is fibrillating, it is not going to contract. It is not going to push that, squeeze that blood into the left ventricle with higher force that normally we see. So in that case, if no atrial contraction, no presystolic accentuation. So here in the stem, they have clearly mentioned that there was pointer towards atrial fibrillation, that is irregular pulse, pointed towards atrial fibrillation. So in patient with atrial fibrillation, we are not expecting to have the presystolic accentuation. And that's exactly why there is absent A wave, because in atrial fibrillation, atria is not contracting, no active filling, no A wave. So there should be no presystolic accentuation either. So this is a false statement, and that becomes our answer. Okay, it's a very good question. To be very frank, these kind of questions should motivate students to spend more time bedside doing case presentations or do their internship sincerely. Okay. Next question. I think this is a simple same question that also appeared in the recently concluded FMG exam. It is literally lift and drop here kind of question, or a copy paste question. We know that pheochromocytoma is where there is increased production of catecholamines. Those catecholamines cause vasoconstriction and patients will have episodic hypertension. So to counter that, we generally give alpha blockers for the management. And between clonidine and phenoxybenzamine is considered as the drug of choice. It is considered as the drug of choice. So it's a very simple and straightforward question. This we have discussed in the lessons as well. We do initiate beta blockers later after initiating the alpha blockers. Please always remember it is AB, alpha first, and then after 3 to 4 days of initiating the alpha blockers, we can start with the beta blockers. Okay. Then this was a question which was kind of expected, anticipated. Every time at least one question on SGLT2 inhibitors had been the standard for last 2 to 3 years since SGLT2 inhibitors came into the market, and deservingly so, because they have revolutionized the mortality reduction in various disorders, CKD, heart failure, ischemic heart disease. So it's an important question. So in this stem, we have a patient who is known case of type 2 diabetes who is on metformin. Despite metformin, his HbA1c is 8.2. We already know that the target HbA1c, how much we want to control, is less than 7%. So target HbA1c is less than 7%. Anything more than that means it is not well controlled. I need to think of adding an additional drug. Now here, apart from diabetes, there is an extra context again. What is this? This is a patient with heart failure with reduced ejection fraction. When do we call it as reduced ejection fraction? When EF is less than 40%. So we are dealing with diabetes with heart failure with reduced ejection fraction. And now I have to add an additional drug because diabetes is not controlled what it should be. We had clearly made a flow chart about making a decision about how do we treat a case of diabetes. And in that video, we have clearly discussed that if you're dealing with a patient of heart failure, the drug that you would like to add is going to be an SGLT2 inhibitor. It's a very logical and simple choice because SGLT2 inhibitors cause glucosuria. They reduce the blood pressure. They make you lose fluid along with glucose. So they are helpful in patient with heart failure. It is well proven that SGLT2 inhibitors reduce the mortality risk in patients with heart failure. So for that reason, I should go ahead with an SGLT2 inhibitor like empagliflozin. And that will be our answer for this question. Okay. Next. This was an asthma based question, and I have told you multiple times in the asthma module also, this is the kind of questions they are asking. Giving you the context, scenario, what is the current status of the patient, and then asking you how do you manage if they are not responding. So in this question, we have a 30-year-old woman with a bronchial asthma who is taking salbutamol and ipratropium meter dose inhalers. Not a very good choice. I don't know if the stem was exactly like this or there were alterations, but not a good choice to start. It's not according to the GINA guidelines, but someone has started it. Now she is having frequent nocturnal symptoms, including wheezing and breathlessness that wake her up several times a week. So it is a poorly controlled asthma. What is the most appropriate next step in the management? So as of now, patient is only on bronchodilators. Patient is not on anti-inflammatory or the maintenance medications or the preventive medications. She is only on the bronchodilators. And that's not how we manage. So now, generally speaking, whenever patients have uncontrolled asthma, to the as and when required inhaled combination of corticosteroids and a beta agonist, we switch to what is called as MART, maintenance and reliever therapy. Maintenance and reliever therapy, which is primarily a combination of inhaled corticosteroid plus a long acting beta agonist, which can also be used as a short acting for its quick onset of action. So it can be a reliever as well as a preventive medication, that is going to be formoterol. And this is the current preferred treatment. And this patient is calling for it because the asthma is not well controlled with whatever current cocktail of medications that the patient is using. So what I should be doing here? Continue current treatment and add montelukast? No, montelukast is not a very effective drug. It's just a small add-on. So as long as the patient is on the ideal treatment and still not getting control, you can consider montelukast as an add-on, but not for someone who is not on the right treatment per se. Inhaled corticosteroid plus salmeterol. Increase the dose of salbutamol? No. Adding a LAMA is not a choice. So here, if the stem was like this, I would probably go ahead with option B, where an inhaled corticosteroid plus salmeterol makes more sense, though formoterol is the preferred choice. That's the current guideline. But if I'm deviating from the guideline, I will need an anti-inflammatory and a long-acting beta agonist. So this is the answer that I would choose. We had discussed a lot of questions on the similar lines in our asthma module. So if you've done that, you should be able to clear it. Okay, so Purima, if it was a 10-year-old child, then I would recuse from addressing that question because the management GINA guidelines for the pediatric asthma is different from the adult asthma. So if it was specifically a 10-year-old child, then like you can discuss it with the Sarath Balaji sir for the answer. This answer is presuming that we are dealing with an adult patient. Okay, so if it was a 10-year-old kid, of course, you cannot apply whatever I've discussed. The next question was COVID, but not a COVID question. It was primarily an ARDS question. A patient of COVID has developed ARDS and his PaO2 by FiO2 is 100, which is clearly supportive of ARDS. And they're asking what is the appropriate ventilatory setting. When we have discussed the ARDS in the video lesson, I've clearly told you that this is an anticipated question, ventilatory strategies for ARDS. So in patients with ARDS, to recruit maximum like non-recruited alveoli, we need to have high PEEP and low tidal volume to minimize the injury. So that's why this recommended strategy is high PEEP, low tidal volume, right? Low tidal volume means approximately 6 ml per kg body weight per minute. That's the tidal volume that we set for the patient. 6 ml per kg. High PEEP, low tidal volume is the strategy. And this we have discussed in the videos as well, that 6 ml per kg is considered as low. Normal for most other patients, we are using 12 ml per kg. And the PEEP has to be kept high. So we are following a high PEEP, low tidal volume strategy for the ARDS. And that's going to be our answer for the question. Okay, so we had plenty of MCQs in the video lessons on the similar grounds discussing the ventilatory strategies for the ARDS. So if you had dealt with those questions, you could have answered it. Okay, now there was another question on a patient with atrial fibrillation. I'm not very sure. Some students said that there was no mention of atrial fibrillation. Whether atrial fibrillation was mentioned or not, it does not influence. Our answer still remains same for this question. So here we have a patient who presented within 2 hours of the onset of stroke and CT brain showed no bleed. What is the next best step in the management? Anyone presenting within 4.5 hours of the onset of the ischemic stroke. No bleed means it rules out hemorrhagic stroke and makes the diagnosis as ischemic stroke. So for this question, our diagnosis turns out to be ischemic stroke. And when we are dealing with ischemic stroke, if they are presenting within 4.5 hours, we go ahead with the thrombolysis. So TPA, or if any other thrombolytic agent was mentioned, that would be the answer. If patient presents after 4.5 hours, then mechanical thrombectomy is a possible option. But for that, we need to know whether the clot is there in a large vessel. So we need to know whether it is a large vessel occlusion or not. For that, we need to go ahead with a CT angiography. So if the question had mentioned that the patient had presented after 4.5 hours, I would have considered CT angiography to decide whether he is a candidate for mechanical thrombectomy or not. Since he has now presented within 4.5 hours, we are going ahead with the thrombolysis, and that will be our answer, right? So anyone presenting within 4.5 hours, he's a indication for thrombolysis, and that's a very simple and straightforward question. Okay. Now another question was on the pituitary gigantism or the acromegaly. So here we had a 15-year-old patient presented to OPD with breathing difficulty. If it was a recombinant TPA, still thrombolysis is the treatment of choice. Breathing difficulty, had a height of 6.4 feet, enlarged jaw. So these are pointing towards either pituitary gigantism or acromegaly. In simple words, this is pointing towards growth hormone excess. So when the growth hormone excess happens before the fusion of epiphysis, we will call it as gigantism, where patients achieve supraphysiological height, like we see in this case. And if growth hormone excess happens after the fusion of epiphysis, then they cannot achieve increase in the height, but other bones like the jawbone, maxillary bone, which can continue to grow, they grow. And the small bones in the hands and feet, that's why it is called as acromegaly. So the story is about growth hormone excess. They're asking, how do you confirm? Now, suspicion is that this is a case of growth hormone excess. How do you confirm the diagnosis? Good. So in case of growth hormone excess, increased IGF, IGF-1 can be considered as a screening test. Some of the students were telling me that there was also an option of MRI brain, and there was no option of suppressed growth hormone on administration of glucose. So I'm not very sure. Nonetheless, our answer remains logical and same. So once you get a screening test done and IGF-1 level is elevated, you go ahead with a confirmatory test. What is confirmatory test? Normally, when we take large amount of glucose, growth hormone gets suppressed. And when we take amino acids or proteins, growth hormone gets stimulated. Similarly, when we induce hypoglycemia, growth hormone gets stimulated in physiological state. But if there is a pituitary tumor which is producing excess growth hormone, it will not get suppressed even when we give glucose. Physiological growth hormone gets suppressed when we give glucose. So we give 75 grams of oral glucose. So in simple words, we are doing a oral glucose tolerance test. After administering 75 grams of glucose, we check the patient's growth hormone levels. If it is suppressed, then the patient is having normal growth hormone physiology. But if it is non-suppressed, it is not coming down, it still remains elevated, then it is suggestive of growth hormone excess, which depending on whether fusion of epiphysis happened or not, we would call it a gigantism or acromegaly. So in this case, our answer should be non-suppressed growth hormone despite giving the 75 grams of anhydrous glucose. IGF-1, decreased or suppressed IGF-1, increased IGF-1. Increased IGF-1, we take it as the screening test. Decreased IGF-1 is suggestive of the growth hormone deficiency and not the growth hormone excess. No, okay, Arcapriya, no, we do not check the IGF-1 once we are going ahead with the growth hormone suppression test. Once we are going ahead with the growth hormone suppression test, we check the growth hormone levels itself. See, there is a reason why we use IGF-1 as a screening test. The growth hormone levels in the blood fluctuate. It's not constant because it is a stress responsive hormone influenced by diet. If you have more carbs in the diet, it gets suppressed. If you have more protein in the diet, it gets elevated. But IGF-1 is long acting. So small changes, small physiological changes in the condition will not change the IGF-1 level. So that's why we're using it as the screening test. But if I give glucose, IGF-1 levels will not show gross difference because of the long-acting nature. So we cannot use the suppression test of glucose suppression test on IGF-1. We have to go ahead with growth hormone itself. Growth hormone itself. Okay, so there was an IGF raised and no suppression after glucose was two options. See, you have to confirm it if they're asking, you have to go ahead with no suppression of GH after administration of glucose. So if they had also added an IGF-1 raised plus no suppression of GH after administration of glucose, well, perfect. So Imran, no. See, we are not linking the IGF-1 levels and the glucose suppression. Keep them apart. Growth hormone and glucose should be linked. So if there were options linking the growth hormone levels and glucose, one of them showing suppression, the other one not showing suppression, go ahead with the one not showing the suppression. So so Imran, you mean there was no option showing that GH suppression after OGGT? Can anybody confirm? Okay, so as Pathkirtan, it's perfect. So if you have a IGF-1 which is raised and non-suppressed GH on administration, perfect. That's how we establish the diagnosis. So that will be our answer. Okay, so good. So then this will be the answer. So raised IGF and no suppression of the glucose GH on administration of glucose. Okay. Okay, so there was a question on the CKD as well, where we had a patient of CKD admitted to ICU with the following findings. The calcium is low, right? Hypocalcemia. Phosphate is elevated. Normally should be 3.5 to 4 point. So there is hyperphosphatemia and elevated alk-phos and elevated parathormone. So it's a classical complication of CKD. It is basically secondary hyperparathyroidism. Parathyroid is elevated. Secondary, there is no parathyroid adenoma or hyperplasia. It is elevated because of the changes that we are noticing here. So secondary hyperparathyroidism. Now, when I have to treat a secondary hyperparathyroidism, how do I treat? So this we have discussed in the CKD complications. So in CKD, phosphate is increased, FGF23 is increased, which causes the increase in the PTH. So in CKD, these three things are increased. And in CKD, vitamin D and calcium are decreased. So when it comes to management, vitamin D supplementation is recommended only when it is low. Otherwise, regular supplementation of vitamin D is not recommended by the guidelines. As doctors, we do prescribe a combination of calcium and vitamin D3 in patients with CKD. But guidelines recommend that when it is low, supplement. When it is not low, don't supplement. So among the changes here, I have to reduce the phosphate. I have to increase the calcium. Vitamin D, I will only act if it is low. So how do I reduce the phosphate? The goal is to keep it below 5.5. That I can achieve either by dietary restriction alone or by adding a phosphate binder. So I need that. Along with that, I have to elevate the calcium. So for that, I need to consider giving calcium supplementation. So here the answer should be calcium supplementation plus phosphate binders. Calcium supplementation plus phosphate binders in addition to the dietary restriction of phosphate. Anyway, that is not there in the option. So this will be our answer. Some of you might have chosen oral calcium and vitamin D3. As I've already told you, guidelines are very clear. When vitamin D levels are low, then only we are supposed to add the vitamin D, otherwise not required. So safe and correct answer here will be option C. Okay, the next question, a patient of high altitude, patient went to high altitude mountain and developed breathing difficulty, vomiting and dizziness. What is the most likely mechanism causing this sickness? So basically here the diagnosis is what we call as high altitude pulmonary edema or HAPE. High altitude pulmonary edema or HAPE. And the main mechanism what triggers this is low oxygen mediated or low atmospheric oxygen pressure usually causes vasoconstriction. Vasoconstriction. The mechanism behind this we have discussed in the COPD module. So in COPD also, there is pulmonary vasoconstriction because of reduced air entry into the alveoli, reduced oxygen entry into the alveoli. And to counter that, in COPD, we give oxygen. When we give oxygen, this hypoxia mediated vasoconstriction gets relieved. So burden on the right heart gets relieved, and that's why oxygen therapy is associated with mortality reduction in COPD. So same applies here. So when you are at very high altitude, the atmospheric pressure is low. So the partial pressure of oxygen is low. So the amount of oxygen entering the lungs is low. So to maintain ventilation perfusion, there is triggering of the pulmonary vasoconstriction. Triggering of the pulmonary vasoconstriction causes the increase in the pressures inside the pulmonary vasculature. Why? Because Boyle's law, pressure and volume are inversely related. So when I constrict the blood vessel, volume decreased, pressure increases. So that increased pressure increases the hydrostatic pressure and triggers the pulmonary edema. The mechanism for this pulmonary edema is the pulmonary vasoconstriction because of low oxygen, not the acidosis, not the acidosis. Okay, so if they're asking the cerebral edema, so there was no mention of the breathing difficulty, only dizziness. Okay, again, it all depends on the diagnosis. So if it is high altitude cerebral edema, if the diagnosis is high altitude cerebral edema, then there is rise in the intracranial tension. So your answer changes to the hypoxia mediated vasodilatation in the brain. Hypoxia mediated vasodilatation in the brain. Okay, so if it is cerebral blood vessels, we are going ahead with the vasodilatation. And if you're thinking about the pulmonary blood vessels, we are thinking about vasoconstriction. Because cerebral, there is a localized autoregulatory mechanism which triggers the vasodilatation when there is hypoxia. But in pulmonary, to maintain ventilation perfusion match, it triggers vasoconstriction. So STEM decides, or if the STEM was same, but options had mentioned cerebral, specifically if the cerebral word was mentioned, then our answer is going to be vasodilatation. If cerebral term is not mentioned and predominant symptom is of shortness of breath, suggestive of pulmonary edema, then I'm going ahead with the vasoconstriction. Okay, so if it is cerebral, then we are going ahead with vasodilatation. Okay. Next, which of the following is most common chronic manifestation of Sjogren's? I think we all know the most common chronic manifestation of Sjogren's is going to be the chronic lymphocytic infiltration of the lacrimal glands and the salivary glands. Lacrimal glands and the salivary glands. So this has been clearly addressed in our module, and that's a straightforward question that we had, nothing controversial or complicated there. Okay, now please help me with the question here. Vishnu Mondal, you're talking about which question? So which of the following is the most appropriate prophylaxis for paroxysmal supraventricular tachycardia in a stable patient with history of asthma? Asthma was mentioned or not? Okay, so if it is about cerebral blood flow, we are going ahead with vasodilatation. Asthma was mentioned or not? Okay, if asthma was mentioned, we know that even if, see here, first of all, they are talking about prophylaxis, not the acute management. So generally adenosine is considered for the acute management. Adenosine is very short acting. It is not suitable for a prophylactic treatment. Amiodarone, verapamil, metoprolol can be considered for the long-term treatment. Generally, PSVT does not call for prophylaxis in most patients, but if there is recurrent PSVT, we might have to consider. So if there is mention of asthma, anyway, we know that even if it is a question about acute management of PSVT, adenosine will remain contraindicated. So that is out from our scenario. So we have to choose between amiodarone, verapamil, and metoprolol. Beta blockers are not good drugs when it comes to the management of PSVT. So I have to choose between amiodarone and verapamil. So here, the preferred agent is always going to be verapamil or diltiazem. Amiodarone can be considered as an option, alternative to verapamil or diltiazem, particularly when you have other contraindications for use of calcium channel blockers. If not, you can comfortably go ahead with either verapamil or diltiazem. If verapamil wasn't the option, good, we will go ahead with that as our first choice answer. Amiodarone becomes our second choice answer. I think I'm sure most of, okay, amiodarone was IV, verapamil was oral. Okay, so that makes it even more clear then. Amiodarone was IV and verapamil was oral. In that case, adenosine also they would have mentioned IV, and metoprolol also they would have mentioned oral. Okay, so then no controversies. I have a very clear answer emerging here, oral verapamil. That will be our answer. Good. Okay, so next question was about a long story of a diabetic presenting with altered sensorium, missing her insulin doses. It was IDDM or a type 1 diabetes is what some students told me. BP is 80/60, pulse rate is high, and laboratory values, so sodium 126, potassium 4.3, blood urea nitrogen elevated, creatinine elevated, RBS 720. Which of the following is not part of the initial management for this patient? Okay, so clearly it is a case of either hyperosmolar hyperglycemic state or diabetic ketoacidosis. Since the question does not mention anything about ketones, I cannot differentiate whether it was hyperosmolar hyperglycemic state or DK. But anyway, it is one of the hyperglycemic crisis or emergencies. The management largely remains same. Okay, now how will I manage? So yes, the A option is not visible to many of you. I think the PPT has jumbled it up a bit. IV 3% sodium chloride was one of the option. And they are asking which of the following is not part of, right? Which of the following is not part of the initial management. So when it comes to the DKA or HHS, the first and the most important thing is the fluid management, right? And when it comes to the fluid management, we are going ahead with the normal saline, right? We initially load and then after that we go ahead with the maintenance fluid. That's the most important step and the first step whenever we deal with a diabetic ketoacidosis or HHS patient. In this case, instead of asking what is not the part of the initial management, if they're asked what is the first step or the next best step, we would have gone ahead with 0.9% NaCl as the answer. So this is true. We do that. Okay. Then to bring down the blood glucose level to less than 250, we have to consider insulin infusion. So insulin is going to be part of our treatment. And then we have to monitor the potassium levels because as we give insulin, there is shift of potassium from extracellular to intracellular compartment. And the guidelines are very clear that we have to consider adding potassium to fluid if the potassium value is less than 5.2. So in this case here, clearly the potassium value is less than 5.2. So I need to consider giving potassium. And of course, I have to monitor the potassium levels. Here, we are not going to give the 3% sodium chloride. Now, some of you may argue, sir, this patient's sodium level is 126. Potassium appears fair. So why am I still monitoring potassium and I'm not giving correction for sodium? Potassium appears safe, but as I give insulin, the potassium will start coming down. So I need to monitor. In fact, at this level itself, I need to add potassium to the fluid. This sodium is the concern, and some of you got confused because there was also description of altered sensorium. Sir, sodium is low, altered sensorium, so why should not we give 3% sodium chloride? Altered sensorium happens in patients with diabetic ketoacidosis because of dehydration as well as ketosis itself. It's very common, need not always attribute it to hyponatremia. And the first thing and the most important thing that you have to remember is that hyponatremia can be false or what we call as pseudo hyponatremia, because sodium primarily regulates serum osmolality and presence of other osmotically active substances in the serum makes the sodium to shift from extracellular to intracellular compartment, though there is no depletion of the total body sodium. Such conditions we can call it as pseudo hyponatremia, and hyperglycemia is one of the most common cause for pseudo hyponatremia. In fact, every 100 milligrams rise in serum or blood glucose level decreases the serum sodium level by 1.6 milliequivalents per liter. So in this case, it is probably the pseudo hyponatremia and not the true hyponatremia. This hyponatremia is because of hyperglycemia. Look at the blood glucose level, so high. So here there is no need for giving the 3% sodium chloride. You correct his blood glucose level, bring it down. As the blood glucose level comes down, the sodium level starts rising and it gets normalized on its own. So here our answer is going to be option A. 3% sodium chloride is not the part of the treatment for this patient. Okay. Next, a patient develops quadriparesis after rapid correction of hyponatremia. What is the most appropriate treatment? So we know that rapid correction of hyponatremia leads to a complication. What is the complication? It's called as osmotic demyelination or central pontine myelinosis. And these patients often present with what we call as locked-in syndrome. Locked-in syndrome, where they are quadriparetic and they are only moving the eyeballs, right? So now when we are talking about demyelination, can you name other diseases where we have demyelination of the central nervous system? Yes, multiple sclerosis, neuromyelitis optica, myelin oligodendrocyte glycoprotein antibody disorders, important demyelinating disorders of the central nervous system. Then acute disseminated encephalomyelitis. For all these demyelination, what is the investigation of choice? Demyelination can be easily visualized on the MRI. So that's why MRI is the investigation of choice when we are suspecting a demyelinating disorder of the central nervous system. And here also it is a demyelination triggered by rapid correction. When I say rapid correction means more than 12 milliequivalents improvement in the sodium levels within a span of 12 hours. So that is again a point we have discussed in the SIADH, and our investigation of choice here is going to be the MRI. I know there were few more questions on the atrial fibrillation. I'm still collecting the stems. And Polivalgut, the GBS is a demyelinating disorder of the peripheral nervous system. So where we can do nerve conduction study, we can't do the MRI of the peripheral nerves to recognize demyelination. But for the multiple sclerosis or neuromyelitis optica, we can go ahead with MRI. So similarly, this is also a demyelinating disorder, iatrogenic, caused by us. So we can image it, MRI. MRI will be the investigation of choice. Okay, so for now, that's it from my side. I'll pass the baton to the next faculty. If any question is missed or the stem was little different, please ping me on the Telegram or the Instagram, because we are putting all our efforts to compile the question as close to the real exam as possible, and we will share it as a PDF through to all of you guys, so that you can prepare better. And you know, the PYTs was the essence of this exam also, and having a good knowledge of the whole topic is important. Rajesh sir, over to you, and sir will take you through the biochemistry questions.
Thank you, Santosh sir. So welcome to the discussion of biochemistry questions. Hello students, hope you had done well in the examination. Now just relax. There were 22 questions from the biochemistry, and most of these questions were integrated with the pediatric medicine or any pathology also. So there is horizontal integration and vertical integration which is seen in the NEET PG. हमेशा दिखता है, इस बार भी दिखा है. PYQs were mainly from the vitamins, repair mechanism, glycogen storage, not glycogen storage disorder, that is GAG, glycosaminoglycans पे, mucopolysaccharidosis पे questions थे. There were question on the lysosomal storage disorder, then hyperlipidemia. Just मेरा कल क्लास हुआ तो मैंने क्लास में बच्चों को बोला था, this is a trending topic for the NEET PG examination, also for the first MBBS university examination, lipoproteinemia. There were 2 questions in the NEET PG exam. आज के exam में 2 questions थे. One was with hyperlipoproteinemia and one on the hypolipoproteinemia, that is on the Tanger's disease. So most of the questions were from the PYQ, moderate level. बहुत ज़्यादा easy भी नहीं था और बहुत ज़्यादा difficult भी नहीं था. Question paper moderate था. आप लोग चार्ट में क्वेश्चंस डाल दो अगर आपको बायोकेमिस्ट्री के क्वेश्चंस बीच में याद आते हैं तो. ओके, So there were question on vitamin B1, vitamin C, vitamin K, vitamin B12 और vitamin D पे भी just अभी संतोष सर ने डिस्कस किया, that is chronic renal failure and जो chronic renal failure के साथ जो rickets associated है उसका treatment पे भी question थे. Okay, so let's discuss one by one. See this question. A 10-year-old child is evaluated for enlarged and orange color tonsil. See this, enlarged and orange color tonsil. ये एकदम फेवरेट पीवाईक्यू है और सभी को ये डायग्राम भी याद है पीवाईक्यू की, तो काफी सारे बच्चों ने ये ऑप्शंस भी नहीं पढ़े एक्चुअली. एनलार्ज एंड ऑरेंज कलर टॉन्सिल्स. ही हैज हिस्ट्री ऑफ फैमिली मेंबर्स डेथ ड्यू टू कार्डियोवास्कुलर एबनॉर्मेलिटी. लेबोरेटरी इन्वेस्टिगेशंस रिवील्स वेरी लो एचडीएल लेवल 5 milligram per deciliter. HDL level 5 milligram. Can you imagine 5 milligram per deciliter? Triglyceride 146, total cholesterol 80 milligram per deciliter. Which of the following is the most likely diagnosis? This is repeat PYQ. ये PYQ है, ये repeat question है. Tangiers disease, yellow orange color tonsil, hepatosplenomegaly, neuropathy is there. This is because of mutation in ABCA1 gene, which is required for the transport of cholesterol from peripheral tissue to the HDL. जो HDL ऐसा चपका हुआ रहता है, जो nascent discoidal HDL रहता है, उसको spherical बनाने के लिए कोलेस्ट्रॉल को HDL के पास लाया जाता है और HDL के पास आने के बाद LCAT जो है लेसिथिन कोलेस्ट्रॉल असाइल ट्रांसफरेज, उसका स्टेरिफिकेशन करके फिर वो जो नॉन पोलर लिपिड है वो लाइपोप्रोटीन के अंदर चला जाता है, उसको बोलते हैं स्पेरिकल HDL. सो हियर आंसर इज Tanger's disease. सो विल गो फास्ट. दिस वाज द फर्स्ट क्वेश्चन. देन सी ऑन द सेम टॉपिक लाइपोप्रोटीन पे सेकंड क्वेश्चन. A 20-year-old boy present with tendon xanthoma. See here, tendon xanthoma. This is a characteristic tendon xanthoma on the elbow. He has strong family history of premature cardiovascular disease. His father died of myocardial infarction at the age of 35. Laboratory reports show a total cholesterol 470 milligram per deciliter, LDL cholesterol 300 milligram per deciliter with normal triglyceride level. Which of the following type of hyperlipoproteinemia is most likely? Fredrickson classification जिसमें 5 टाइप्स दिए हैं हाइपरलाइपोप्रोटीनेमिया के, उसमें हम हमेशा बताते हैं कि टाइप 1 और टाइप 2A ये दोनों इंपॉर्टेंट है. दिस इज हियर आंसर इज टाइप 2A बिकॉज देर इज इंक्रीज इन LDL कोलेस्ट्रॉल, देर इज इंक्रीज इन द टोटल कोलेस्ट्रॉल, देर इज टेंडॉन xanthoma, involvement of the tendons. One more feature is there, the MI history and the cardiovascular risk. So when there is increase in the LDL, when there is increase in the total cholesterol, it increases the risk of atherosclerosis and myocardial infarction. It is, so this is a case of type 2A. It is because of LDL receptor defect, or ApoB100 defect. So this is hyperlipoproteinemia type 2A. ओके, सो ये बहुत बार क्वेश्चन आता है, टाइप 1 पे भी आता है और टाइप 2A पे भी आता है. ये पूरा PYQ है, ऐसा पकड़ लो इसे. नाउ द थर्ड क्वेश्चन, ये भी थोड़ा सा PYQ का पार्ट है. ए पेशेंट हैज विटामिन B12 डेफिशिएंसी ड्यू टू ileal resection. On examination, he has a positive Romberg sign. Laboratory investigations reveal macrocytic anemia, elevated homocysteine level and elevated methylmalonic acid. So हम हमेशा बताते हैं पढ़ाते वक्त कि B12 और फोलेट में कैसे डिफरेंशिएट करना है. तो elevated methylmalonic acid means B12 deficiency. There is already given B12 deficiency. Also ileal resection indicates the B12 deficiency. And there are neurological features. Which of the following amino acid is likely to be deficient in this patient? So phenylalanine, nothing to do with the B12. Methionine, cysteine, these amino acids, they are related with the B12. How it is related with the B12? In the reaction C, methionine, it is converted into S-adenosyl methionine, and S-adenosyl methionine is converted into S-adenosyl homocysteine, and this S-adenosyl homocysteine is converted into homocysteine. And this goes for the cysteine synthesis. And in the upward direction, it is methionine synthase reaction, which is B12 dependent. If there is B12 deficiency, it blocks the folate in the methyl folate form. So it is methyl tetrahydrofolate, which is blocked here. it is converted into tetrahydrofolate. So this is folate trap reaction. इसको folate trap वाली reaction भी बोलते हैं क्योंकि B12 के deficiency में folate की deficiency होती. If B12 is deficient, this reaction is blocked and there is decreased level of methionine occurs. So here, so which of the following amino acid is likely to be deficient in this patient? Answer is methionine. और इसी पे दूसरा क्वेश्चन बेस है जो बार बार पूछा जाता है, दैट इज होमोसिस्टीन यूरिया, जिसमें मिथ्योनिन भी बढ़ता है, होमोसिस्टीन भी बढ़ता है और सिस्टीन सप्लीमेंटेशन देना पड़ता है. सो दिस इज डेफिशिएंट विटामिन, हियर इज द मिथ्योनिन. थर्ड क्वेश्चन. नाउ द फोर्थ, पीकेयू. हमेशा हम बोलते हैं माउसी ऑर्डर पे क्वेश्चन आएगा, लेकिन इस बार थोड़ा सा पीकेयू का वेरिएंट पूछा. सी, हाय एवरीवन, यस मेथ्योनिन. हाय सुकी. A 6-month-old infant diagnosed with phenylketonuria. It started on phenylalanine restricted diet. Despite strict dietary compliance, the child continued to show developmental delay, elevated phenylalanine. There is elevated phenylalanine and decreased tyrosine level. मतलब वो रिएक्शन में कहीं तो भी ब्लॉक है. तो मेजर इज क्लासिकल फेनिलकेटोन्यूरिया जिसमें फेनिलैलेनिन हाइड्रोक्सिलेज ब्लॉक होता है. Further testing reveals a normal phenylalanine hydroxylase gene. Which of the following deficiency is most likely responsible for this atypical presentation? See, which is a cofactor for the phenylalanine hydroxylase? This is the phenylalanine hydroxylase reaction where phenylalanine is converted into tyrosine with the help of this phenylalanine hydroxylase. So ये reaction catalyze करता है. Now, if there is, see, this requires the tetrahydrobiopterin, which is converted into dihydrobiopterin, and again with the help of dihydrobiopterin reductase, which requires the NADPH, it is resynthesized. So if this is not blocked here, the presentation, there is increase in the phenylalanine level and decrease in the tyrosine level. मतलब यहीं पे कहीं तो भी block है. So it is a variant of PKU. That is because of the either deficiency of dihydrobiopterin reductase. There is no dihydrobiopterin reductase. यहाँ पे फोलेट दिया था, ऐसा दिया भी होगा तो ऑप्शन में डाहाइड्रोफोलेट दिया होगा. देयर इज नो डाहाइड्रोबायोप्टेरिन रिडक्टेज इन द ऑप्शन. द नेक्स्ट बेस्ट ऑप्शन इज द बायोप्टेरिन, दैट इज टेट्राहाइड्रोबायोप्टेरिन डेफिशिएंसी. फेनिलकेटोन्यूरिया के 5 टाइप्स है. हाउ मेनी टाइप्स आर देयर? 5 टाइप्स आर देयर related with this coenzyme deficiency and synthesis of these coenzymes also. Okay, so this is biopterin here. So discussing the next question, एक पेडिग्री चार्ट आया था जिसमें ऐसा इंडिकेट कर रहा, ये चार्ट ये इंडिकेट कर रहा है. So the affected means all children they are affected. See, from the affected mother, all children they are affected. And see the transmission, only mother is transmitting, or mother, if the affected mother is there, mother is having the affected child. If father, see affected father, there is no transmission from the affected father. What is this inheritance is known as? This is mitochondrial inheritance. And here answer is Kern-Shire syndrome. This is answer, Kern-Shire syndrome. Okay. Prader-Willi, all of you know that genomic imprinting, chromosome 15. Williams syndrome, this is autosomal dominant, alpha-1 antitrypsin deficiency, autosomal codominant, and the Kern-Shire syndrome, which is having the mitochondrial inheritance. The next question, your favorite topic है NEET PG का, that is lysosomal storage disorder. A 9-month-old infant present with developmental regression, hypotonia, and exaggerated startle response. Fundus examination shows a cherry red spot on the macula. Enzyme assay reveals deficiency of hexosaminidase A. मतलब diagnosis already दे दिया. Hexosaminidase A deficiency. Which of the following substance is most likely to accumulate in this condition? In this hexosaminidase A, it is a Tay-Sachs disease. It is a Tay-Sachs disease, which is GM2 gangliosidosis. So which compound will accumulate here? It is a GM2 gangliosides. It is GM2 gangliosides. Sphingolipids, they accumulates in the Niemann-Pick disease. Galactocerebrosidase, it is in the Krabbe disease. GM1 gangliosidosis, separate disorder is there. Also the Fabry disease, there is GM1 gangliosidosis. So here answer is GM2 gangliosides. Just wait. See, this image was there in the examination. Elbow और knee joint दोनों पे lesions थे जो follicular hyperkeratosis दिखा रहे थे. So phrynoderma image with follicular hyperkeratosis was asked in the examination. इसमें पूछा था which of the following should be done in the next step. Which of the following should be done in the next step? So hyperkeratinization and the blockade of adnexal gland is there in the phrynoderma. And in phrynoderma, this is a multi-nutrient deficient condition because of vitamin A deficiency, also essential fatty acid deficiency. So next step in the management is the ocular examination for the vision problem, that is the conjunctival xerosis, bitot spot, corneal xerosis, corneal ulceration. ये सब देखने के लिए we'll do the ocular examination. So it is not related with the vitamin D level. Vitamin D is related with the rickets. Vitamin B12 having the neurological symptoms. Deep tendon reflexes means for the neurological symptoms. It is not required here. It is ocular examination which is needed here. Yes, subcutaneous xanthoma was given, but LDL cholesterol, total cholesterol were raised. And there is history of family history of cardiovascular disease, so that indicates the hypercholesterolemia. तो उसका disease का नाम ही है type 2A का hypercholesterolemia. Next question. A 2-year-old child present with developmental delay, coarse facial features, hepatosplenomegaly and corneal clouding. So corneal clouding, जब भी corneal clouding दिखता है तो NEET PG वाले तो हमेशा वो हर्लर के साथ जाते हैं. So enzyme assay reveals the deficiency of alpha L iduronidase. ये deficiency भी दी गई थी. Which of the following substance is expected to accumulate in this disorder? So this is a hurler. This is a type 1 mucopolysaccharidosis. Hurler और hunter दोनों में this dermatan sulfate and heparan sulfate accumulates. जहाँ जहाँ heparan sulfate accumulate होता है वहाँ वहाँ mental retardation होता है. Remember this, Marquio और Moretti-Lamy ये दोनों में भी mental retardation या subnormal या normal intelligence रहता है. This is because there is no accumulation of heparan sulfate in this disorder. ये भी हम जब पढ़ाते हैं तब बताते हैं कि कौन सा compound accumulate होता है, कौन सा GAG accumulate होता है. So here answer is dermatan sulfate and heparan sulfate. Next question. A 5-year-old malnourished child present with bleeding gums, perifollicular hemorrhage and poor wound healing. Which of the following enzyme is most likely impaired in this condition? Which of the following enzyme? Normal routine question जैसा विटामिन सी पे बेस्ट है लेकिन वैसा पूछा नहीं है, थोड़ा बहुत वेरिएशन हो सकता स्टेम में. Here answer is prolyl hydroxylase. This lysyl oxidase is somewhat confusing, but it is not answer here. It requires copper. It requires copper. हाइड्रोक्सिलेशन ऑफ कोलेजन के लिए दो चीजें लगती है. वन इज प्रोलिल हाइड्रोक्सिलेज एंड अदर इज लाइसिल हाइड्रोक्सिलेज, नॉट लाइसिल ऑक्सीडेज. ये दो चीजें लगती है और ये दोनों के लिए कोफैक्टर है विटामिन सी. विटामिन सी इज रिक्वायर्ड फॉर द हाइड्रोक्सिलेशन रिएक्शन जिसमें प्रोलिन और लाइसिन का हाइड्रोक्सिलेशन होके हाइड्रोक्सी प्रोलिन और हाइड्रोक्सी लाइसिन सिंथेसिस होता है. एंड दिस इज इंपॉर्टेंट स्टेप इन द कोलेजन सिंथेसिस. सो अगर ये नहीं रहा तो डिफेक्टिव कोलेजन इज देयर दैट कॉजेज द पेरिफॉलिकुलर हेमोरेज ब्लीडिंग गम, मींस विटामिन सी डेफिशिएंसी कॉजेज दिस मैनिफेस्टेशन. व्हिच ऑफ द फॉलोइंग एंजाइम इज मोस्ट लाइकली इंपेयर्ड इन दिस कंडीशन? आंसर इज प्रोलिल हाइड्रोक्सिलेज. ओके, ये तो लाइसिल इज नॉट देयर इन ऑप्शन. Lysyl oxidase was there or not there? ठीक है, नहीं है तो भी प्रोलिल हाइड्रोक्सिलेज इज आंसर हियर इन दिस क्वेश्चन. बायोकेमिस्ट्री पे बहुत क्वेश्चंस थे, लगभग 24 क्वेश्चंस थे, इंटीग्रेटेड थे. सिर्फ क्लिनिकल बेस स्टेम था और इंटीग्रेटेड थे, उस वजह से वो ऐसे क्लियर कट दिखते नहीं है, लेकिन इट इज़ ए इम्पोर्टेंट पार्ट. सी, जो बेसिक सब्जेक्ट वाले टीचर्स है वो क्लिनिकल केसेस डालते हैं और जो क्लिनिकल केसेस वाले टीचर्स है वो बेसिक क्वेश्चंस डालते हैं, तो वो बैलेंस हो जाता है. नेक्स्ट क्वेश्चन. ए mRNA कंसिस्ट ऑफ कोडिंग सीक्वेंस ऑफ 900 न्यूक्लियोटाइड्स. A frame shift mutation occur at the 4th nucleotide position. 4th nucleotide. Total 900 nucleotide है, मतलब 900 से suppose 300 amino acid बनेंगे. So there is mutation occurs at the 4th nucleotide position. What is most likely outcome of this mutation? no biological change, partial loss of protein and function, complete loss of protein and function, no change in the function as it will be corrected in post-translational modification. Post-translational modification is nothing to do with the this mutation in the mRNA. So this is wrong option here. No biological change if there is frame shift mutation. Frame shift mutation का मतलब होता है either addition of nucleotide or the deletion of nucleotide. If this first three position, this will code one amino acid only, and this is the fourth nucleotide. If there is addition or deletion at this fourth sequence, it will alter the reading frame of mRNA. Total reading frame of mRNA get altered. That causes the that affect the synthesis of, मतलब अभी ये सिर्फ एक अमाइनो एसिड बना है और टोटल कितने बनने वाले थे हमारे 300 299 अमाइनो एसिड्स अफेक्ट होंगे, लगभग 299 अमाइनो एसिड्स अफेक्ट होंगे. सो इट कॉजेज द प्रीमेच्योर ट्रंकेशन ऑफ प्रोटीन एज इट इज अर्ली इन द स्टेज. मैं ये इसलिए एक्सप्लेन कर रहा हूं क्योंकि मोस्ट ऑफ द बच्चों ने पार्शियल लॉस ऑफ प्रोटीन एंड फंक्शन टिक किया है. हियर आंसर इज कंप्लीट लॉस ऑफ प्रोटीन एंड फंक्शन. Here answer is complete loss of protein and function because this frame shift mutation occurring at the early level, बहुत शुरू में ये change हो रहा है, that causes the complete loss of protein. Hi business champs. Next question, a 22-year-old very tall man, just FMG में repeat हुआ, FMG का जो recall session लिया उसमें भी ये question लिया गया. A 22-year-old very tall man with long arm span had visual problem and visited ophthalmologist. Sudha ma'am के पास गया. He was found to have ectopia lentis. Which of the following genes is most likely mutated? So this is a case of Marfan syndrome. Abraham Lincoln को Marfan syndrome था ऐसा बोलते हैं, confirm नहीं है. Okay, क्योंकि उसका tall stature था and features, some features were there. Okay, so the most likely mutation is fibrillin 1. This is the answer here, fibrillin 1 mutation. It is a scaffolding protein for the elastin, and deficiency specifically affect the lens. Skeletal changes are there, मतलब पेरोस्टियम अफेक्ट होता है और एओर्टा का मीडिया अफेक्ट होता है. सो एओर्टिक अन्यूरिज्म फैटल कॉम्प्लिकेशन है मार्फन सिंड्रोम में. दिस इज एहलर डाउनलोड सिंड्रोम. दिस इज नॉट ए आंसर हियर. दिस इज कोलेजन 5 म्यूटेशन. इट इज देयर इन द एहलर डाउनलोड सिंड्रोम. दिस PLOD mutation is there in the काइफोस्कोलियोटिक टाइप ऑफ द एलर डाउनलोड सिंड्रोम. फोर्थ ऑप्शन मिला नहीं कौन सा था, तो यही इतने ही ऑप्शन मिले. हियर आंसर इज द फिब्रिलिन 1 जीन म्यूटेशन. बहुत कॉमन PYQ है, अब भी जस्ट FMG के एग्जाम में आके गया. ए पेशेंट विथ सीवियर डिस्निया ABG रिवील्स. सो ABG पे 2-3 क्वेश्चंस थे, मैं 2 क्वेश्चन यहाँ पे कवर कर रहा हूँ. सो ABG रिवील्स 7.2, pH 7.2 मतलब एसिडोसिस. इट इंडिकेट्स एसिडोसिस. दिस वाज सिंपल क्वेश्चन, एसिडोसिस. PCO2 रेज, मैं हमेशा बोलता हूँ कि PCO2 मतलब कार्बोनिक एसिड समझो उसको. इट इंडिकेट्स द रेस्पिरेटरी एसिडोसिस. Respiratory acidosis. So here answer is respiratory acidosis, and this bicarbonate level, it is normal, somewhat normal level. Which of the following is the underlying disease? So it is metabolic acidosis. ROMS, all of you know the ROMS, that is respiratory opposite and metabolic same. So in the metabolic, see, metabolic pH decreases and the, just wait. Here answer is respiratory acidosis. Just wait here. This is acidosis, this is respiratory acidosis, this is normal. So answer is respiratory acidosis, not metabolic acidosis. So here answer is respiratory acidosis. क्योंकि PCO2 बढ़ा हुआ है, that's why respiratory acidosis. The parameter who goes with the pH is the primary defect. Here answer is respiratory acidosis. Now see the next question. फिर से acid base balance पे question है. A pH 7.3 that indicates the acidosis. तो अभी अल्कोलोसिस वाला कोई ऑप्शन है क्या यहाँ पे? देयर इज नो ऑप्शन विद अल्कोलोसिस, तो कट नहीं कर सकते. PCO2 44, 35 to 45 नॉर्मल रेंज रहती है, मतलब ये लगभग नॉर्मल है, मतलब रेस्पिरेटरी का कुछ रोल नहीं है. तो यहाँ पे रेस्पिरेटरी है क्या? सो कट द रेस्पिरेटरी पार्ट हियर, कट द रेस्पिरेटरी पार्ट हियर, कट द रेस्पिरेटरी ऑप्शन हियर. Bicarbonate level 16 that indicates the metabolic acidosis, that indicates metabolic acidosis. तो अभी कितने ऑप्शन बचे? सी metabolic acidosis with anion gap 30 and acute metabolic acidosis with anion gap 16. अभी ये दो ऑप्शन बचे. Base excess it is -12. 12 उधर चला गया. Base excess is -12. Sodium 130, chloride 84. Which of the following explain the underlying defects? Now calculate the anion gap. So anion gap is equal to sodium minus chloride plus bicarbonate. So it is 130 minus 84 plus 16. So it is 30. It is 30. What is anion gap here? So see the 30 metabolic acidosis with anion gap 30. This is the answer. This is the answer here. So question थोड़ा simple था लेकिन complicated कर दिया उसको तो थोड़ा सा ये हो गया. Base excess that indicates the -12 plus -2 is the normal range. -12 indicate the severe metabolic acidosis. So here answer is metabolic acidosis with anion gap 30. Next question, a 10-month-old boy present with recurrent oral lesions and respiratory infection. Lab finding reveals decreased B cell and T cell count with reduced adenosine deaminase. This is a subtype of one disorder, that is severe combined immunodeficiency. Which of the following is most likely diagnosis? It is SCID. SCID, it is caused due to adenosine deaminase deficiency. SCID, it is caused due to the defect in non-homologous end joining. Here answer is SCID, severe combined immunodeficiency, adenosine deaminase deficiency. Both B cell and T cell, they are affected, and person or the child is prone for the repeated infection. Child is prone for repeated infection, SCID. नेक्स्ट क्वेश्चन, ए चाइल्ड प्रेजेंट विद मल्टीपल फ्रेकल्स. ये तो फेवरेट क्वेश्चन है बायोकेमिस्ट्री का. डीएनए रिपेयर मैकेनिज्म पे हर साल क्वेश्चन आता है, हर बार हम रिपीटेडली ये लेते हैं. उसमें भी बोलते हैं वो चार्ट में कि ये दो बिल्कुल याद रखना है, एक जीरोडर्मा पिगमेंटोजम और दूसरा बोलते हैं HNPCC, हेरिडिटरी नॉन पोलिपोसिस कोलन कैंसर. हियर आंसर इज see a child present with multiple freckles and photosensitivity. Examination reveals two basal cell carcinoma lesion on the face. Which of the following DNA repair mechanism is defective? This is a nucleotide excision repair. This condition is known as xeroderma pigmentosum. There is 1000 time risk of getting the cancer, that is basal cell carcinoma. ये भी पूछा जाता है, basal cell carcinoma, squamous cell carcinoma and melanoma. So there is chances of these three cancers, and there is 1000 time more risk of getting cancer when person is exposed to sunlight, sun exposure. This is because of thymine dimer formation, thymine covalent cross linking, and there is formation of cyclobutane link between two adjacent thymine molecules. So this is nucleotide excision repair defect. A man was trapped in the tunnel for 5 days. यहाँ पे थोड़ा सा मुझे पूछना है, which mechanism will provide. यहाँ पे बहुत सारे लोगों ने मुझे बोला कि एनर्जी था वर्ड, ठीक है, तो विल गो विद द एनर्जी टू द ब्रेन ड्यूरिंग दिस पीरियड. मतलब मेरे को पूछना है यहाँ पे एनर्जी था या ग्लूकोज था. सो एनर्जी अगर पूछा है, सो योर आंसर इज कीटोसिस. एनर्जी अगर पूछा है तो योर आंसर इज कीटोसिस. नाउ सी देयर आर वेरी स्टेजेस ऑफ द स्टारवेशन, लेकिन आफ्टर 72 आवर्स के बाद में the brain will utilizes ketone bodies, mainly 60% ketone bodies and near about 30-35% और मतलब अभी यहाँ पे 60 लिया, 60 to 65 आता है यहाँ पे. 60 to 65% it is energy is provided by the ketone bodies after the 72 hours, and if and the 35% it is from the gluconeogenesis. It is from the gluconeogenesis from glycerol and the amino acids. 35%. So major source of energy it is ketone bodies. जैसे जैसे दिन बढ़ते जाएंगे वो ketone bodies पे पूरा शिफ्ट हो जाएगा. बट यहाँ पे 5 दिन की हिस्ट्री है, so it is a ketone body which will supply the energy. हाँ, एनर्जी सही. हाय मुनीश, एनर्जी था तो गो विद द कीटोसिस. अगर यहाँ पे ग्लूकोज है तो कीटोन बॉडी ग्लूकोज नहीं देंगे, ठीक है, तो यहाँ पे आंसर थोड़ा चेंज हो जाता है. A patient present with bleeding manifestation due to clotting factor 9 deficiency and resolve after vitamin K. It resolves after vitamin K therapy, which may be the underlying disease. इसका थोड़ा सा स्टेम अलग हो सकता. Which may be the underlying disease. Resolve after vitamin K. So these bleeding manifestations which resolve after the vitamin K dose, it is seen in the biliary obstruction. In biliary obstruction, there is block to the flow of the bile. उसके वजह से विटामिन के का एब्सॉर्प्शन नहीं होता. विटामिन के इज ए फैट सोलुबल विटामिन. विटामिन के का एब्सॉर्प्शन नहीं होता. दैट्स व्हाई देयर इज विटामिन के डिफिशियंसी. सो दैट्स दिस इज करेक्टेड बाय द giving the vitamin K. Hemophilia is not corrected by giving the vitamin K. Hepatitis, there is no role of the vitamin K, and pernicious anemia, it is related with the vitamin B12. It is related with the vitamin B12. The next question, a patient present with right heart failure, इसमें और ज़्यादा symptoms थे ऐसा मुझे बच्चों ने बताया. The patient present with right heart failure, nystagmus and ataxia. He was non-alcoholic and did not have any habits. Which of the following deficiency causes these symptoms? अभी इसमें जो options है उसमें the best option is thiamine. Thiamine causes the wet beriberi. So this can be a case of the wet beriberi. Wet beriberi, though it is not alcoholic or there is no polish rice की history भी नहीं दी है, chronic alcoholic भी नहीं बोला है, फिर भी ये will go with the thiamine because thiamine deficiency can be there in the bariatric age group, in the bariatric surgery. Thiamine deficiency can be there in the malnutrition. Also some diseases that causes the thiamine deficiency, especially age mention किया रहता तो और ज़्यादा better होता था. It is a case of thiamine deficiency because these are the symptoms: nystagmus, ataxia, and right. There is marked peripheral vasodilation in the thiamine deficiency, which causes the edema, right-sided heart failure. There is high output cardiac failure. And edema and accumulation of fluid in the various spaces, pericardial, pleural spaces, there is accumulation of fluid. So here answer is thiamine. Zinc is not related with these cardiac manifestations. Selenium is related with the cardiomyopathy. But selenium, there is nothing like nystagmus and ataxia in the selenium deficiency. In B12 deficiency, there are features of neurological deficiency, but it is not related with the heart. Okay, so here answer is thiamine deficiency. If glucose level, if glucose level increase 2 to 3 times of the normal and maintain at this level, this is a hypothetical situation. If glucose level increase 2 to 3 times of the normal and maintain at this level, what will happen with insulin in this hypothetical situation? What will happen to insulin? क्या होगा? सोचो, बीटा सेल से इंसुलिन सिक्रीट हो रहा है. इनिशियली देयर इज इंक्रीज इन द इंसुलिन सिक्रेशन. इनिशियल स्पाइक रहेगा इंसुलिन का. जब तक इंसुलिन है वहां पे स्टोर्ड इंसुलिन जितना है वो स्पाइक दे देगा. लेकिन बाद में द न्यू इंसुलिन सिंथेसिस विल ऑकर एंड दिस न्यू इंसुलिन विल रिलीज स्लोली. दिस न्यू इंसुलिन विल बी रिलीज स्लोली. सो देयर इज सडन राइज इन द इंसुलिन सिक्रेशन एंड सस्टेन ड्रॉप. इंसुलिन के बारे में पूछा है. सडन राइज इन द इंसुलिन सिक्रेशन एंड देयर इज सस्टेन्ड ड्रॉप in the insulin. Okay, continuous increase in insulin will not occur. Increase followed by below the baseline, this will not occur. And initial rise followed by again increase levels, this will not happen because the beta cells of the pancreas, they get exhausted, so insulin will have to synthesize again. So initial insulin release occur, then it is sustained drop will be there. So this is option here. There was positive Romberg sign. हाँ, कौन सा रोमबर्ग साइन वाला कौन सा लिया था हमने? ये क्वेश्चन में था कि इसके पहले वाले क्वेश्चन में था? रोमबर्ग साइन, रोमबर्ग वाला आइलियल रिसेक्शन वाला क्वेश्चन हमने ऑलरेडी डिस्कस किया है. आइलियल रिसेक्शन एंड पॉजिटिव रोमबर्ग साइन. न्यूरोलॉजिकल फीचर्स इंडिकेट्स द B12 deficiency if रोमबर्ग साइन वाज पॉजिटिव. ये तो शायद सिराज सर ने डिस्कस किया होगा, फिर भी मैं ये थोड़ा सा बायोकेमिस्ट्री से लिंक्ड है तो मैं डिस्कस करूंगा. ए ड्रग पेग्लोटिकेज was given to the patient with raised uric acid. It decreases the uric acid level by which of the following mechanism? So see, this uric acid, it is converted into allantoin. It is converted into allantoin. This is by the oxidation. This is by the oxidation. So this is mechanism here, oxidation. So here answer is oxidation, not hydrolysis. This is allopurinol which inhibits the xanthine oxidase, not this drug. इनिबिट द यूरेट ट्रांसपोर्टर, ये भी नहीं है. ये ऑक्सीडेशन करके उसको अलेंटाइन में कन्वर्ट करके मोर सोलुबल फॉर्म में कन्वर्ट करता है वो, और वो एक्सक्रीट होता है. सो हियर आंसर इज ऑक्सीडेशन. सो ये कम से कम 22 से 24 क्वेश्चंस थे बायोकेमिस्ट्री से रिलेटेड. मोस्ट ऑफ देम वेयर पीवाईक्यू बेस्ड और मॉडरेट लेवल के क्वेश्चंस थे. आई विल हैंड ओवर द सेशन टू द नेक्स्ट फैकल्टी. थैंक यू वेरी मच ऑल ऑफ यू. Hi, sir.
Hello guys, good evening. Dr. Vinish here. I'll be taking up the questions from anesthesia. If I'm visible and audible, please give me a thumbs up, guys. So let me start with the session. The questions from anesthesia were integrated as with other branches. They were integrated with other branches also. So let's discuss the questions and answers straight away without me wasting any time. The first question was, a patient is scheduled for surgery, develops preoperative bradycardia, hypotension, and facial flushing. Which of the following muscle relaxants is most likely responsible for these symptoms? Easy question. The answer is atracurium. Okay. All of us are aware of that. Here the answer is atracurium. Okay. Atracurium. Okay, guys. So here the answer is atracurium, and that's exactly why we have a drug like cis atracurium. The reason for atracurium having the problem is because atracurium has histamine release. That is one of the problems that you see. So the histamine release is a problem that you see with atracurium, and that's the reason for it. All right. And so this is the answer. The most likely responsible drug is going to be atracurium. Right, guys, if there are any changes, please let me know, because there are some options which I feel are not correct or the question is not framed correctly. So please help me with that. Okay, let me take the next question. This was the first question. I hope all of you have got it correct. Let me take the next one. A patient, this question, initially all the students told me, sir, we got a question on dantrolene. But when I discussed the question framed was, if just let me know if it's correct or not. A patient undergoing surgery is administered succinylcholine along with a muscle relaxant, right? Shortly after, the patient develops bradycardia and hypotension. Which of the following is the most appropriate life-saving drug in this scenario? A lot of students told me that the answer here is dantrolene, but dantrolene is not the answer according to me, because I feel the answer here is atropine. Okay, according to me. The reason is that the patient has been given succinylcholine, the patient has been given a muscle relaxant, but they have nowhere mentioned about malignant hyperthermia changes that we were expecting. So if a patient develops malignant hyperthermia, guys, so immediately you're not going to get bradycardia and hypotension. It's more going to be about muscle rigidity, increase in temperature, all right? Changes which are there, all right? So therefore, according to me, there were no symptoms mentioned about malignant hyperthermia, though they did mention about succinylcholine, they did mention about muscle relaxant. But if the question asked is about bradycardia and hypotension, remember succinylcholine, whenever is given to someone, it does cause bradycardia, right? Especially if given in pediatric patients or in adults. So it does decrease the heart rate. It can cause hypotension, right? And it can cause arrhythmias as well, right? So therefore, in that case, if there is bradycardia that is taking place, right, there is hypotension that is taking place. So for me, the correct answer would be atropine, because many times when we are giving succinylcholine, especially to a pediatric patient, we always add atropine or we always add glycopyrrolate, right? So here the point was, what do you give to take care of bradycardia? So if this was the question, then according to me, the answer should be atropine. If there are any changes, guys, please let me know, because here they are not discussing malignant hyperthermia according to me from the symptoms that are given. Please correct me if I'm wrong, guys. Please correct me. Okay, let me take the next question. This question must have been covered in medicine also, but this is one question which we always discuss when we discuss ventilators. There's a critically ill patient with COVID-19 admitted to the ICU, is on mechanical ventilation. The PA to FiO2 ratio is 100, indicating ARDS. So the question is regarding ARDS. Which of the following is the most appropriate ventilatory strategy? Remember, always we discuss nowadays what we say is a lung protective strategy, right? And the lung protective strategy now is to start a patient on a low tidal volume. So you have to search where is the low tidal volume, and comparatively you have to give a high PEEP. So the correct answer is A. Dr. Joshua says malignant hyperthermia given. Okay, so let me correct myself. If malignant hyperthermia was given in this question, then the answer becomes dantrolene. But from what was told to me by the students, that malignant hyperthermia per se was not given directly. If Dr. Joshua is telling me that malignant hyperthermia was mentioned in this question regarding succinylcholine. So if malignant hyperthermia is directly mentioned, then the answer is dantrolene. But remember, if malignant hyperthermia is not given, then the answer will become atropine. I think, we'll have to further see with other options that are available. Let us get back later on. Okay, as we always do, let's get back and we'll try to get the correct answers and options here. Right? So other people can also tell me if I'm correct or wrong regarding the malignant hyperthermia part. Right? So let's go to the next one, which I was discussing. Okay, let me take with functioning adrenal tumor. Okay, increase in temperature. Dr. Apurva says increase in temperature was mentioned. Dr. Apurva says increase in temperature was mentioned. So in this case, if you have malignant hyperthermia and if you have increased in temperature mentioned, right? So you have increased in temperature mentioned. In this case, the answer is dantrolene. So Dr. Purva Garg has also said increase in temperature. So we'll stick with dantrolene as the answer, right? The next question I said high PEEP and low tidal volume. All of you are aware of this answer. Let me go to the next one. Again, must have been discussed in surgery. Part of Pharmac, I told you a lot of integrated questions. Functioning adrenal tumor for surgical excision, which is the most appropriate drug pre-op, intra-op to control the blood pressure. So most of the drugs we normally use, but here the correct answer according to me is going to be phenoxybenzamine, right? The next question we'll take. Which intravascular crystalloid in excess can cause hyperchloremic metabolic acidosis? Again, integrated questions, comes with many branches, right? So here the correct answer is going to be normal saline. If you give huge volumes of normal saline, this is where it can cause a hyperchloremic metabolic acidosis. All of you are aware of it. Again, these are simple questions which came. These are integrated questions which were there. All right. Let me take the next one. A patient was, again, I need you people to correct me in this also. This was another question given to me, or maybe it's the same question which was there the first one. So this was told to me by some students. A patient was given sevoflurane and succinylcholine for abdominal surgery and develops post-operative muscle rigidity. Again, drug of choice for this, dantrolene, diazepam, propranolol, paracetamol. I may be wrong, so please correct me if I am. So here, sevoflurane is given. Remember, sevoflurane and succinylcholine. Yes, sevoflurane can also cause malignant hyperthermia. Succinylcholine, of course, known to cause malignant hyperthermia. Out of all the inhalational agents, halothane causes maximum. But it's not that sevoflurane does not cause malignant hyperthermia, even it causes. But here we are talking about an abdominal surgery and we are talking about a post-operative muscle rigidity. If there is malignant hyperthermia, we just saw that it was supposed to be increase in temperature intraoperative. Right. So the symptoms of malignant hyperthermia, they normally take place intraoperatively. They did not take, it's not about postoperative. Dr. Munish says malignant hyperthermia. No, so how can, so if this is post-operative muscle rigidity, according to me, I may be wrong about the question, the way it has been framed, I may be wrong about the options, but if these are the question on the option given, therefore dantrolene is given intraoperatively to treat the symptoms of malignant hyperthermia. It happens immediately intra-op, it does not happen post-op. So if the word post-op is given, I will not go with the answer dantrolene. If the answer is given intraoperatively, develops muscle rigidity. Answer, because diazepam, why is it used in anesthesia? There are 4 reasons for it. Diazepam causes amnesia, right? Midazolam is the most common used, but of course you can use diazepam also. Diazepam causes amnesia. It causes anxiolysis. These are the reasons we use in anesthesia. It causes sedation. It also causes very slight muscle relaxation, which is more commonly seen with midazolam. Okay, guys? So please correct me about this answer.
And let's start with this first confusing question, which a lot of students told me that they have given a researcher is trying a new thing, new drug on some 20 PHCs, and he is not giving that same new drug on remaining 20 PHCs. He's just doing lifestyle modification in remaining PHC. So which type of trial is this? One thing is, what is this quasi-experimental trial? Simple point is,
if they have not done randomization, then it is quasi-experimental trial. So in this question, you can see they have not written the word that the selection is done by randomization. Do tell me in the chat box whether the randomization was given in the question or not. Because if they have done randomization, then answer will be cluster randomized trial, because this 2020 PSC will be cluster and they are doing the trial on the whole cluster of 2020 PSCs like that. But if the randomization has not been done, then the answer is quasi experimental trial. What is this field trial and clinical trial? Of course, I hope you know this cluster randomized trial, field trial, clinical trial, all are type of RCT. We do cluster trial on the whole community, on the whole group. Field trial we do on healthy people, which we can find in field. And clinical trial we do on sick people, which we can find in clinics. So if they have not done randomization before doing this experiment, that was quasi-experimental trial. Do tell me whether randomization was written or not. Okay? Yes, no randomization was given. So if randomization was not given, then the answer is quasi-experimental trial. Next was a question which has two different type of recall. Some students say that in this question they have written that HIV drug is started at 34 week. Viral load was very high. High we decide when the viral load is more than 1000, we decide it as high. And baby is healthy and breastfeeding mother want to give. So if breastfeeding we are giving, if breastfeeding is planned, in that case, we give nevirapine plus jadovudin for 12 weeks. If breastfeeding is not there, then we give nevirapine for 6 weeks. So correct answer is B. We have to give it for 12 weeks with exclusive breastfeeding. Okay. Next question is that of course, there is a diabetic male who was admitted to ICU with some complication. He died 7 days after admission. How do we report it? How do we do the surveillance for it? So I hope you all know active surveillance we do for hidden case and passive surveillance we do for those case who come to hospital themselves. मरीज खुद से बीमार होकर अस्पताल में था तो वो नोटिफाइड केस है और नोटिफाइड केसेस को हम लोग कहते हैं पैसिव सर्विलेंस because the patient themselves reported, so it is passive surveillance. And if you mix active plus passive, then it becomes sentinel, which is the best surveillance. For all cases we do sentinel surveillance. Okay, so I hope it was, this one was also clear. Then they have given one population of 70 lakh and they are asking that 30% are living in slum area, which does not matter. Main thing is that we all know that urban PHC is at 50,000 population. So we just have to divide 70 lakh. 70 lakh means 70 into 10 to the power 5 with 50,000. 50,000 means 50 into 10 to the power 3. So you can see it will become 7,000. 70 and 20 more will remain here by 5. No, 700 by 5 will come out, hai na? Because this 50-50 will also cancel, 10 will also cancel, okay? So it will be 700 by 5. And 700 by 5 will be, yes, if you solve it, it is 140, 10, 10, hai na? Like on solving it, it will come 42. I have done the calculation, but let's do it again this time also. 5 will cut 70 into 14. 10 and 14 and 140. So it will be 140 here. Because we all know PHC is at 50,000. Let's do the calculation here. 70 lakh. So 70 lakh means total this much 0 and then 50,000 is the population of urban PHC. So if we try to solve it, this 40 will cancel this 40. So it is 700 by 5 and 5 will cut 70 by 14. So it is coming 140 here. But I think the recall data has some issue, or maybe, so the answer was 42. I have done the calculation, but here it is not coming well. So in the detailed explanation session, which we are going to have in this week only, I will again come back to this question with great detail. Someone is saying ki, "Rehne de bhai, tere se nahi hoga." Yes, I am getting confused in this question because of the option, or so I will correct it and I will discuss it in detail when we will have the detailed discussion. This question they are asking that there is two independent population and we are measuring mean hemoglobin level. So hemoglobin level is something which we can measure. It is a quantitative data. And if it is in a quantitative data and there is two group, then we all know that it is unpaired t-test, which is also known as student t-test. This question has came in last NEET also, but with a different, of course, question frame. And we have again and again discussed that whenever there is two group and we are measuring something which we can monitor like C-reactive protein level, then we can apply student t-test or unpaired t-test. Okay, but if there is three or more group, we will apply ANOVA. If the data is pre-post, before, after available, then we apply paired t-test. Okay. Next question was that in the Nalgonda technique, what are the things that we use for defluoridation? To remove the excess fluoride, we use Nalgonda technique, which we have three things: lime, alum, and bleaching powder. So of course, alum and lime option will be better option, but ideally the correct answer will have lime, then alum, then bleaching powder we add. So ideally it should have all the three things, which was not there. Then they are saying that if someone is having skeletal fluorosis, and skeletal fluorosis is something which will happen if the fluorine level is more than 10 in water. In that case, what dietary measure can decrease fluorine? So if we have high calcium, high vitamin C, which is acting as antioxidant, plus some other antioxidant rich diet also, that will decrease the absorption of extra fluorine. So that was the answer here. In the next case, they are saying that if there is high fluorine in water, we know that, then which step is not helpful in management of that thing? So if we change water source, we can have another water source with less fluorine. If we are using water from river or spring, usually fluorine is more in deep well, bore well, because fluorine comes from a lot of stones also. So it can have high fluorine, deep well, bore well. But flowing river can have low fluorine level. So using water from flowing source, it can also be helpful in managing high fluorine level. Identifying and treating fluorosis, that can also help. But use of only alum will not help. It should have all the three things: lime, alum, bleaching powder. Only then fluorine will be less. If you add only alum, it can further increase aluminum level also in the water. So it is not so helpful thing. We need to have all the three things, only then defluoridation by Nalgonda technique can occur. One more thing they were asking was that if there is rickets in a child and there is history of no sun exposure, which program can help us? So of course, in this case, the initial screening can be done under Rashtriya Bal Swasthya Karikram. But after that, she need the food which is rich in calcium, and food is provided in Anganwadi program under ICDS. It is ICDS because Government of India mixed education with food. So that's why it is integrated child development. Earlier it has Anganwadi and midday meal both. Now midday meal is known as PM Poshan, and ICDS is the one which is Anganwadi. So why not midday meal? Because the age is 4 years only, and so probably she will go in Anganwadi only, probably for sure. Up to 6 year children go in Anganwadi, and Anganwadi come under ICDS. So that's why the answer is ICDS. Then the next question was ki, there was a mosquito larva which is floating parallel. So I hope this was a big hint, because Anopheles do not have breathing tube. Siphon is not there, so it has to come on the surface to breathe, whereas Aedes and Culex can keep hanging from the water surface. Second hint was given was that it has lateral abdominal hair. So this also corresponds to Anopheles larva. Let's see what Park is writing here. Park is writing the same two things: no siphon tube, resting parallel, and palmate hair present on abdominal segment. These are clear signs that it is Anopheline mosquito. Plus remember, Anopheles is the one with spotted wing, not Aedes. Okay. Then this is the picture also in the Park. You can see this is the Anopheles larva floating parallel and hair also in the abdominal segment. Now they were saying that if we are giving 60 milligram of elemental iron and 500 microgram of folic acid to adolescent girl once a week, blue tablet, under which program it will come? Anemia Mukt Bharat. Probably this was not the question. The question was, they were asking that, let me go to that question. yes, this was probably the question ki what is the dose of iron and folic acid which we give in adolescent? This is a NICT repeat PYQ. We give 60 milligram of elemental iron, 500 microgram of folic acid in 10 to 19 year age, blue tablet once a week. Okay, then this was the question of POSCO Act, which is also taught in PSM. And in the POSCO Act, we have all the children under 18 year are covered under POSCO Act. And you can see it from PARC also, they have written any person below 18 year is covered. So it's not for male or female, it's for both below 18 year, not 16 year. Okay. Then in this question, they are saying that a patient has history of palpitation, breathlessness, pedal edema, and he saw of high output cardiac failure. High output cardiac failure is congestive heart failure, and along with that there is dyspnea, pedal edema. So this is all suggestive of wet beriberi, and wet beriberi is due to thymine transketolase enzyme deficiencies also, and this is directly the answer. I hope you would have done it correct. Now, if in that question they have not given 34-year-old female, they have given a HIV positive mother who is getting the treatment lifelong. And if it is lifelong treatment given, then we can think of giving nevirapine only till 6 weeks. But again, the main thing is we want to do the breastfeeding. And in India, we do breastfeeding is allowed also. So in case of breastfeeding allowed, we can start nevirapine and continue exclusive breastfeeding. But nevirapine plus zidovudine, these two has to be given till 12 weeks. So I think the real question was the one which we already discussed earlier, that for how long we have to give it, for 6 weeks or 12 weeks. If breastfeeding is there, we have to give it till 12 weeks, especially if the viral load is more than 1000, like the viral load was 1200. So we have to give it till 12 weeks. Okay. Chalo. Yes, do sawal mix ho gaya hai. Yes, I know it was not the same question and the recall is not adequate. That's why we will have a detailed session with better recall within a week. Okay. Next question was that if the vaccine vial monitor question are there, I hope you all must have done this correct. That if they are writing that inner square of the vaccine vial has darkened. So if inside is darker as compared to outside, then we discard it. But they are saying inner square has darkened, but it is still lighter than the outer circle. So that means inner square is also having some darkness, but the darkness is less than what compared to outside. In this case, we can use it. If it is same color, we don't use it. Or if it is inside darker, we don't use it. So use the vaccine as it is still potent, and we can sequel and we can use the vaccine. We have to discard it if it is same color or inside is darker. Okay. Okay, so we have already done this question of anemia mukt. One more question was that according to Indian dietary guideline, what is the recommended daily cholesterol intake relative to energy consumption? So the dietary guideline that we especially prescribe to all the cardiovascular disease patient is known as prudent diet also. And they clearly say that the fat intake should be less than 10% of total energy intake. So here the cholesterol intake should be less than 10%. If the total calorie is 1000, 10% of 1000 is 100. So it should be less than 100 per 1000. That is the correct answer, undoubtedly. Okay. Then, of course, we have done this question. So the next question was, which vaccine to prevent cancer is being approved in the national guideline? So national guideline has approved HPV vaccine to prevent cervical cancer. This is HPV vaccine which has been approved, is given 1 dose only, and this 1 dose is given only to girls as per national guideline approved in India. Of course, in developed country it is given to girl and boy both, and 1 dose given to girl between 9 to 14 year. Okay. So this is one HPV vaccine which is approved. I hope you all know HPV 16, 18 are most common strain. And if you find E6, E7 subunit in the blood, that is more suggestive of cancer. And L1, L2 subunit is used in the vaccination. Okay, so we have done this anemia thing. Now, in the RCT, what is the correct sequence of event? So PARC textbook has clearly written it that in RCT, the first step is drawing up a protocol. After that, we select reference and experimental population. Reference means control group, experiment means intervention group. Then we do randomization. After selection, we do randomization. Then we do manipulation. So after randomization, there is manipulation. Then we do follow-up, and last is assessment. And this is direct 28th edition Park textbook lines. So protocol, selection, randomization, manipulation, then follow-up, and finally assessment. Okay. We keep on discussing these topics of case control study sequence has already been asked. So it was expected that they will ask RCT sequence, which they did. Okay. Next question was that, we already have done. So in the cardiovascular disease guideline, the saturated fat should be less than 10%. So less than 10% means it should be the calorie coming is less than 100 kilocalorie per 1000. Okay, this is not a correct one. The correct one was what we already discussed. Now, one more thing they are asking here is, we want to know whether the target has been achieved or not. We want to access the quality and impact of result. So we are trying to assess the final thing, and final thing are assessed by evaluation. If you look at the Park also, Park has also clearly written that achievement of stated objective of a program is evaluated, is compared with the help of evaluation. Let me explain. This is again a repeated PYQ. Difference between monitoring, evaluation, surveillance is very easy to understand. Monitoring is day-to-day activity. Let's say you are in a relationship. Every day your boyfriend or girlfriend check your phone. What have you done on Instagram chats and other thing. That is monitoring. Surveillance means close monitoring, very close monitoring. Like your Instagram password is with your boyfriend, girlfriend, that is surveillance. They already know what is you are doing. And if you are not checking it daily, but every 3 months once your boyfriend, girlfriend is in bathroom, you are taking the phone and checking all the things which has done in last 3 months. So it means you are evaluating the final outcome of 3 months. That is evaluation. Okay. So here, because they are looking for the final outcome, the target achievement, so definitely the target achievement is the thing which we do in evaluation. Then one more question was that they are saying that early screening test is useful in case of breast cancer. But finally, they are finding that in the mortality, there is no difference. That means early screening test was not so useful. This is known as lead time bias. I hope you know lead time is the time gap between early screening test and usual diagnostic test. And in that time, if we can do some surgery and we can save the life of the patient, then there is no lead time bias. But if we are not doing any intervention, or if the early screening test is done after the cancer is spread, then early screening test is not useful, and that lead time only lead to bias. So lead time bias simply means that we are doing early screening test, but it is not helping in survival of patient. Still the mortality rate is same. So that is and that is the point of lead time bias, that lead time is useless. Lead time is a bias. Okay, that means screening test is not helping in improving the survival of patient. Okay, then this was again a repeated question, that if we want to know the time period between entry of pathogen and maximum infectivity, this is known as generation time. Incubation period is entry of pathogen and appearance of first symptom. Serial interval is passing of infection from one person to another. What is the time taken in that? So here it was generation time. Okay. So that's all. Thank you so much. Love you all. We will come back with a detailed explanation with better recall within this 1 week. Okay. Thank you so much. Love you all. Thank you. Thank you.
Thank you, Ashwini sir. I'll take over and we'll start off with Psychiatry Chatpat. So everybody, can you hear me and see me? Please confirm. Can you hear and see me? Chat में please जुड़े रहें so that I will know that you can hear me and see me. Give me a thumbs up and then we'll go in a rapid speed all the way.
हो गया मेरा, बंद कर दे.
Guys, audible? Visible? Thumbs up? All right, awesome. So, kaisa tha psychiatry? How was it? Surprisingly, out of all the minors, there was a lot of weightage to psychiatry. I am very happy. How were you feeling about it? Definitely moderate intensity tha. Didn't seem like a very super difficult, no curveballs, no googlies there. And at the same time, a lot of PYTs and PYQs, correct? Some cut copy pasted from even a more recent exam of FMGE. So, सब मन से बना के बोल रहे हैं कि एक भी ऐसा क्वेश्चन नहीं था. अच्छा, ओके, ऑलराइट. सो विल फोकस. क्या क्या टॉपिक्स थे? सरप्राइजिंगली सब्सटेंस नहीं पूछा गया फॉर द फर्स्ट टाइम, ऑल्दो दैट हैज ऑलवेज बीन ऑन द टॉप. इस बारी देयर वर क्वेश्चंस फ्रॉम पर्सनालिटी डिसऑर्डर, स्ट्रेस एंड ट्रॉमा में से थीम थी. डिसोसिएशन, जो कि एफएमजी में भी पूछा गया था. साइकोफार्माकोलॉजी, ऑलवेज अ फेवरेट. एंड स्किज़ोफ्रेनिया एंड एमएससी से भी क्वेश्चन था, मेंटल स्टेटस एग्जामिनेशन से. सो शुरू करते हैं, लेट्स गो. Confirm if this was there or not, and we'll solve it simultaneously. A friend of Mr. K is reporting that Mr. K is very much obsessed with his schedule. He is very rigid about perfection, and he keeps on managing everything extremely systematically. He's been doing this since a very long time. Since when? Since his young age, adolescence, teenage say. And he does not agree with his friend, and he's not ready to seek any therapy for the same. What is the probable diagnosis? Is he narcissistic? Is he dependent personality disorder? Is it obsessive compulsive personality disorder? Or is it an avoidant personality disorder? क्या mark किया आप लोगों ने? What did you all mark? Guys, this is something that we have covered in the lectures very properly, that people with obsessive compulsive personality disorder are extremely punctual, very particular, very rigid, perfectionist, parsimonious. So this is very hallmark, very pathognomic of obsessive compulsive personality disorder, not OCD, OCPD, obsessive compulsive personality disorder, also sometimes called anancastic personality, right? So I think a lot of you all got it, right? Perfect. C is the right answer. Absolutely. Let's go. Next. तो ये हमने ऑलरेडी टॉपिक पढ़ा हुआ है, बहुत अच्छे से पढ़ा हुआ है, राइट? बहुत प्रिडिक्टेबल सा था. And I keep saying personality disorders are very important. Next was a patient. ये क्वेश्चन था कि नहीं, पहले मुझे ये thumbs up देना. Patient is brought to the hospital with a bizarre presentation by a social worker. The social worker reports that he's been living in his town and actually he belongs to some other nearby town. And after a recent earthquake, stressor, he was brought here. He doesn't remember his identity and how he reached 110 kilometers away from his home. There is no history of substance abuse. Family members are concerned about his condition. What is the diagnosis? Dissociative identity disorder, dissociative amnesia, dissociative fugue, or depression. Now, clearly, guys, depression तो नहीं है. Dissociative में से कौन सा वाला है? What is your answer? What did you all reply? Did you write DID, dissociative identity disorder, amnesia, or fugue? क्या reply किया आप लोगों ने? क्या आंसर किया आप लोगों ने इसमें? Yes, the previous answer was OCPD, correct? Well, this is another thing that we have done in detail, where we've talked about a person traveling really far away. पूरी स्टोरी सुनाई थी मैंने आपको, and उसको ये नहीं याद है मैं कौन हूँ, मैं कैसे यहाँ पे पहुंचा, और I don't have any recollection of that. So he's traveled away from home, has no memory, and has forgotten. So amnesia is a part of it, and may also take a new identity. So confused नहीं होना है, ये dissociative fugue है. Fugue is the right answer. Identity disorder नहीं है, क्योंकि fugue के अंदर amnesia और identity disorder दोनों ही हो सकता है. Understood? So the answer is dissociative fugue. Everybody, thumbs up to fugue. सबने fugue mark किया है? Dissociative fugue is the right answer. ये FMG में बहुत cut copy paste question आया था अभी recently. एकदम ditto. Okay. Alright guys, moving ahead. ये दोनों question यहाँ थे. ये confirmation is really helpful. Can we move on to the next question? Once you give me a thumbs up, we'll move on to the next question. I have about 6 questions. I'm down with 2. और रह गए 4. Come on guys, wake up, tell me था कि नहीं. We'll quickly finish it off. Okay, ये question actually already आपके साथ discuss हो चुका है फार्मैक में. सिराज सर ने ऑलरेडी ले लिया है, मैं सीधा आंसर बता रही हूँ. I saw Siraj sir take it up, that a patient of schizophrenia is on haloperidol and he was responding well for a long period of time. Now he's presented with orofacial dyskinesia, choreiform movements, and possible dystonia. So he has something called tardive dyskinesia. What is the problem and what is the treatment? Since it is tardive dyskinesia, अगर आप diagnosis कर पाए तो आप treatment भी कर पाएंगे. So this is the right answer. Again, something that we have already discussed. This is something we हमने PG marathon में discuss किया था. We had talked about the treatment in PG marathon. You should be able to diagnose it, and then once you can diagnose it, you can give the answer. Correct. XYZ is too correct. So we have 3 down, right? And I hope your strike rate was excellent till now. अगला, a 21-year-old female, ये थोड़ा tricky है, लोगों ने थोड़ा सा गड़बड़ किया है यहाँ पे, so just hear this properly. 21-year-old female presents to the emergency department with complaints of amnesia of events of for the last 2 weeks since she lost her father due to road traffic accident, and she also gets flashbacks of the events frequently. What is the probable diagnosis? Is it dissociative disorder? Is it PTSD? Is it acute stress disorder? Or is it major depression? देखो डिप्रेशन नहीं है क्योंकि लो मूड वगैरह नहीं लिखा हुआ है, although there's a death. डिप्रेशन नहीं है clearly. Now you tell me, dissociative disorder किस किसने लिखा, PTSD किस किसने लिखा और acute stress किस किसने लिखा? What is the answer that you all have written? XYZ says C. Okay, it is not dissociative disorder. Just because there is amnesia doesn't mean that it fulfills the entire criteria. Between PTSD and acute stress disorder, this is clearly acute stress disorder because of the duration of 2 weeks. Okay, this is again something that we discussed, a very similar question where the answer I had discussed very categorically कि timeline जरूर observe करना. Less than 1 month है तो acute stress है, और अगर more than 1 month है तो PTSD है. तो ये PYT में आया हुआ है, PY previous topic है जिसपे हमने already discussion की हुई है. Acute stress disorder is the right answer. Acute stress disorder. Great. All right. Zoning down to this one. A patient sitting outside his home believes that whenever a bird is chirping, जब भी एक bird चींची करती है and flaps the wings, he has to follow the birds. He says that he's getting instructions from the god and he will be harmed if he does not follow the birds. What is the probable diagnosis? ये MSc से है guys. So is it a primary delusion? Is it a delusional perception? Is it a delusional reference? Or is it a hallucination? Dr. Kabir says primary delusion. Okay. Doctor, do you want to try and think of it from a different point of view? Something that we have discussed again in the 2.0 very clearly in our longer notes, that delusional perception is when a normal thing is given an abnormal meaning. So notice that birds anyway chirp and anyway flap their wings. That's a normal thing. And this normal thing has been given an abnormal meaning altogether. When it comes to instructions from God and all, that is all the secondary part of it. That's the secondary part of the delusion, which is why we will not have delusion of persecution or reference or anything else. Delusional perception is the right answer. Guys, if there's any changes in the question, obviously we'll fix it. We'll come back with a refreshed one. थोड़े से दिन में we do fix it and we will obviously update you. So far, I believe सब कह रहे हैं कि यही questions हैं. Psychiatry में 6 question आए थे, almost we are done. We're on the last one. A person commits a crime, but upon evaluation, he says he heard voices asking him to kill. So command hallucinations. There were voices commanding him. And he also had a disheveled appearance. So probably has schizophrenia, right? Most probably the diagnosis. What is the next legal step? Should you just make him undergo the trial? Should you send him back? Should you take him to a psychiatric evaluation before deciding on a trial or convict him? The answer here was, again, take a psychiatric evaluation before deciding on trial. Definitely the answer. And we have covered it under the capacity and under the Durham's and the McNaughton's rule in our lectures. Transient global delusion was an option. Okay, transient global delusion is not the right answer. So thank you for sharing. I'll just add it to the notes. Thank you so much. Transient global delusion was one of the options. Thank you for sharing that. Thank you. Right. So we are done. And that was that. I don't think I've missed out any questions. I'm here for a second or two. If you want to share something that I missed out, if you want to add something, please let me know. And कैसा था आप लोगों का? कैसा strike rate आप लोगों का रहा? Any other questions? Any comments? Any clarifications? Of course, we will come back in a few days, guys. I want to pace it up so that I can give the time to the next faculty. कुछ भी है तो पूछ लो, मन में कुछ रह गया है तो पूछ लो. All right, guys, we'll take up your doubts soon. Thank you, Dr. Sandeep. Over to you.
Thank you so much, ma'am. All right. Hi, guys. Good evening. Good evening. Good evening. I hope everybody is able to see me, hear me. Okay. Now, surgery was fairly straightforward questions. Most of them has been through your previous year questions or topics. No bouncers as such, whatever questions I could recall. Let's quickly do the questions, look at the answers, give me here and there, whatever you have your input, and we'll wrap it as early as possible. So the first question, I think this was an image that we had. Something with related to TNM classification, there is erythema present. So that's what I've been told on the breast. If the erythema is present, it is going to be your inflammatory breast cancer, right? And we all know inflammatory breast cancer belongs to, right? So we have inflammatory breast cancer. If you know, the inflammatory breast cancer belongs to T4D category, correct? This is going to be T4D category. So obviously here the answer is going to be D for Delhi, nothing less, nothing more, correct? Clear, guys? Right? So this is going to be your T4D. Everybody got it right? Nothing wrong about it. We've already discussed this in our NEET PG marathon series. I've given you very clearly that T4A is involvement of chest wall, B is skin, C is A plus B, and D it is going to be your inflammatory breast cancer. So there was limited breast skin inflammation. See, if the breast skin inflammation, as you can see here, if it involves more than 1/3 of the breast skin, then it qualifies to be as inflammatory breast cancer. So you have to give me a little bit more on this. But if it is there of an image like this, where more than 1/3 of the skin was involved, the answer is going to be T4D. Agar less than 1/3 hai, then you have to give me other inputs. Did it look like POD orange? If the POD orange was there, it is skin involvement, then it will become T4B. Okay, then it will become T4B, right? So help me up here. If you have a skin involvement of more than 1/3 of the breast skin, ठीक है, अगर POD orange, देखो either the skin जो infiltratives है, it will either categorize into T4B or T4D. If it is more than 1/3 of the breast skin, you are a better judge. Give me an input on that. Now, the next question that I had, I think everybody knows it. It is like the patient had this presentation where the image of the barium swallow was given, lower esophageal sphincter was constricted, and then the investigation is there. This is your rat tail appearance, or I can say, you can call this as rat tail appearance. You can call it as the bird beak appearance, or you can call it as the pencil tip appearance. Many things that we have already discussed it. So basically, all these points towards the diagnosis of achalasia cardia. We have discussed in detail about achalasia cardia in our recent marathon also. And I told you in achalasia cardia, the investigation of choice is going to be manometry for diagnosis. Okay? So answer here is going to be manometry. We have already discussed this question previously also. Nothing spectacular about it, right? The next question that we had a patient with a stab wound to the abdomen. On examination, there's hypotension. Now, whenever the patient is in shock, I say hemodynamic instability is there. Tenderness suggestive of peritonitis. Now, this is a warning sign also. So whenever there is this, you have to go with exploratory laparotomy. And see, FAST is for blunt trauma, DPL is for blunt trauma, CECT in stable patient. None of them is going to be correct. Correct. So here we already discussed both. I mean, the exact set of question I've discussed in this NEET PG's 2025 session only. Okay. The next question that we had is a 60-year-old patient presented to the OPD with jaundice. On examination, there are scratch marks. This is because of the elevated bilirubin level. Palpable gallbladder indicating Courvoisier's law, and it is non-tender. Now, Courvoisier's law is going to be for periampullary carcinoma, right? If it was a distal cholangiocarcinoma, I could have agreed to it, but here the answer will be pancreatic. Head cancers, I've already discussed that as well. Okay. We have already discussed the exact subset of the question in our this thing also, right? In our NEET PG marathon. Another one that you have, a patient presented with anal cancer below the level of dentate line. Help me up if this is the right wording of the question. What is the most common lymph node involved? See, the most common lymph node involved below, I've already told you, it is going to be inguinal. Above, it is going to be pararectal group of lymph nodes. But now, is it superficial or deep? Remember, answer here is going to be superficial inguinal group of lymph nodes, right? So below the dentate line, which is a squamous cell cancer, they spread to the superficial inguinal group of lymph nodes, and that would be the right answer. Correct? Chalo. The next question that you have, a patient presented with abdominal pain on examination is associated with liver enlargement. Biopsy is obtained from the lesion, CCT image is given. Now, the problem in this question is focal nodular hyperplasias are usually asymptomatic. They're incidentally found, and once you confirm it, they don't even require treatment. But if you have an abdominal pain, liver enlargement, they don't sit with focal nodular hyperplasia. But anybody can recall, was the CT image something like this? Was the CT image something like this? A quick feedback. ऐसा कुछ था क्या CT image में? Was there a CT image like this? No. Was there an MRI image? Gross specimen was given. ठीक है, तो image नहीं था, gross specimen था. Okay, you had a gross specimen. ठीक है. Gross specimen में did the center of the specimen had a fibrotic scar, something like this? Center of the specimen में fibrotic scar था. ठीक है. If the central stellate scar was given, then the answer to this question would be focal nodular hyperplasia. ठीक है? ठीक है. Then the answer will be focal nodular hyperplasia. ठीक है? We have already discussed on the central stellate scars which are present. So in that context, ठीक है? चलो. According to the Parkes classification, how would you classify the following fistula? What can you identify from the image which was asked? I've given you ABCD as an option. कौन सा पूछा था? Can anybody give me, according to the Parkes classification, this was the image given. What was the exact coefficient that was asked? Okay, this is your internal anal sphincter. So this is your internal anal sphincter. And this happens to be your external anal sphincter. So was the tract running between the two sphincters? If the tract was running between the two sphincters, then it is going to be intersphincteric variety. That is A for Ahmedabad. Okay? It is going to be an intersphincteric variety. Correct? Okay? If the tract was running between the two sphincters, it is an intersphincteric variety. Got it? Chalo, great. Now, they've asked you another question. Which of the following statement is true regarding the suture material given? If the suture material was given as PDS, remember PDS suture material, it is monofilament. It is monofilament. If it is monofilament, you cannot have braidedness. So it is non-braided. They are non-braided. These are absorbable. These are absorbable. And all monofilaments have high suture memory. So the question was like, which of the following statement is true? Monofilament is true. Beaded is not. It is absorbable. It has high suture memory. So answer here is A for Ahmedabad. Was this the question? Was this the question? Okay, great. Now, next question. A patient developed carpopedal spasm on the second day following a total thyroidectomy. A classical case. We have already dealt with it. A classical case of post-operative hypocalcemia due to accidental damage to your parathyroid gland. So it is not because of recurrent laryngeal nerve injury. It is not a thyroid storm. It is hypoparathyroidism. Is correct, not hypothyroidism. Answer here is going to be C for Calcutta. Okay. Option was carpopedal spasm. Achha, in the option, the carpopedal spasm was given. Okay, gross specimen tha, nahi samajh mein aaya beta. Okay, this question needs to be reconstructed. Carpopedal spasm was given in the option. Correct? ठीक है. Neck mass was excised in 3 days. What complication is likely to seen? Acha. Okay, then we have to reassess this question. ठीक है? On day 2 to day 5 के बीच में usually hypocalcemia वाला feature मिलेगा. That is going to be your damage to the accidental damage to parathyroid gland. ऑप्शन में कार्पोपेडियल स्पैज्म था. ठीक है, ठीक है, got it. Okay. Right, a patient with circumferential full thickness burns over the right lower limb is developing a progressive pain, pallor, and decreased distal pulses. That means it is gripping. So it is going to go into acute arterial occlusion. So what is the most appropriate management? I have to relieve that component, and that is what we call it as escherotomy. So not the elevating the limb, not IV antibiotics, perform escherotomy. We've already described in our regular lecture also that escherotomy is done to save the component. Okay? So not the grafting. Next question, this we've been asking again and again. Look at the knot itself. I've already explained you in our NEET PG marathon. Also, this is going to be a classical question of your surgeon's knot, which is going to be the most stable knot. 2 loops on top, bottom, and 1 loop on top. Okay? Chalo. Next question. This was again discussed. If you have gone to my regular lectures or if you have seen a NEET PG marathon, you would get the same context. सिंपल वाज आस्क्ड नॉट सर्जन. बेटा आर यू श्योर? इनमें से देखो मैंने आपके सामने 4 नॉट्स रखे हुए हैं. कैन यू आइडेंटिफाई विच नॉट वाज देयर? और द 4 नॉट्स दैट आई हैव शोन यू हियर, विच नॉट वाज गिवन इन द एग्जाम? 1 2 3 4 में से बता दोगे? कैन यू टेल मी विच वाज आस्क्ड? Javed says 1. Anybody else? Because most 4th. बेटा सी इफ हाँ अगर 4 दिया था then it is surgeon's knot. ठीक है, then there is no question. ठीक है, कोई डाउट ही नहीं. Yeah, because most of the people who have messaged me also, they have said surgeon's knot only. ठीक है. Now, in the laparotomy, a surgeon invariantly causes injury to a structure posterior to the foramen of Winslow. Now, foramen of Winslow के through जब आप access लोगे, you will take portal triad. तो portal triad में, so the injury to the portal triad cannot happen because posterior to foramen of Winslow, foramen of Winslow के anteriorly portal triad है, posteriorly IVC है. तो IVC is the most likely cause. ठीक है. Abdominal aorta is going to be far away from it. It is on the left side, so not happening. Portal vein is on the anterior surface. Hepatic artery is on the anterior surface. So answer here is going to be A for Ahmedabad. Okay. It's again we have discussed it in very clear format. कि foramen of Winslow के through when you access लेते हो, anterior to foramen of Winslow you have portal triad. Posterior to foramen of Winslow you have inferior vena cava. ठीक है. चलो. Now this was a question which was slightly tricky. A lot of you were continuously messaging me. According to the Strasberg's injury, was this image given, guys? Because we've already given the entire detailed bile duct injury in our lecture also. ठीक है, जो हमने NEET PG marathon किया था उसी में पूछा हुआ था. I've discussed there also. Now my question to you is, was the image given same? यही image दिया हुआ था? Was this the image given? Yes, the image. अगर ये image है, it is Strasberg's A. It is type A. अगर ये इमेज दिया था, इट इज स्ट्रासबर्ग टाइप ए. अगर यहां पे अगर कुछ कटा होता और यहां से बाइल डक्ट लीक आ रहा होता, देन इट वुड बी स्ट्रासबर्ग सी. ठीक है, तो ए और सी में आइडेंटिफाई करना बहुत इंपॉर्टेंट है. ये देखो, आई टोल्ड यू सी में कहां से लीक आ रहा है. यू कैन सी राइट अक्रॉस हियर. ठीक है, सी में लीक इज फ्रॉम द सेक्टोरल डक्ट, whereas ए में इट इज गोइंग टू बी फ्रॉम द लिवर्स बेस, ऑल्सो फ्रॉम द सिस्टिक डक्ट. ठीक है, स्मॉलर जो कॉम्पोनेंट्स है. So this is your Strasberg's A variety. Now, the next question that you have varicose vein पे देख लो. An image was given. I think the varicose vein का image दिया हुआ था. And which of the following statement is correct regarding this condition? Identify the options and let me know what is correct. We have already discussed that in our class also. Varicose vein are only cosmetic, have no complications. This is wrong. Varicose vein can lead to eczema and pigmentation. This is correct. Sclerotherapy is a treatment of choice. No, sclerotherapy is only done if the size of the vessel is less than 3 millimeters in diameter. Surgery is contraindicated in symptomatic. No, surgery is actually the mainstay for symptomatic component. So answer here is B for Bombay. Were these the options? Options यही था. C6 was also in the option. C6 is going to be an active venous ulcer, na beta? C6 is going to be an active venous ulcer. So one of the option you're saying is C6. Stage 6 was given in the option instead of first. इमेज वाज देयर, ठीक है, आई गॉट द आइडिया, समथिंग इमेज ऐसा वैरिकोज वेन का इमेज दिया हुआ था, ठीक है, बट देयर वाज नो अल्सर. ओके, इमेज वाज देयर विदाउट एन अल्सर, ठीक है, इमेज प्रेजेंट है, नो अल्सर, ठीक है. Pelvic tumor is the most common cause is wrong. It is because of congenitally weak valves. ठीक है, fine. So options has to be revisited, but mota mota hi tha. Pelvic tumor is the most common cause for unilateral varicose veins. Or the whole option. Okay. Kuldeep, got any more options? Can you recall? Look if you can recall any further options. I'll just mention it here. One of the options were pelvic tumor is the most common cause for unilateral varicose vein. ठीक है. B and C are seen. That's it, sir. Okay, great. Got it, guys. Chalo. A child is evaluated for congenital hypothyroidism. Image reveals normal location of the thyroid gland. If it is normal, then it cannot be ectopic thyroid gland. No radio tracer uptake or technetium or iodine thyroid scan. What is the most likely diagnosis? Okay. Now, when you say the image reveals a normal location, so thyroid agenesis cannot happen. This hormonogenesis where deficiency of thyroperoxidase enzyme, where even if you're giving iodine, it has not been uptaken. Dysgenesis is not the answer. So answer here is most likely to be thyroid dysharmonogenesis. Okay. Iodine symport defect was also there. Then that will be the better answer. No, agar sodium iodine symporter defect ho jayega. Agar sodium iodine symporter defect is present, then this will be a better option. Can you recall, was this the option given? हाँ, अगर fourth option sodium iodine symporter defect है, then this will become the better answer. ठीक है, then the answer will become then D. So this is not there. Sodium iodine symporter defect. Then the answer will become D for Delhi. ठीक है, चलो great. Now I think ENT में already आपके साथ discuss हो रखा है submandibular gland के surgery में. What were the nerves damage in submandibular gland excision? So you can just see if you have already gotten this question. Have you discussed this question in ENT already? Submandibular gland excision में कौन-कौन से nerves हैं which are going to be damaged, that is lingual and hypoglossal nerve. ठीक है. अच्छा, was this question asked, beta? Can you recall? Was there an image asked for angular dermoid today? Was this asked? Angular dermoid आज पूछा था क्या? Okay, so great. So this was an spotter angular dermoid. Great. ठीक है. अच्छा, ऐसा कोई क्वेश्चन पूछा था, द मैनेजमेंट ऑफ फियोक्रोमोसाइटोमा? फियोक्रोमोसाइटोमा का मैनेजमेंट पूछा था. Was this question asked? ठीक है. Yes, first line में first alpha blocker, that is phenoxybenzamine, then followed by beta blocker. Correct? ठीक है. करेक्ट. प्री ऑपरेटिव बेटा, यही फर्स्ट लाइन मैनेजमेंट है, प्री ऑपरेटिव. ठीक है. फाइमोसिस पे कोई सवाल आया था? एनी अदर क्वेश्चन दैट दे आस्क्ड यू? फाइमोसिस पे कोई सवाल आया था? Was there a question? Foreskin was not able to retract. ठीक है. अगर फाइमोसिस के साथ साथ if there's a white discoloration, then the answer will become BXO, that is balanitis xerotica obliterans. ठीक है. Progressive stenosis and image was given. Was there any diabetic history, beta? Was there any diabetic history? कोई डायबिटीज का हिस्ट्री था? वाइट था. ठीक है. रिमेंबर अगर फाइमोसिस के साथ if the foreskin's edge was having a white rim, sorry guys, if there was a white rim, ठीक है, if it was white rim, then the answer would be balanitis xerotica obliterans. If only the foreskin was fused, then the phimosis there. अगर phimosis का white rim होगा, then the answer will be BX, or else balanitis xerotica obliterans. There was a white rim, ठीक है. अगर calcification है, that is, then it will be okay. Chronic component हो जाएगा. Meatal stenosis was also an option. But meatal stenosis cannot be the answer here. अगर foreskin fused है, then it is going to be phimosis. Paraphimosis retracted skin है बेटा. ठीक है, इतना देख लेना. White rim था, diabetic की history थी. अगर if it is added with diabetes or any other component, then the answer would be BXO. अगर नहीं है तो सिर्फ phimosis है. ठीक है. Meatus was visible. Upper cross was not there. Previous question में only half of the surgeon not part. देखो बेटा, कहीं पे अगर नीचे 2 लूप बना हुआ है ना, तो surgeons not है. अगर white rim present है तो BXO बेटा, you are the better judge, you took the exam, so you should be able to help me better. ठीक है. So all in all, there were like 20 odd questions that we had from surgery today. ठीक है. So that's the 10% of hypospadiasis, phimosis, meatal stenosis were the options. Better than the phimosis will be the answer. BXO option में था कि नहीं था? Was BXO in the option or not? BXO option में था कि नहीं था? It was there. बेटा अगर white rim के साथ है, then the answer is BXO. If it is not having a white rim, then the answer is phimosis. ठीक है? You know the options. I've given you the clarity here. You decide and let me know. ठीक है? चलो. So that's all from my end. It was a quick catch up for you. So I finished all the questions and their answers. I'll try to reconstruct it in a better form. I'll share the PDF also. So they're not given, so rather single row with 4 knots. बेटा अगर 4 लूप्स दिख रहे हैं ना, 1 2 3 4, ठीक है, अगर 4 लूप्स दिख रहे हो, सर्जन ही है. यू कैन सी 1 2 3 4. यू गो हियर, यू सी 1 2 3 4. अगर 4 लूप्स दिख रहे हैं भी नीचे ऐसे नॉट की तरह बोल रहे हो, देन द आंसर इज सर्जन्स नॉट. ठीक है, चलो. बेटा paraphimosis cannot be the answer. Paraphimosis is going to be retracted skin होगा. वो glans, it will be below the level of glans penis at the level of your exactly ridge. Okay, चलो. coronal sulcus के अगर नीचे मिलेगा तो paraphimosis है, right? चलो. So thank you so much, guys. I will hand over to the next faculty. This was the surgery recall that we had. Thank you so much. Have fun.
Thank you so much, Sandeep sir. I hope I'm audible and visible. Thank you. So yes, so now let's do a quick recall of dermatology questions that came for the NEET PG exam. I hope all the thank you so much. Kuldeep, I guess Sandeep sir has left. So I'm sure that he will be responding you through our Telegram groups. Okay. And yes, so now let's do a quick recall of dermatology. As it was not very typical questions that we got this time in dermatology, but let's see one by one, because if your basics were strong, it was quite attemptable. So now let's see the first one. Patient presented with a itchy rash on the elbows and buttocks with a recent diagnosis of gluten-sensitive enteropathy. On immunofluorescence, IgA deposition is seen. Yes, Dugu is saying that the answer is A. And I also agree with you, because this is again a pretty direct question, right? Because whenever you get a patient who has itchy papulovesicles, especially when it is associated with celiac sprue, like celiac sprue or gluten sensitive enteropathy, that is going to be dermatitis herpetiformis. So in the question, exact question with the same option. Thank you, Kuldeep, for confirming. So here what has happened is, now in this direct immunofluorescence, you can see that the greenish discoloration, like the fluorescence has been taken up at the dermal papilla, right? So there is a granular IgA deposition at the dermal papilla. This is going to be very typical for dermatitis herpetiformis. Definitely, when you say IgA, linear IgA should not be the option. I hope that all of you has got this right as well. Yes, same image, says Dugu. Thank you so much. So I guess there is no confusion with this question. So I believe that most of you have got it right as well. So we have discussed the same thing multiple times during our lectures as well. Thank you, Javed. So now let's see the second question. So in the second question, a patient has freckles, severe photosensitivity, and he has developed basal cell carcinoma lesions. Which DNA repair mechanism is most likely impaired in this condition? Now, when you read this thing, so what should come to your mind is that first you have to reach out to a diagnosis. Kyunki in this MCQ, the examiner has not given you the diagnosis, which is a disease where you have freckles, photosensitivity, and also the patient is prone to a lot of pre-malignant as well as malignant conditions of the skin. What could be the diagnosis here? Was this the same kind of a question which was asked? Yes, very good. Javed is saying that this is going to be xeroderma pigmentosum. Xeroderma pigmentosum. So that is correct. So this is going to be xeroderma pigmentosum. So xeroderma pigmentosum, this is a autosomal recessive condition where a patient will be having severe photosensitivity. The patient can also have photophobia, isn't it? Freckles over the skin, hyperpigmentation, and there is 1000 times increased risk of malignancy. And there is a 1000 times increased risk of malignancy as well. So in these cases, what is happening here is it a mismatch repair, nucleotide excision repair, or non-homologous end joining, or base excision repair? What would you think is the right answer? So remember that this is a nucleotide excision repair defect. Okay, that is a defect that you can see, that is NER defect can be seen in cases of xeroderma pigmentosum. Yes, Dugu has got it right. So that is about this question, where the question was about xeroderma pigmentosum. Interestingly, the diagnosis was not given, and this is a bit different from when it comes to the actual question. It is a bit different because this time they asked you what is the DNA repair mechanism defect that is going on. So now let's see the next one. I think that this question may be taken up in micro as well, isn't it? So what is this? Painful vesicles appear inside the mouth of a young adult. So the question was given as a young adult who is having a painful vesicles, and there is some facial pain as well. So vesicles and facial pain, and a Zhang smear is showing multinucleated giant cells. So where do you find this multinucleated giant cells? See, we see multinucleated giant cells in infections, right? So which kind of infections do we find them? Yes, Kuldeep says that this is going to be D. Midlife is also saying it is D. Yes, correct. So I agree with all of you. So this is going to be seen in herpes simplex virus infections. Now, there was also a mention of inclusion bodies, because we know that there can be Cowdery type, isn't it? Cowdery type A inclusion bodies can also be seen in HSV infections. So here Imran says that the same question came in FMG. Yeah, for the last FMG exam also, you got a question on multinucleated giant cells. The answer was again HSV. So this has been repeated in that exam as well. So now let's see the next one. Now this one I don't know, because some of the students they told me that there was a mention about a bluish discoloration, but ultimately what I understand is an image was given, or there was a mention that there was a persistent pigmentation in the oral mucosa. And not just that, this is having a history of 6 months, and all the symptoms is getting worsened when the patient is taking a spicy food.
So symptoms worsening on spicy food, some burning sensations happening, and this lesion is present for more than 6 months now. So what it should be? Was it mentioned that it is a bluish discoloration, or was it just mentioned that there was okay, so here it can be a drug. Okay, Kuldeep says that yes. Okay, understood. So this can be a drug induced lichen planus, right? Lichen planus. But here, this question, I would believe that this is a bit tricky. Okay, image was given. Okay, understood. Thank you so much for confirming. So image was given. I'll just note it so that when we give you the actual recall booklet, we'll add the images as well. Okay, no mention of bluish color. So this thing is controversial. And here, if it is a drug-induced lichen planus, when you look into the options like ciprofloxacin, beta blockers, fluconazole, and lithium, here we can easily rule out fluconazole and ciprofloxacin. However, drug-induced lichen planus is reported with both beta blockers as well as lithium. So was there anything else mentioned which could have been more favor? Otherwise, what we have to do is, okay, Javed says that the bliss somewhat looks like a Wickham striae. Image was there, but discoloration was bluish. I understood. So that is it. But here, when it comes to between beta blockers versus lithium, I would say that beta blockers should be a better answer because that is much more common than having uh, oral lichen planus due to a drug-induced reaction with lithium. Okay, so that would be the right one. Image only, but only the bluish discoloration. Thank you, Aniket, all of you for responding. So that is about this question. Again, it can be a case of a drug-induced lichen planus. So now let's see another one. Now this question as well, I would like to get all of your inputs because this is what I have formulated the question based on the recall. 20-year-old patient has a stable hypopigmented patch. It's a stable patch on the trunk which is present since birth. Wood's lamp examination shows accentuated whiteness and diascopy does not alter the color. What is the most likely diagnosis? Okay, since childhood it was given. Yeah, Wood's lamp showed no findings. But most of the times in our group, many of you mentioned that there was a whitish fluorescence from the Wood's lamp. Okay, it was since childhood asymptomatic patient. Okay, chalo, let's see the options now. Vitiligo, nevus depigmentosus, nevus anemicus, indeterminate leprosy. So from all these options, I can easily rule out indeterminate leprosy because there is no mention of any sensory deficit. There is no mention of any nerve involvement, even the age, isn't it? So we can rule it out very easily. Now we are left with three. And in all these things, where do you find some changes in diascopy? Because here diascopy does not alter the color is written. So in nevus anemicus, there would be blanching because this is going to be a capillary defect, correct? So we can rule out nevus anemicus as well. Now we are left with vitiligo and nevus depigmentosus. Now, yes, sir, Wood's lamp was given. So okay, so some of you saying that diascopies was not given, some of you saying that Wood's lamp was given. If Wood's lamp was given, this Wood's lamp examination can show a whitish fluorescence with both these conditions, that it can be seen with vitiligo as well, it can be seen with nevus depigmentosus as well. So that is going to be pretty more challenging now, isn't it? But based on the age, if it is mentioning that it is present since birth or since childhood, then you know that vitiligo is an autoimmune disease. And autoimmune disease usually presents, female fertile 40s, right? So less likely on a 20-year-old. So here I would say that the right answer, if at all these points are given, then the most appropriate answer should be nevus depigmentosus. Yeah, since childhood agar diya hai, then it is better that we should be considering nevus depigmentosus. Since it is a pigmentary defect, there will be no change in a diascopy, and a Wood's lamp will still show a dull white fluorescence as well. Okay, dull white fluorescence as well. So now let's see the next one. So the next question again. So this time what has happened is most of the questions will be able to reach out to a diagnosis, but the actual question is actually twisting, isn't it? So let's see here. Patient presents with a swollen ankle, multiple discharging sinus, and black granules. So the first sentence itself, that is going to correlate to a mycetoma triad, isn't it? That is going to correlate to a mycetoma triad. And whenever we see that there are macroscopic black granules that is being discharged, that is more likely to be, is it going to be a eumycetoma, ya fir actinomycetoma? Because eumycetoma is going to be fungal and actinomycetoma is going to be bacterial, right? So these black granules is going to again be in favor of eumycetoma, which is going to be a fungal etiology. So now tell me, what do you find here? Arthrospore, slender, yeast, septate hyphae. So no diascopy was given. So no, that diascopy wala thing that we have already completed. So that was in the previous one. So yes. So here we'll be able to see a dematicious fungus, right? So that is about so that is about eumycetoma. And the next one is another image. So can you please confirm if the images were given? The images were given for this question because a patient who had an indurated plaque on the cheek with central atrophy. Chest X-ray reveals apical calcification. Which of the following test is most appropriate to confirm the diagnosis? So in dermatology, whenever we see that there is a single plaque lesion that is present, especially rather than central atrophy, we will be able to see a central scarring usually. Same image, same options. Super. Okay, that is good. So this image is again going to be the same. Good. So if you're getting an image like this, then what could be the diagnosis here? The diagnosis here should be a lupus vulgaris, right? Because in lupus vulgaris, what do you get? There will be a long-standing history and it would be a disfiguring lesion because wolf-like Chuan skin, right? So all those things can be seen and the central scarring can also be seen. Now, how do you diagnose? The diagnosis is usually going to be because with a biopsy. But there is no biopsy that is given in the MCQ. So here in the MCQ, the options were Mantoux test. Again, we cannot take it for a confirmatory diagnosis of the lupus vulgaris. Slit skin smear. This is usually done in Mycobacterium leprae, isn't it? PCR and a probe test. So after biopsy, the next best answer here should be a PCR. Should be a PCR. So Kuldeep, yes. So this is going to be the right answer here. Okay. So these are the questions that I could gather from dermatology recall. And there was also, I guess, a question on phrynoderma, which I'm sure that our next faculty, Dr. Sharad Balaji sir, will also be covering it. And if there is anything else which we have not discussed, which has come, so please feel free to share it. Yes, Kuldeep, that is going to be PCR itself. So without wasting any more time, thank you so much for responding and I wish you all the very best for amazing results. And over to Sharad Balaji sir for pediatrics recall now. Thank you so much.
Okay. Shall I start? So as far as pediatrics is concerned, it is not that much difficult. They are all relatively straightforward questions. So going to my question number 1. So let me open the chat box. Okay, right. So shall I proceed? So to start with the pediatrics question number 1. A child presents with neurodegeneration. A child presents with neurodegeneration and a cherry red spot on fundus examination Enzyme assay shows hexosaminidase A deficiency. What is the most likely deficiency? So this is relatively a straightforward question. So is that question framework correct? If at all, you please tell me. So as far as this question is concerned, almost all lysosomal storage disorders are associated with the neurodegeneration as well as cherry red spot. The only neurodegenerative disorder among all that is frequently asked in question is absence of cherry red spot in case of Gaucher's disease. So Gaucher's disease is literally ruled out in this case. Okay, Gaucher's relate is not deficiency, which product accumulation. So you tell me what is the product that is accumulated. Choices you tell me. Okay. Third option was sphingomyelinase. Okay. So can you tell me the question framework then, so that I can help you to get the answer. So as far as this framework is concerned, GM1 gangliosidosis is associated with the beta galactosidase deficiency. And the major manifestation of beta galactosidase deficiency, apart from neurodegeneration and cherry red spot, it is beta galactosidase and it is not hexosaminidase, so it is literally ruled out. The second one is GM2 gangliosidosis can be either due to hexosaminidase A or hexosaminidase A and B. Hexosaminidase A deficiency is basically Tay-Sachs disease, which is associated with cherry red spot, whereas hexosaminidase A and B deficiency is associated with the Sandoff deficiency, which has also got cherry red spot, but it is hexosaminidase A and B. Whereas Niemann-Pick disease, A and B is associated with the sphingomyelinase deficiency, whereas C is associated with the cholesterol defect, cholesterol export defect, but the majority of them are associated with cherry red spot. Gaucher's disease is due to beta glucosidase deficiency. There is no cherry red spot. So as far as this question frame and the stem is concerned, the answer is GM2 gangliosidosis, particularly Tay-Sachs disease. If liver and spleen is given, it can be Sandoff disease. In liver and spleen is not there, then it can be due to Tay-Sachs disease, because Tay-Sachs disease will not be associated with will not be associated with hepatosplenomegaly, right? So going to question number 2, an HIV positive mother with a viral load of 1200 copies per ml delivers a full-term baby. What is the most appropriate antiretroviral prophylaxis for this newborn? So as far as the clue here is, HIV copies of more than 1200 copies per ml. So what is a high risk mother? There is a high risk and low risk. For low risk, we will give Zidovud or Nevirapine for about 6 weeks. But as far as high risk is concerned, we will give both Zidovudin and Nevirapine for about 6 weeks, sometimes up to 12 weeks. But we need to give dual therapy. What is the indication for dual therapy in prophylaxis? The indication for, so I would like to know the choices here. The best choice is, okay, the best choice is, what is that? 12 weeks. So the best choice is Nevirapine and Zidovudin for, it is not 6 weeks, it is basically 12 weeks. Okay, right. So what is that? What are all the high risk cases? The high risk cases are basically, 1 second. Okay, so what are all the best options here? So this is basically a high risk case. The high risk case means, look here, mother took ART for less than 4 weeks, RNA copies of more than 1000, and look here, the mother developed HIV during peripartal period, postpartum pregnancy, breastfeeding. So this is a high risk cases. To be very frank, the treatment of choice is Nevirapine plus Zidovudin for about 12 weeks. But I don't find the correct option for here. But as far as the option that is given, we can go for Nevirapine plus Zidovudin for 6 weeks. But the best answer is Nevirapine and Zidovudin for about 12 weeks. For about 12 weeks. So would like to know what is the correct options that are given. Would like to know what is the correct option is the given. Correct answer will be nevirapine plus zidovudin for about 12 weeks, not 6 weeks. Since this comes under high risk, you need to give dual therapy for about 12 weeks. Next one. So this is a direct question indeed. So complementary feeding is initiated in a 7-month-old child using the Katori method. What is the recommended amount and frequency of feeds in 24 hours? The answer is quite straightforward. So up to 6 months, it is basically exclusive breastfeeding. But after 6 months, what is the frequency that we give? That we give is half to 1 Katori 6 times a day. But basically total feed is 6 times a day. Between 6 to 8 months, it is half to 1 Katori, and after 8 to 10 months, 6 to 8 months, it is half to 1 Katori, whereas after 8 to up to 8 months, it is 1 to 1.5 Katori, and it becomes 6 times a day, rather than it becomes 7 to 8 times a day. As far as this question is concerned, it is half to 1 Katori. So, but dual drug therapy should be there. So for this question, half to 1 Katori 6 times per day. So it is a direct question from infant and young child complementary feeding practices. Next question. So this is somewhat a tricky question if this is not given. But the question is very straightforward, since they had added L-iduronate sulfatase. So the answer is very simple. A child with a developmental delay and coarse facial features is found to have L-alpha iduronate deficiency. Which of the following substance accumulate in this condition? Remember one thing very clearly. Whenever you have an increase in dermatan sulfate, I repeat, whenever you have an increase in dermatan sulfate, it is directly proportional to the skeletal manifestations. More and more accumulations lead to skeletal manifestations. That's why dermatan sulfate is more getting accumulated in Marotier lami. Whereas, what is the role of this heparin sulfate? More and more heparin sulfate means it is basically mental retardation. So more heparin sulfate means mental retardation. More dermatan sulfate means it is basically a skeletal issue. Since the question had added L-iduronate deficiency, you all know that we are dealing with a case of Hunter syndrome. We are dealing with a case of Hunter syndrome. In Hunter syndrome, among all those 5 points, coarse facial features, mental retardation, corneal opacity, skeletal issues, as well as your hepatosplenomegaly will be present. Since the question is straightforward, since it includes L-iduronate deficiency, it comes under Hurler syndrome, and the diagnosis and the accumulated products will be dermatan sulfate and heparin sulfate. So the answer will be C. Okay. Corneal clouding was also given, means it is heparin sulfate. The question is straightforward. Wherever you have dermatan sulfate, skeletal issues will be there. Wherever you have heparin sulfate, you have mental retardation. Both are common in Hurler syndrome. Right. Only dermatan sulfate, only in case of Marotier lami disease. Chondroitin sulfate in case of Marcuse disease, but it is not given here. So the answer will be both dermatan and heparin sulfate. And going to the next question, a 5-year-old child with chronic kidney disease with the bowing of legs, calcium is 9, along with that serum phosphate is very high, vitamin D 25OH-T3 is low, alkaline phosphate is low. What is the next step in management? To be very frank, if it is a case of chronic renal failure, I repeat, if it is a case of chronic renal failure, then apart from oral calcium and vitamin D, dietary restriction of phosphorus as well as phosphorus binders will be there. So I would like to know what is the correct framing of question. Even though we give oral calcium and not vitamin D directly, it is not vitamin D, that is 25OH3. So what we give is activated 125OH-D3, that is called 1-alpha calcidiol. Okay, how can you give phosphorus when phosphorus is already getting accumulated? So based on the options that are given, C can be more than B. I repeat, oral calcium and vitamin D, but definitely phosphorus binders should be given in this case. So I would like to know whether the answer options are correct. Phosphorus binders are must in this case. Okay then, but sometimes we use growth hormone therapy in CKD cases. Growth hormone therapy is there. So I would like to know the correct options. Yes, we use growth hormone therapy. One indication for growth hormone therapy apart from growth hormone deficiency is chronic kidney disease. Among this, all should be given, but appropriately when you compare to A, B and D, C can be a good choice provided the choices are correct. You give calcium, you give activated vitamin D, that is called 1-alpha calcidiol, you give phosphate binder, and also you give growth hormone. All are correct. All are correct. Okay, so that's why I would like to know the correct framework of questions. I would like to know the correct framework of questions. Okay, right, but all are included in a CKD therapy. Then, so this is a straightforward question and a picture-based question. Whenever you have a neonatal respiratory distress and scaphoid abdomen, unless otherwise proved, you are dealing with a case of defect in the pleuroperitoneal membrane, otherwise called as congenital diaphragmatic hernia. That's why your abdominal contents will go into the thoracic cavity. What will be the manifestation of congenital pulmonary airway malformation? You will see grape-like clusters in one lung and you are pushing the mediastinum to the other side. That will be the manifestation of the CPAM. What is congenital lobar emphysema? And again, congenital lobar emphysema is mainly due to an emphysematous lung involving the left upper lobe and pushing the mediastinum to the opposite side. Both congenital lobar emphysema and CCAM will look like and will push the mediastinum to the opposite side. Neonatal pneumonia, either it can involve alveolar opacities involving a single lobe or multiple lobes. This question is a straightforward and I hope the question had included a defect in the pleuroperitoneal membrane. Next. This is also a straightforward question. A tall adolescent boy with a lens subluxation, a long limb and arachnodactyly. So what we call it as, what is this? Marfanoid habitus. Marfanoid habitus is present in men 2B syndrome, Marfan syndrome, as well as in homocystinuria. Right, in homocystinuria, you have mental retardation along with the stroke, whereas Marfan syndrome is classically characterized by lens subluxation, arachnodactyly, long limbs. So probably we are dealing with a case of fibrillin 1 gene, whereas collagen type 1 gene defect leading to osteogenesis imperfecta or brittle bone disease, whereas elastin gene defect leading to what? Williams syndrome, along with a happy smile in their face. Dystrophin gene is a straightforward question leading to Duchenne muscular dystrophy. This question is also a straightforward one. Next question. A child suddenly develops severe coughing and respiratory distress after accidental ingestion of a peanut, aspiration of a peanut. What is the first line of management? So I would like to know whether the child is less than 1 year or more than 1 year. That is very, very important. In the questions that we received, it did not mention any thing regarding the age. So Dugu says the age of the child is 2 years. So less than 1 year, more than 1 year. For that back slap and chest compression for children less than 1 year, whereas abdominal thrust for children more than 1 year. And this is again a straightforward question. So if 2 years is given, then abdominal thrust is the answer of choice. That is Himmlich's maneuver. Next question. A pedigree shows a mitochondrial pattern of inheritance. Affected individual shows external ophthalmoplegia, pigmentary retinopathy, and cardiac conduction defects. Remember, what is that? Mitochondrial inheritance is notorious to produce multi-system involvement. That's why we will call it as a mixture of almost all many systems are involved. So what we call it as illegitimate association. That is association of different organs with different severity. What we call it as illegitimate association. So here there is an association of eye. There is an association of your external muscles, and there is an association of heart. Your mitochondrial induction is prone to produce hypertrophic cardiomyopathy, as well as they are prone to produce arrhythmias. So Duchenne muscular dystrophy is an X-linked and which usually do not involve your external muscles. Okay, so you will not get that external ophthalmoplegia. So here this basically fits into Chiari syndrome. Friedreich ataxia is characterized by spinocerebellar degeneration, dorsal column degeneration, as well as corticospinal cord degeneration. It is characterized by a multiple units of trinucleotide repeat that involves GAA. And your myotonic dystrophy, again characterized by involvement of 19q, and it is characterized by CTG repeat. Myotonic dystrophy is the characteristic feature of distal limb stiffness rather than proximal limb stiffness, and it also involves multiple systems. It can produce cardiac conduction defects, but pigmentary retinopathy and external ophthalmoplegia is less common in myotonic dystrophy. Right. Next question. A 2-year-old child presents with generalized seizure following a high-grade fever. What is the first line of seizure in active febrile status? I would like to know what are all the options given. The options that are given that we have are diazepam, valproate, fosphenytoin, and 2 antibiotics. I don't know whether these are all the real things that were asked or given. So to be very frank, when seizure lasting for more than 5 minutes, whatever might be the cause, whether it is a febrile seizure or afebrile seizure, when any infant is brought to your casualty or room, invariably first 3 drugs can be tried. One is IV diazepam 0.2 to 3 mg per kg. Second one is IV lorazepam 0.1 mg per kg. Third option is IV midazolam, again 0.1 mg per kg. These 3 drugs, whatever is available, can be given. But as far as midazolam is concerned, you can give as IM, you can give as intranasal spray also, as well as you can give IV. Whereas diazepam, instead of 0.2 to 3.5 mg per kg, can be used in the rectal diazepam. So among the options, so benzodiazepines are the treatment of choice in any child with a febrile seizure, first treatment of choice. Here only diazepam is given, so probably the answer will be diazepam. Whereas the second choice, if diazepam doesn't work, go for fosphenytoin. If fosphenytoin doesn't work, you need to go for valproate, and then if doesn't work, then you go for levetiracetam, and you can go for next phenobarbital, then IV midazolam infusion. The last bet is thiopentone propofol. If it doesn't work, then ketamine and anesthesia can be given. Finally, vagal nerve stimulation. All things can be tried. But as far as this question is concerned, either IV diazepam or rectal diazepam, IV bar, IM bar, intranasal midazolam, and or IV lorazepam. All 3 drugs can be used. Okay, right. A 6-month-old child. So this is a very, very easy question. Recurrent infections and failure to thrive. Lab test shows adenosine deaminase deficiency. So what is the most probable diagnosis? It's very easy. It is severe form of, that is, you have 2 types of SCID. One is X-linked SCID. Another is autosomal recessive SCID. X-linked SCID is associated with interleukin 7, interleukin 2 deficiency, whereas autosomal recessive SCID is associated with the ADA deficiency. So it is associated with the phenotype. Your T minus will be there, T cells will be affected, B cells will be affected, and NK cells will be affected, and it is the most severe form of SCID. And remember, hypogammaglobulinemia usually associated with the Bruton gene. Dyejar syndrome, you all know that it is associated with the chromosome deletion Q. And catch-22, what we call it as Wittgert-Aldrich syndrome, is both the T and B cell deficiency along with the eczema and microthrombocytopenia. So among this option, severe combined deficiency will be the correct answer. So with this and with regard to one question on phrynoderma, I would like to know what are all the options, because vitamin A deficiency can come, zinc deficiency can come. These are all old things, but the most recent concept is deficiency of essential fatty acids. I would like to know what are all the options given in that particular question. That is typical phrynoderma involving toad-like skin involving your elbow and knee. I would like to know the answer options given in that. I would like to know what are all the options. So don't worry, you will be getting good marks, right? Again, we will come up with correct answers if it is wrong here. So with the good stem of questions and good options. Okay. So all the best for your examination. Thank you.
Thank you, Sharad sir. And bachon, this is the last session, last recall, that is Ophthal. Now, Ophthal, we did not have too many questions. And out of the few questions that we had, all were not very straightforward either. And जो really expected topics हैं, उसमें से questions नहीं थे. जो questions आए हैं, like out of the 6 or 7, we are going to, this is our last session. This is the last one. I know that you people are really tired. So we'll just quickly go through the Ophthal. No discussion, just the question and the probable answer. So I'll just look at this question. I think this is what had come. You had two pictures. And the question probably was that which components of binocular vision do these pictures represent? Something like that. Right? It is something like this, that the first picture is showing something like this. There is like a house and there is a dog, and one eye is seeing the house, the other eye sees the dog, and when you keep both your eyes open, you see that dog inside the house. Right? So this is called as simultaneous macular perception. This is simultaneous macular perception. And the next picture is, see, with the right eye, you see the rabbit. And in the left eye, you are seeing the rabbit which has a flower in the hand. And together you fuse them and you see this complete picture. Right? I hope that this was the question. And they had asked what are the components of binocular vision. So the first one, this is simultaneous macular perception, and the second one is fusion. These are the first two grades of binocular vision. जो third grade है, that is stereopsis or depth perception. उसका picture ये नहीं है. तो अगर ये दोनों pictures थे, then the answer is simultaneous macular perception and fusion. I hope this is the answer. बाकी options में something else would have been given. They would have mixed up stereopsis with the options. Lekin stereopsis is the third grade. That is not these two pictures. Yeah, so if this is the image, then this is the answer. Simultaneous macular perception, that is picture number 1. So this picture number 1 is simultaneous macular perception. Second picture is fusion. Okay, this was a difficult question. So you do not have to really blame yourself if you've got this wrong. I would say that many students would have got this wrong, and the examination is relative. So don't get disheartened. This one is like a P by Q. I don't know exactly question क्या था, लेकिन image तो यही था. It probably would have said that an elderly patient has like dandruff-like scales at the pupillary margin, ring on the anterior capsule. So this ring that we see, this is called as the PXF ring. And they may have mentioned subluxation of lens, or they may have mentioned the increased intraocular pressure. Right? Was this what, did they give something else? Did they say lens subluxation or increased intraocular pressure also? Was it there? Subluxation of lens or increased intraocular pressure? Yeah. There was no mention of all these things. Okay. So anyway, even if that is not mentioned, this image is enough for us to come to the diagnosis. It's an elderly patient with this kind of a ring on the anterior capsule of the lens. It is PXF syndrome or pseudo-exfoliation syndrome. This is like a PYT. So I think this most of you would have got right. And this is like a regular question. This is kind of a regular question. Right? Next one. Next one is also, it is not exactly a very straightforward question, but this is something which has been asked a couple of years back in the FMG paper. Probably it said something like this, that there's an elderly patient who has presented to us with hazy cornea, and on examination there are bullae on the cornea suggestive of bullous keratopathy in that particular eye. So bullous keratopathy is suggestive, what is generally suggestive of endothelial decompensation. It means that the endothelium is not working properly. Now, why the endothelium is not working properly? The clue to that is given by the examination of the other eye. And the question probably said that in the other eye, there are guttate lesions. Guttate lesions means there are areas of endothelial dropouts, or they may have mentioned endothelial dusting. Endothelial dusting. Something like this was mentioned. So bullous keratopathy in one eye, which is suggestive of endothelial decompensation, and guttate lesions or endothelial dusting in the other eye. So this is suggestive of Fuchs endothelial dystrophy. Fuchs endothelial dystrophy. Fuchs endothelial dystrophy was there in the options, I believe. Yes, so Fuchs dystrophy was there in the option, so that is the answer. Acha, previous question में increased intraocular pressure was also mentioned. Yeah, that makes it a little easier. Okay, so ये question भी बिल्कुल direct नहीं है, but it is a kind of a PYT. It is bullous keratopathy in one eye, suggestive of endothelial decompensation, and the cause of endothelial decompensation being looked at the other eye by the guttate lesions. Right, next one. Next is like this says that it's a child, like a child, maybe a 15-year-old girl or a 10-year-old girl. There is a mass which is close to the lateral canthus. It is a painless mass, non-tender mass. It is slowly increasing in size. Now, because it says that it is a child, it is painless and it is gradually increasing in size, and probably the question would have also said that it has been present for a long time. It has been present for a long time. Did it mention that it has been present for a long time? So see, the key things that in the question are that the patient is a child, the lesion is close to the lateral canthus, it is increasing in size but very, very slowly, and it has been present for a very long period of time. Yeah, so the answer to this is a dermoid cyst. If this was the image and this is what the question was like, then the answer to this is dermoid cyst. Gradual increase in size, yeah. यही था? This was the image. Yeah. So I think most of you agree that this was the image and fairly this was the question. Then the answer to this is dermoid cyst. Actually, in ophthal, like there is not like too much of DD. It is either this or this. So that's why the other options do not really matter that much. क्योंकि उसको confuse होने लायक कुछ नहीं था. Chalo, next one. Next one is a PYT. It's a PYQ, I would say. The image that is shown below is used in the management of which condition? So see, this is a question which has been asked before in the INI-CET paper, I think. So you see this intracorneal ring segment, that is ICRS or INTAX. And intracorneal ring segments are used in the management of keratoconus. So was this the image and was keratoconus there in the option? Yes, it was there in the option. So यही answer है. So it is the if Yeah, so this is an image of ICRS or intracorneal ring segments, and keratoconus is the answer. Now, this again, like a slightly orbital cellulitis is a regularly asked topic, but the question you can answer the question more by elimination. So see, I think these were the options that were there, that which of the following statements is true about orbital cellulitis, that ethmoidal sinusitis is a cause, topical antibiotics and steroids is the treatment, it presents with proptosis but with normal ocular movements, and it is limited by the orbital septum. Something on these lines would have been the options. Now see here, if we look at option B, topical antibiotics and steroids is not the treatment. The treatment is systemic antibiotics. You have to give systemic antibiotics. It presents with proptosis, that much is correct, but ocular movements will not be normal. Ocular movements will be limited in a case of orbital cellulitis. And orbital cellulitis is not limited by the orbital septum. It goes posterior to the orbital septum, and that's why it is orbital cellulitis. If it is limited by the orbital septum or it is anterior to the orbital cellulitis, we will call it as a preseptal cellulitis. So all this is wrong. So that's why ethmoidal sinusitis is the common cause, or is a common etiology. Something on these lines would have been there in the options, and that is the correct option. I don't know whether you would have been able to answer the question directly, like if you kind of rule out the other options, we can come to the correct options. It is the common cause for all ages, tha kya? Yeah, it's a common cause for all ages. See, because the others are not the option, not correct. That's why this has to be correct. It is something like that. The treatment is systemic. It cannot be topical antibiotics. Obviously, the ocular movements are going to be limited, and it is not anterior to the orbital septum. It is posterior to the orbital septum. So these options are obviously wrong. So that's why ethmoidal is the common cause. Now, these are the questions from Ophthal. As I told you, not exactly the expected topics. हम विजुअल पाथवे, रेटिना, ये कॉर्नियल अल्सर्स, ये सब एक्सपेक्ट करते हैं. ग्लास प्रिस्क्रिप्शंस. They have not given the questions from our usual topics in ophthalmology, and I would say that exactly not the straightforward questions, except for a couple out of the 6. 2 were really straightforward, ye pseudo exfoliation wala and this intax wala. The other 4 were like kind of, I would say, not exactly the kind of question we would have expected. But still, see, the exam is relative. Ab ye jo hai, stress lena band karo. You have stayed up so late after such a difficult day. You have managed to survive through this grueling year. Now, please take it easy for a few days and wait for the results and hope for the best. It really doesn't help. अभी बैठ के इतने wrong हुए, इतने right हुए, ये cut off होगा, वो cut off होगा, सोच के कुछ नहीं होने वाला है. So that's why there is, give yourself some rest. Give yourself give your mind a little time to unwind. And take a break from this for some time. That's what I would say. So with that, we kind of finish our recall. So over to Dr. Ranjit to just sum it up all.
Thank you, ma'am. Thank you very much. Hey guys, how are you doing? I've seen lots of corrects and I see few familiar names as well. Hi to Lit in Blue, how are you? Javed, INA number is coming. Definitely give it up, and don't worry. Like every teacher now said, you've done your hard work, and I'm sure the results will be good, and I hope it will be good as well. And let's wind up here. And you have spent a long day, and I'm sure that from tomorrow onwards, you might not know what to exactly do, right? That's also a different feel. And enjoy. Go watch a movie. If you have something to catch up with friends, do that. Definitely the Goa trip will be pending, right? Go and do that, right? Enjoy. And this time, fortunately, NBS said that the results date also will be announced in around the first week of September. Hopefully, it's on time. And it's I and B. We never know what happens, right? So all the best, guys. If you are attempting for the first time, this is just a trial. Continue reading. If you are aiming for INI, continue reading. If you feel that this is what I need is what for me for. Take rest is completely fine. Let's see what happens after the results. So thank you everyone for staying awake and staying live and giving us contributions in the terms of options for so long. Thanks the entire students who help us with the question recall. Thanks to the team which has been working tirelessly behind it, Dr. Hara, Dr. Anto, Dr. Mamu. Thanks to the operations team, right from Raman, right, Kanchan, Aditya from the studio team, and all the faculties here, and especially students. You deserve a big round of applause. You've done it, and hopefully we'll see you on the other side. Thanks a lot, and very, very happy night and a good night. See you. Thanks, Aditya.